Good morning, distinguished guests, ladies and gentlemen. We just finished our pre-Congress meeting yesterday, and we will have another 1.5 days meeting since now. And I am Dr. Jian Wei, the Superintendent of Chengxin General Hospital in Taipei. First of all, I would like to thank again for joining us today at the Taipei VAV Summit 2020. On the global impact of the COVID-19 pandemic, this year's meeting will go digital. We believe that with the help of newly developed digital technology, people can communicate with each other face-to-face without gathering together at a certain destination. Through the online presentation and timely interactions with the world, experts can communicate to the solutions of valvular heart disease. I hope that everybody will benefit from the remaining 1.5 days meeting. Topics to be addressed include aortic root surgery, specifically the TAVR operation, surgery for Barlow's disease, interventions for tricuspid mitral and the pulmonary valve diseases, TAVR for bicuspid aortic stenosis, TAVR in young and low-risk patient, and the TAVR for the patient with pure aortic regurgitation. This year, experts from 13 countries and areas, including New Zealand, South Korea, Vietnam, mainland China, France, Australia, Denmark, Singapore, Japan, Hong Kong, USA, Canada, Switzerland, Israel, and Taiwan, across different time zones will join us. Hopefully, we will create a dialogue and consensus to improve the patient care in our daily practice. Finally, we're looking forward to a wonderful and fruitful meeting. Next, I would like to say some words in Mandarin Chinese to our Chinese friends in China. 我是台北振兴院的院长魏征，欢迎各位来参加这次的会议。我们昨天已经开了一天的会，但是后面还有1天半的会议呢。这个欢迎大家来参与这一次的台北 VAV Summit 2020。由于最近这个新冠肺炎的关系，所以我们这次的会议改采这个线上首播直播的方式进行。那首先要感谢过去大家一起来支持我们这次的会议。那在这个今天的会前会里面呢，我们昨天的会前会里面，我们在 Meet Expert 已经有各国不同的专家发表了各种不同设计的这种瓣膜手术那么诸位假如还有兴趣的话，还可以回头再看昨天的这个节目那么这中间包含到很多的案例分享那么还有就是这个演讲者呢，我们来自于13个国家，包含到纽西兰、韩国、越南、中国大陆、澳洲、新加坡、以色列、香港、美国、加拿大、瑞士、丹麦以及台湾等这些的国家以及地区在这些专家在线上都参与了一些很热烈的讨论，欢迎各位呢有空再去看我们直播。那后面这1天半呢，我希望我们这次会议能够圆满成功那么finally, I would like to ask Jian Ye, Professor Jian Ye, our co-chairman, also our most important sponsor for this meeting, to say some words to us. 叶健教授要讲几句话吗？今天是另外一个 opening， 正式的 opening。Yeah.
Thanks. I just want to say thanks to Professor Wei and Professor Yin and all the meeting organization committee so quickly to put this meeting together as a virtual meeting, and I'm pretty sure there's a lot of work behind that. And yesterday we had a great day with all the case presentation discussion. It was a very, very fruitful discussion. I learned a lot. It was a great format of the meeting. And today, I think we're, as the Professor Wei mentioned, today we're going to have all the lectures from all the world-renowned speakers, presenters And the topic is really covered all the valve area, including like a TAVIs, mitral valve, tricuspid valve, even surgical, like a David procedure. I think well, I'm really looking forward to Dr. David procedure, who's joining cardiac surgery, and I think will give a lots of information to the audience. I'm really looking forward to listen to all the presenters. So I think this year, even that we cannot get together in the same room, but we are still very closely connected through the other computers, the internet. I think this is a great opportunity for us to share our experience and the knowledge together and learn each other. And I wish everyone had enjoyed the meeting and a good time. Thanks.
Now let's proceed to the first session. The first topic will be presented by Dr. Jian Ye. Okay, so I would let me make a very brief introduction to Jian Ye. He graduated from Wenzhou Medical College in China and went to Canada for so many years, and he had done a lot of works and also the researches in the field of cardiac surgery. He's especially interested in the complex mitral valve repair and the minimally invasive transcatheter heart valve surgery and aortic surgery, also off-pump coronary bypass. He is now the clinical professor of the surgery and also the director of research at the division of cardiovascular surgery, University of British Columbia, Vancouver, Canada. He has recently done a lot of work in the transcatheter valve implantation for the aortic valve for the TAVI. Also many innovations. So his topic he's going to talk is about the management of aortic stenosis, current evidence, and my update to guidelines. Let's welcome Dr. Jian Ye.
Thank you, Professor Wei, for your nice introduction. So can you see my screen?
Yes, yes.
Okay, perfect. So I'm going to give a very brief talk about the management of aortic stenosis because it's a 15 minutes, so I cannot cover all the areas. But as you know, for the previous many years, I always say the good things about the TAVI. But today I will reverse a little bit. I was mainly focused on my concern on the TAVI based on the current evidence. So this is my disclosure. And as everybody knows, aortic valve disease etiology is basically congenital valve disease. That's including like a unicuspid, bicuspid, functional bicuspid, or quadricuspid aortic valve, and acquired valve disease that's most common in the Asia Pacific, probably is rheumaticus, and in the North America is the most is the calcified, and other things like endocarditis. Seems like a recent years increase, and other pathology, of course, the aortic regurgitation. So the first aortic valve replacement was performed in 1960, and since then, this aortic valve replacement has becoming the standard procedure for all the valve pathologists. And also many prosthetic valves develop, including mechanical valves, stent valves, or stentless valve, a homograft. So up to 2014, the AHA and the ACC guideline, the only standard treatment is the aortic valve replacement. It's a surgical valve replacement. So the guidelines are pretty simple. So aortic stenosis usually is management and diagnosis and management are pretty simple previously because only one treatment, surgical aortic valve replacement for all the pathology. So over the past decade, and transcatheter aortic valve implantation has been significantly advanced, and many valves have been developed, as you see here. And so this has changed all the the management of aortic disease over the past 10 years. And many clinical trials have been quickly completed. And also very surprisingly, the transcatheter has been approved so quickly between like 2011 and 2016. So for the high risk, prohibitive risk, and the intermediate risk. So 3 years later, the guidelines, the 2017, the AHA-ACC focused the update to the 2014 guideline. And you can see that, in 2014, the aortic valve replacement, that's only the treatment for the aortic stenosis. It's 3 years later, and you can see the TAVI now becomes as a sort of a standard for the prohibitive surgical risk patient, and also the alternative treatment for high and low risk or intermediate risk patient. So the 3 years later, the guidelines significantly changed. And European guidelines the same. So they basically, for the other intermediate and high risk patient, basically either surgical aortic valve replacement or TAVI. That's in 2017. So that means that only really left the group of patients for this open heart surgery is a low risk patient. So what happened in the 2019? So the low risk patient trial with either balloon expandable sapien valve or evolute low risk trial that have been 1 year result is out and reported, and of course showed there's non-inferior to the surgical aortic valve replacement. I just want to say that evolute the low risk trial, they reported 2 years result, but actually is probably is a 1 year result because the median follow-up was really only 12.2 months. So this is basically 1 year outcome of all 2 low risk trial, and it confirmed the TAVI is non-inferior to the surgical valve. So in the same year, FDA has approved a TAVI for low risk patient. So that means there's not really a patient left for the open heart surgery because the TAVI now approved for the low, intermediate, and high risk, basically all the patient. So now this year, as a reported 2 years follow-up of partner 3 trial in low risk patient. And as you see the graph, and also show the non-inferior to the surgical aortic valve replacement at a 2 years follow-up. And if you separated the endpoints by death, stroke, and rehospitalization, as you see here at the 2 years, there's no really different in death, stroke between the TAVI and the surgical arm. Only difference is rehospitalization. So the 2 years outcome already, and the 1 year and 2 years outcome already show TAVI is non-inferior to the surgical valve in low risk at 2 years. So my questions is current evidence really robust enough for use of TAVI in low risk patient? I think that's a real question. So now we can carefully look at all the trial, particularly the partner 3 trial, because the 2 years data, the result is reported. So look at this. This trial is the patient basic consent for the trial, but 1/3 consent patient was excluded from the study. The main exclusion actually due to the anatomic reason. So that's the things I think need to pay attention on that. And you can see the exclusion criteria, major exclusion criteria is one bicuspid valve, that's everybody know. But other things that you can see this severe calcification in the LVOT or annulus, and also the complex coronary disease, and the low EF, and the renal insufficient. These are as excluded from the study. So this is a really high selected patient in the trial. So many patients is excluded from the study. So this, I think, I need to be careful to look at the exclusion criteria in each randomized trial. I think that's very critical. And then you look at the age. This trial suppose in every patient who's older than 18 years old, they are candidate for this trial. But at the end, you can see that majority of patients enrolled in the study are greater than 70 years old. You can see 75.7% patient are more than 70 years old. And also the average age is 74. And it's look at it, it's a really less than 65 years old patient. It's really only like 6 to 7%. So that's a really, really low portion of the young patient in this clinical trial. So, and then look at this, the slide. So I just put this together. That's the incidence of endpoints from year to year 2. So basically the second years, during the second years, and you can see the preliminary outcome is a much higher, is almost 100% high compared to surgical. It's double. And death also doubled, and the stroke is way high in the TAVI group. And another thing is valve thrombosis is also 3 times high compared to the surgical arm. So these are we have to look at it carefully in this details. If you look at the overall, the endpoints at 2 years, there's no different, or rehospitalization is actually better in the TAVI arm. But if you separate it into the year 1 or year 2, there's a significant change in the year 2 compared to the year 1. And these are the detailed numbers about the stroke event and death and hospitalization. As you see there, in the year 2, stroke event and see in the 6 patients in the TAVI arm, only 1 patient in the surgical arm. That's in the year 2. And the deaths as 7 versus 3 in the year 2. And the rehospitalization is no change, basically similar between the two groups. So this is, I think, is quite a significant difference from year 1's data. And another thing is the thrombosis. This is really concerning because generally speaking, for the bioprosthesis valve, as a high risk of thrombosis is usually during the first 3 to 6 months. After that, the risk is pretty low. But in this study, particularly in the TAVI group, and the thrombosis is 2.6%. That's really high, and also surprise, for bioprosthesis valve. So this in the year 2. But there's a real question in the further follow-up in the year 3 or year 4, is this will be continued situation, or this is just happened in the year 2? But generally speaking, because as we know, I already mentioned, the usual thrombosis happen in the earlier stage, not in later stage. But in the TAVI, actually, even the later 2 years, still have a high thrombosis. As I mentioned yesterday, I think there's a high risk of thrombosis, not because it's the tissue valve itself per se, but I think the main issue is because it's a TAVI, when we implant the transcatheter valve, we don't remove the calcified valve. That's why it's significant change the flow pattern in the aortic root. That's probably the main reason. That's why cause flow like stasis and high risk of thrombosis in the TAVI group. If that's the reason, is the main reason, this probably won't change during the later follow-up. So I expect that this thrombosis probably will be somewhat continue during the later follow-up, unless we started more aggressive anticoagulation. But that's still unknown. But this is really concerning. So now we look at the partner 2 trial, the 5 years data, and the same in the early years, the primary endpoints is death and disabling stroke is high in the surgical group compared to the TAVI group. However, this curve is across. You can see the cross at the 3 years. And now is a death and a disabled stroke, because it increases in TAVI group compared to the increase faster compared to the surgical group. So this two line will be separated more during the further follow-up. We don't know, but there's a trend. This seems like this two curves separated after the 3 years. So this is I think the similar pattern to the 2 years of follow-up in the low risk patient, and you can look at it separated into the stroke and the death, or the rehospitalization, or the reintervention. As you see there, the first is a rehospitalization. Initially, same is high in the surgical valve compared to TAVI in the early years. But at the 2 years, this line also crossed at the 2 years, and then continued separation to the five years. So this will be further separation. We don't know, but this will be data will tell. And another thing is the reintervention, and you can see the 3.2 versus 0.6. This is a quite a significant difference at the 5 years. In the TAVI, it's 3.2. In the surgical valve, only 0.6%. So I think that this is a sort of alarming, like a warning sign. And other things I want to mention is the mild platelet valve leak is not really improving over the time. And you can see on this figure, you can see at the year about 3 years, and it seems like a mild platelet valve leak. Seems like there's some effect on the survival. Also, the p-value is not really significant, but it's close. So whether this two curve will be a continuous separation beyond the 5 years, we don't know. But that's also is a little bit a warning sign. So these are the 5 years result from partner 2 child intermediate patient. Seems like there's a pattern in the median patient. There's 3 years. There's something that crossed the lines are crossed. In the partner 3 child, seems like so the 2 lines already, the 2 curve already pretty close. There's a line really close now at the 2 years. Whether in the 3 years or 4 years this will be crossed like the partner 2 child, we don't know. We'll see what's later follow-up data. And other things, the common concerns is the incidence of pacemaker, particularly with self-expanding valve. I think, of course, this is debatable. Some people, the high implanted, the pacemaker rate is very low. But based on the trials, this is a number still 2-digit. It's not low. So pacemaker, I don't think is a major issue in the elder patient, but I think is a major concern in the young and healthy patient. Because the pacemaker down the road, like for the 10 years later, they usually have quite a complications, either infections, leads fractures, malfunctions, and need reimplantation, lead extraction. Our center is a big lead extraction. We are doing a lot of leads extraction. So this is not the small things for the pacemaker in the young patient. So this question is the current evidence robust enough for use of a TAVI in low-risk patient? My current answer is no, unfortunately, based on these results. I don't think it is ready to extend the use of TAVI in most low-risk patients with aortic stenosis. But people will say, why you care about the durability? Why you care about the valve failure? We can do the valve in valve. If TAVI failed, we can put another valve. Yes, I think the answer yes or no. Such as this patient, we did this patient in 2008 transapical. I think I implanted this 23 valve sapien, and 10 years later, this valve has become a stenosis, and then we put another valve 23. Excellent outcomes. Patient very good, so no problem. But however, in the same year, we have another patient where we implanted 23 sapien valve transfemorally, and 10 years later, also 10 years later, and this valve becomes stenotic. So we look at this angiogram and the CT. You can see the right coronary artery is extremely high risk for occlusion with put another valve in. So this really is cause a problem to do another valve in. So this patient is basically, we don't have really transcatheter option, and probably need some sort of a more innovative procedure to fix these problems. So that's why not every patient can have a repeated TAVI. And also there's some studies show the survival benefit of mechanical valve versus a bioprosthetic valve, particularly in the patient younger than 60 years old. So we don't want to forget this, because the mechanical valve in the young patients still have a benefit. So this is my 2020 update to guideline. So any symptoms way is, I think I need to separate. The first need to separate is bicuspid valve or tricuspid valve. I didn't have time to present the bicuspid valve TAVI result because it's a time limit. So, but regardless of the current report, there's lots of report on bicuspid valve, but all the early outcomes, I don't think it's really compatible with the surgical outcomes in the bicuspid aortic valve. So I think it's very important to separate into these two, and then you consider age. I think for the bicuspid valve over 80, I think regardless of the risk, I think TAVI is a good choice. But if the low intermediate risk, I think a surgery should be the first choice in this group patient. And child leaflet's age, I think my opinion is every age high risk should be a TAVI, and greater than 75 probably TAVI, and the 6 to 675, I think it should be a shared decision, the patient and the physician, make a decision which is the best for the patient. And it's less than 65, I think a surgery is still probably is a better choice at this point. So now that the management of aortic stenosis becoming more complex compared to the 10 years ago, you can see that the mechanical valve, tissue valve, transcatheter, and what the best for this. So there's many factors we should consider. One is the anatomical related factors. I listed a lot. I'm not going to say all the listers, but you have to consider the anatomical factors, and you should consider the resource-related factors, and also the patient-related factors, and other things, disease-related factors, and other disease. Even you need to look at the device-related factor, because in some center you are not available, not every type of valve available. Which valve is best for this anatomy? If not available, I think a surgery should be considered. So I think these factors should be all considered during the decision making, particularly in the medium patient and the relatively young patient. So I think final slides, I think because it's more complex in terms of diagnosis and management of aortic stenosis. So therefore, it's very important to achieve for patient-centered care and shared decision making. In order to achieve this, I think a physician or surgeon who talk to the patient must know the advantage and disadvantage of each option, not just the TAVI, not just the surgical valve. I think should know both, and then you talk to patient to inform them, and they can be completely informed, and they will make the decision. And also a very young patient, don't forget the mechanical valve. I think that's still the reasonable option. And lastly, I think we have to respect the patient's preference and wish. Thank you.
Okay, thank you, Dr. Jian Ye. So because we have plenty of time for discussion afterwards, so we will proceed to the next topic. That will be presented by Dr. Vinnie Bapat. Well, Vinnie Bapat is our old friend, and he came from a family physician and received his medical degree from CHGH Jeng Wei Medical School and King Edward's 7th Memorial Hospital in Mumbai, where he completed his resident training in general surgery and cardiothoracic surgery. Afterwards, he was appointed in Guy's and St. Thomas Hospital in London as attending. At that hospital, they have the highest volume of dissection surgery in the UK. He also he led the minimally invasive aortic valve replacement program and pioneered the use of a sutureless valve at that hospital. afterwards, recently, he has, several years ago, he established the anterior right thoracotomy approach for the aortic valve replacement in the UK. Working at the forefront of the TAVR program at Guy's and St. Thomas Hospital, he also developed the app for the valve and the valve surgery, and that app has already been used worldwide. So actually, he had been in Taiwan to teach us to do the valve and valve surgery several years ago, and actually our program is also, we are grateful to his help. And well, the topic is recently he was appointed as by the New York Presbyterian Hospital Medical Center. Well, I graduated from and I obtained that doctor of medical science degree in 1982. Okay, so also, you know, it's my pleasure to know that he's now appointed by the New York Presbyterian Hospital. Well, the topic he's going to talk is the surgical valve replacement in the current era. So let's welcome Dr. Vinnie Bapat.
Can you see me?
Yes,
for some reason, my computer has decided not to allow me sharing the screen. So if you just give me 1 minute, I'm logging in from my other computer, and I'll be there in just 1 minute.
Sure,
Apologies for that. So just give me 1 second. This computer should hopefully log in.
Well, take your time.
I think this is a talk which is a great segue to Professor Jian Ye's talk. And I think he summarized it really nicely in terms of whether the low-risk TAVR is suitable or not in majority of the countries. And every country is going to be different. United States, of course, works on principle of FDA approval. And because of the FDA approval, once you get the FDA approval, patients can choose to have TAVR. So my talk is going to be, where are we in terms of surgery now? Whether, you know, surgery is going to be suitable in all patients, some patients, and hopefully you will see me in another screen in a second. So please allow me to switch over. I'm going to from there.
Well, you just take your time, and maybe
thank you very much for the patience.
Maybe Dr. Jian Ye, can you answer the question for you? The question is, do you have any experience to explain the TAVR valve for any reason? Can you say some words for this? I can answer this question.
Yes, the slides is on. Should I answer later?
Okay. Well, so Dr. Bapat, now
I just wanted to confirm if you can hear me.
Okay. So Dr. Jian Ye, are you still will be on the line, right? So we will discuss on this topic later. Okay, thank you. So Dr. Bapat, please.
Thank you very much. So I'll start from the first. So as we definitely saw that transcatheter valve definitely has a big impact on the management of TAVR, aortic stenosis. But the most important thing is what this slide shows is there are many types of devices which are currently available. And as you know that some of the devices such as device D, which is center, has been withdrawn. And similarly, direct flow has been withdrawn, and so has been Engager and few others. So the advantage of TAVR, of course, is less invasive and short hospital stay, which is extremely attractive to all the patients. In my mind, when I look at TAVR and SAVR, the main difference is you excise the leaflets and you implant a valve under vision in surgery. And in TAVR, you keep the leaflets and you implant the valve under radiology. Now, the main difference in these two hence is surgical valve tends to maintain the geometry very well, while the TAVR device, the geometry of the TAVR device is finally determined by native anatomy. And that becomes very important when we think about durability and long-term outcomes. Early challenges for TAVR, for sure, we had problems like embolization, sizing issue, vascular complications, stroke and PV leak, which again, Jian Ye has emphasized very clearly that these are important issues. High pacemaker rate depends on the type of device and annular ruptures. But slowly and surely, in last 10 years, we have seen that TAVR has grown into maturity, procedure has become simplified, and patients can be discharged nearly next day. And in fact, in New York now, some patients are discharged on the same day as well. We have got cerebral protection. We have got better understanding of CT sizing. And I think the risk of annular rupture has really gone down because we have got multiple device choices. The evidence for TAVR is building very rapidly. You can see the evidence in terms of randomized trials. And you can also see large evidence built earlier in SOURCE registry in Europe, as well as TVT registry, which is in United States. And this has one thing for sure, is this has consistently demonstrated good early result, and in some cases, even intermediate result. So there have been a lot of trials, and we talk about these trials. So you can see that, again, PARTNER 3 and EVOLUTE-R have been randomized trials. NOTION, again, is a randomized trial for all comers. And then most importantly, I think UK TAVI registry, which is a real world practice in United Kingdom. And essentially, I'm not going to go through these tables, but essentially to show you that in patients who are either less than 70 years or more than 70 years with low STS risk, surgery is equivalent to TAVR. And in some cases, actually, TAVR is better than surgery in early results, such as in PARTNER 3. So what becomes important is that informed, again, the decision of the patient and the shared discussion, as again, Jian Ye emphasized, becomes very critical. But more importantly, the patients in the trial are very selective. And again, I would say that 33%, but maybe even more are. So who are not included in the trial? Patients, obviously, who have aortic regurgitation, bicuspid valve, unsuitable anatomy in terms of alveolar calcification or low coronary artery, patients who have severe peripheral vascular disease. This becomes very important because when we are interpreting the data of TAVI, it's very important to understand that these are for transfemoral cases only. That means if you have a low-risk patient who needs an alternate access, maybe actually surgery is a better option in those patients. Patients whose syntax score is high and has got complex coronary artery disease, again, the balance shifts towards surgery, and patients with severe LV dysfunction. And as you know, that these patients were excluded from the low-risk trial. Again, I'm going to emphasize again that the results of PARTNER 3 do not apply to all the other devices. And that's very important because many times what happens is you can by subconsciously pick up a good result from PARTNER 3 for stroke and pacemaker, and then have a better result from another trial, another device for vascular complication. But when you talk to the patient, I think you have to be device specific as well, and especially for devices which have not yet been approved for low risk at all. So who are the poor candidates? In Colombia, we luckily see the patient together. We discuss the CAT scan together. We look at the echo together. So we look at few things now. Who are the candidates in which we are going to get poor result with TAVR? So of course, patients with LVOT calcification, either you are going to get paravalvular leak or annular rupture, patients who can have coronary obstruction risk, and the patients such as heavily calcified raphe or bicuspid valves. Another very important thing in bicuspid valve is also ascending aortic disease. If patients have ascending aorta, which is larger than 4.5 centimeters, we rediscuss this patient whether we should do surgery or TAVR, irrespective of the risk of the patient. And the most important and critical part is patient-prosthesis mismatch. And this becomes important not just for TAVR, but also for SAVR as well. Let's show some examples of these patients. This is an extreme example of a patient who has got severe, LVOT calcification. The center, however, chose to, perform TAVR. As you can see very easily, there's a lot of PV leak there, and we had to explant this valve after a few days, and you can obviously see why. This is one of my patients who is 90 years old, relatively fit 90-year-old, beautifully tricuspid valve, absolutely suitable for TAVR. But if you look at the leaflets and the calcification pattern in short axis or long axis, you can see that the nodules of this calcium would have definitely obstructed the right coronary artery as well as would have injured the aorta. So this patient underwent open surgery. He took some time to be discharged, but at least he is alive and safe. Bicuspid disease can be very different. This is the patient where we have excised the bicuspid valve just to show you that in bicuspid, sometimes coronary artery arises from commissure, and it's very important that the coronary obstruction risk is evaluated separately in bicuspid valve. So again, bicuspid valve is a relative contraindication in these patients. What about a patient like this? 25% of the patients have ascending aorta, which is dilated. This, for example, is one patient where this is an evolutar size 34, and you can see that the ascending aorta is massive. There is definitely risk of rupture. There is definitely risk of aortic dissection in this patient. So in my opinion, this patient should have undergone surgical valve and ascending aortic replacement rather than TAVR. This is the second patient is extremely interesting. She's quite a big lady with a large BMI. She's the one with even a 23S3. You can see that we cannot use 26 evolutar here because very narrow sinuses. Doing a TAVR in this patient is going to give you very good early result, but she's going to have PPM. And this patient, in fact, came back after 6 months and underwent a root replacement with a freestyle root for PPM. So very important is not just to suicide anatomy, but also to focus on concomitant disease. I see nowadays that even patients with mitral disease, we feel that, let's treat aortic stenosis and the mitral regurgitation is going to disappear. I think this is where a good heart team discussion is critical. And what I have seen in Colombia, that we are matured slowly and surely into making right decisions, that functional MR might go down in a high-risk patient, but a degenerative MR is never going to go down, and it's better that patient has bivalve disease rather than just TAVR. So I think it's very important that TAVR is not cure for everything, and we have to make right decisions in these patients. Younger patient is a bigger challenge. And I think the main challenge is because we still question the durability of the TAVR devices. We still question need for new pacemaker. And again, we have to try and understand what is the real role of mechanical valve. And the reason I'm saying mechanical valve is not because of the valve itself, but the role of anticoagulation. And this is what I'm going to slightly bring up in the conversation later. So first of all, when you say younger patients, we are going to see more bicuspid disease. Is valve thrombosis, which again, Professor Ye mentioned, that is going to be a critical issue, and durability as well. As you know, that bicuspid valves and bicuspid valves are different. Like if you have type 0 is different, if you have type 1 is different. So again, we are really careful in Colombia when we say bicuspid valve, and I completely agree with Jian Ye that currently we use TAVR only for high-risk patients in bicuspid valves, and that too in select anatomy. I think we still need to understand a lot more about sizing, geometry, the role of coronary obstruction and PVL as well in these patients. Valve thrombosis has been a major issue in all the devices, mainly in TAVR devices of certain kind, but even seen in surgical valves. We still don't know what the implications are going to be. But one thing for sure is, if we are going to put the patient on anticoagulation for this, then might as well do a mechanical valve so that patient can just have lifetime single surgery. So I think as we get more knowledgeable about this issue, I think the treatment algorithm is going to change slowly. So why do we worry about durability? The main reason for durability, and I can see Professor V for sure will know this because it's his generation who really drove the valve science, is that stiffer the stent, there is less deflection and more stress on the leaflet. And although, manufacturers will always say that there is never any problem, this has been, demonstrated for more than 5 decades now. Further, thinner leaflets can have more stress points. So again, we are going to learn a lot about stress and the asymmetry of the TAVR device and see how the durability is going to be. So this is something we have learned from surgery. And this graph, as you know, Toronto SPV valve was brilliant for 6-7 years and then just drove down completely in terms of durability so that it's not even implanted now. So I think we are going to see a lot of this in TAVR devices, but we just have to wait for longer duration to simplify. What about valve area? In 5 years, at least in partner 1 and B, we have seen that there's a reasonable consistency, that it is maintained. And more importantly, in Notion trial, I think we have got the longest follow-up now. And Professor Søndergaard, who will give a talk, I think, later today, can probably highlight on this issue that there has been no inferiority in TAVR devices at 5 years. So clinical decision making, this is a chart from Professor Mack. As you can see, again, insisting that between 50 to 70, we need to make a shared decision. And I think what I'm saying shared decision is it's not up to just cardiologists to say, I'm not going to do TAVR. But I think it's important for surgeon to also maintain the integrity and say, can actually surgical valve give good result? And that's very important. So let's look at this particular subgroup. Patient is between 50 and 70. We call them young patients. But those are the patients who we expect to live long. And why do I say that? Is because of all these factors which we have already discussed. Now, the main concern is, in my opinion, why do we define age as a boundary between bioprosthetic valve and mechanical valve? And the reason for that is to avoid second intervention. That means patient is below certain age, I do one operation and then that's it. Patient is above certain, and when I trained in London initially, it was 70 years old, and now it may be 65 years old. So the main goal for this age cutoff is avoid reoperation and avoid anticoagulation. Now that's very, very important. So we don't want both of them in these young patients. So let's define young and who is old. So in my opinion, the definition is based on life expectancy and durability of the valve. So a patient who lives longer than the valve is young for that valve. A patient, a valve lives longer than the patient, we can define that patient as old. So I think age cutoff is not a very good science, in my opinion. I think it's very important that every patient, in our experience, we assess the life expectancy and then decide, whether I'm going to do a tissue valve or a mechanical valve. That is the first thing. And this is very, very important. So let's look at TAVR, in these patients, say a very fit patient between 50 to 70. Let's assume that TAVR is going to last for 8 to 10 years. That also means that reintervention is going to be common. That means this patient is going to definitely live longer than the valve. And we think that the new generation valves are magic, but they are not, because they are actually crimped further down. So maybe actually they will not last longer than the older valves, which were not crimped heavily. So this is the best case scenario, I think. Means in bicuspids and all, we are going to get just worst cases, and as I've shown. So what are the other options? When these patients come back, what are we going to do? Can we do a TAVR in TAVR? I think, again, Jian Ye showed an example that in some patients, maybe you can. But what about explanting a TAVR and doing a SAVR? That may be actually a very smart option. So maybe this is what we need to do and learn. And if we do TAVR in TAVR, there's going to be, my concern is that the risk of thrombosis is going to be higher because the amount of metal which is in the aortic root is going to be very high. You've got 2 stents, the leaflets are going to be crowded there, and there's going to be higher rate of thrombosis and a need for anticoagulation. And again, I bring your attention back. If we're going to anticoagulate these patients, why not just do a mechanical valve, and then that's so be it. And again, if we do explant in these patients, how easy that is going to be. And again, patients are going to be 10 years older to undergo open surgery. So we have been actually collecting data now from all over the world about TAVR explants. And as you know, that there are some important considerations. There could be damage to ascending aorta. There could be damage to annulus. There could be damage to mitral leaflet, because while explanting, you can cause damage to the mitral and conduction tissue. So I think we are going to learn a lot about this from the explant registry, which is going to be presented at TCT as well as London Valve later this year. But I can tell you something, that it's not that easy, but it may not be that difficult either in future. My biggest question as a surgeon is that, sure, surgery can be done, but then we need to plan surgery properly. We just can't say SAVR is better than TAVR, and then in a 60-year-old implant a bioprosthetic valve, which doesn't last for 10 years. We keep saying, surgical valves last for 15 years. That's not very true. We also need to define that we have to make sure that we don't have PPM issues. So that means we are going to, if there is a small valve, we are going to do root enlargement or root replacement. And then we have to definitely, discuss with the patient the associated increased risk for the procedure. So I think this is very, very important. I think we have got 3 device options, which are, you can see. And the sutureless valve, of course, becomes very important in terms of hemodynamics. This is something we have published in a scientific journal, how using, for example, in TUTI, streamlines the blood flow and increases the LVOT area into a circular area and increases the flow or stroke volume by around 13% to 20%. So I think we need better solutions if we are going to promote surgery in these younger patients. We can't just simply say, I'm going to use a tissue valve and that's going to work very, very beautifully. So I think, again, less invasive options are going to be more attractive to patients as we offer them in Colombia to all the patients. These are some of the examples which I'm sure you all practice as well. So the final thought is surgery should still be the first choice if it's an unsuitable anatomy. There's no confusion in my mind about that. But this will change with durability. And I think if you have a patient with an ideal anatomy, that becomes more important. If I feel that if, doing a TAVR, the chance of second intervention is higher, then maybe we should just do SAVR. That means, patients who are living up to maybe 8 to 15 years. But if you're going to do a surgical valve and patient's going to outlive that valve and you're going to implant a small surgical valve, then that's a bad option, because we know very well that valve in small surgical valves don't work very well. So I think, to summarize finally, surgery definitely has a role, more than we think today, but I think a mature heart team discussion is extremely critical. Thank you very much.
Thank you, Dr. Bapat. Well, I think since you talked about the current the options for the surgeons to choose what kind of the therapeutic modalities for the patient with aortic stenosis, I think it's quite important for the modern surgeons to know. Okay, so afterwards we will just after all the speakers talk, and then we will have the discussion. Well, the next 3 topics will be chaired by Dr. Wei-Hsian. Dr. Wei-Hsian he graduated from National Defense Medical Center, and he received his internal medical training and cardiology training at Veteran General Hospital, and afterwards he moved to our hospital as the chief of cardiology for many years, and he is very skillful in doing the coronary interventions, and also he contributed a lot in our program, the TAVR program. So, so the next 3 topics will be chaired by him. Please, Dr. Yin.
Thank you, Professor Wei. Dear good friends from overseas, although this is a virtual meeting, I think every one of you enjoyed. And the next talk will be delivered by Dr. Kentaro Hayashida. Kentaro is also our old friend. He attends this meeting every year and contributes a lot. I think small anatomy is of no doubt a challenge both for surgeons and implanters. of TAVI. So I think in dealing with small anatomy, you should have some tips and tricks or thinking. And I think Japanese lady and the gentleman are small, and with this kind of anatomy, very often I've been proctor there, and I experienced this. I do have experience on this. So I think Kentaro can share us his experience very well. Let's welcome Dr. Kentaro Hayashida. Please, your microphone, please. Kentaro?
Okay, can you hear me?
Yes, now. Okay,
okay.
We can see your
slides. Thank you so much.
Yeah.
Thank you very much for your kind invitation and introduction. So today I'm going to talk about TAVR in patients with small anatomies and heavily calcified valves. Okay. And I'd like to present some cases. This is the case 1. 80 years old female. She had a very small statue, like 147 centimeter, and the body weight is 38 kilogram. Body surface area is 1.2. Typical very small Japanese lady. She developed severe aortic stenosis with mean pressure gradient 85. And she also has a reduced kidney disease. And this is echocardiography. She has very small LV left ventricle and ejection fraction of 54. And if you look at the CT scan, she had really small, less like the 295, that is smaller than 300. She also has a small sinus of Saba, like 25. And we could also see the severe calcification. And the coronary height is the 12 for RCA and 11 for LCA. And either femoral axis should be okay. Left side is a little bit smaller, but the right side should be okay. And the 80 years old female, independent, very severe aortic stenosis with mean pressure gradient 85, and the body surface area 1.2, and STS 2.6%, low risk patient. And the choice of treatment is the TAVI or surgical AVR. And finally, we chose TAVI. And after predilatation with the 16 millimeter balloon, we deployed AViV R23 millimeter valve and with the control pacing, because we found the not good expansion of the valve. We performed post-dilatation, and finally the mean pressure gradient was 15 with mild PPL. And if you look at the hemodynamic, before procedure, she has the 0.2 of index AVA, but it increased to the 0.85. And 1 year later, it increased to the 0.96. And the AR was decreased to trace. And we could treat this kind of patient with the self-expanding device as well. And this is a case 2, 88 years old female. She also has very small statue, like 145 centimeter, and the body surface area is 1.2. And she also had the CKD, and the mean pressure gradient was 87. And STS was calculated as 10. This is also the echocardiography, and hopefully it worked. And size of the left ventricle in 37 over 24, and very severe aortic stenosis with mean pressure gradient 87. like this. You can see the very hypertrophic LV with narrow LV cavity. And if you look at the aortic annulus, the size of aortic annulus at 252, that is very small. And the sinus of Sava is also 25. And finally, we chose Sapien 320 millimeter valve with 0.5 cc under filling under local anesthesia. Like this. And the post-dilatation was performed with the same contrast volume with the library system. And the final PVL was trivial, and we didn't see AV block. And this is the postoperative TTE. If you look at the mean pressure gradient, it decreased to 11, and the peak flow velocity was also decreased to 2.2 with the trivial AR. And we didn't see no alveolar obstruction in the discharge at day 4. And if you think about the prosthesis-patient mismatch, this is the definition. The effective orifice area of the implanted prosthesis too small in relation to the patient body size, resulting in abnormally high postoperative gradient. And if the this ratio, index COA, was smaller than 0.65, it defined as severe PPM. And if you look at the data from the surgical AVR, the total incidence of PPM 44%, and mainly due to moderate PPM. And this study included the many patients. And if we look at the breakdown, a severe PPM matters, especially in the patient with reduced ejection fraction. So we need to be careful. And if you look at the data from the TAVR registry, and if you look at the data from the Dr. Pivaro, and the TAVR did better in terms of the hemodynamic performance in the patient with small annulus. And if you look at the data from TBT registry, and the severe PPM was noted in 12%, and the severe PPM impacts the late mortality. That is also very important in TAVR era. And this choice extent registry demonstrated that the balloon expandable valve demonstrated the higher incidence of the moderate and severe PPM compared to MViV R and Puro, presumably due to intra-annular position of the valve. And if you look at the data from our Ocean TAVR registry, and 20 millimeters Sapien 3 device was used in 8.5% of the patient. And if you look at the data about MViV R, 23 millimeter was used in 10% in our cohort. And this is the hemodynamic performance of the 20 millimeter Sapien 3. Even with the small annulus, the 20 millimeter Sapien 3 did a good job, like the index effect AVA like 1.3 or 1.2. And this is the data from our registry that the severe PPM was noted only in 0.7% in a cohort. It's totally different from the what we saw from the TBT registry or registry. Maybe presumably due to the small body size of the of our cohort. And this is the Ocean SHD family. And I also would like to present the third case. This case has a small anatomy, small sinus of Saba, as well as heavy calcification. And here is some LVOT calcification. And she also has the low right coronary artery. Because this is our early experience in 2014, we proceed to TAVR. And nowadays, if we had this patient, we don't do the TAVR anymore. And because of the high risk patients, so we protected the right coronary artery. And this is the old XT device. We deploy the valve a little bit lower to secure right coronary artery with the protection with balloon. But we saw the coronary obstruction, and we performed balloon dilatation, but it didn't work. And finally, we needed to deploy the 2 stent to secure the good minimal lumen area. But after that, we also found perforation of the sinus of Bapat here. That means even at the 1 TAVR procedure, we observed the 2 complications. So I think the heavy calcified leaflets and the small sinus of Bapat, this combination is quite dangerous, so we need to be careful. And if we shift to the topic to the heavily calcified aortic valve, this case has a really heavy calcification like this. And we were a little worried about to perform TAVR with balloon expandable valve. And finally, we chose the lotus valve like this. This is a classic lotus valve. And like this. And it took a really long time to lock the valve. And finally, we made it. And this case was supported by the Dr. Didier Chiche in 2015. And this case also has the 3 LVOT calciums. And because the patient was too old, like 89 years old, to receive surgical AVR, we performed the TAVR as well with lotus valve. And finally, the result is like this. This is the echo, and we can find only mild PVR here. So Lotus did a really good job in this case. So in conclusion, ladies and gentlemen, not only annular size, but also patient body size should be taken into account to avoid PPM, especially severe PPM. So we should be careful with combination of the heavily calcified valve and small sinus of Bapat. And optimal device selection is important to avoid complications. So thank you very much for your attention.
Thank you, Dr. Kentaro Hayashida. We will have a discussion at the end of the session. So let's move to the next talk, which will be delivered by D.W. Park. Dr. Park is also a renowned interventionist worldwide. He's currently the director of the CAS lab at the Assam Medical Center. And he is also the program director and the co-director of TCT AP, AViV, and the compressed PCI. So he contributed a lot in the field of coronary intervention and also the valve intervention. So I think he's the best person to present this topic, TAVR in patients with coronary disease. Let's welcome Professor Park.
Okay, thank you, Professor Wei, and thank you, Dr. Yin. And can you hear me? My sound?
Sure. Yeah.
Okay, so I'm very happy, and definitely I'm really very glad to present my the study in the Taipei 2020 meeting and in this unprecedented chaotic COVID-19 situation. So today my topic is about the TAVR in the patient with concomitant coronary artery disease. This is my disclosure. So, and coronary artery disease and severe aortic stenosis definitely had common soil of a degenerative disease, and many patients has two diseases simultaneously. The reason why the aortic valve disease and coronary artery disease had common risk factors and also share the same pathophysiology. The severe AS has advanced coronary artery disease owing to such background, the history. So I'm gonna start my presentation. This is our representative case, an 82-year female presented with dyspnea functional class 4. She had multiple risk factor hypertension, diabetic, CKD. Nearly 10 years ago, she underwent PCI at the mid-AD approx RCA. And 10 years ago, she had moderate AS, now progression to severe AS. And the creatinine, eGFR 37, and the coronary renal disease, chest X-ray shows severe pulmonary edema, acutely compensated heart failure, and echo shows low flow, low gradient, severe AS, ejection fraction 30%, STS score is high, 11.9. And looking at chest X-ray, and we see the severe edema. So, and looking at the patient coronary angiographically, previous proximal RCA stent was patent, mid-AD stent was patent. However, she had also very tight, significant proximal disease. Also, she had diffuse 56% suck disease, and the 2 bacillary disease remained. How do we treat? The coronary artery management strategy, and CAD, we do CAD revascularization, yes or no? If you consider revascularization strategy, TAVR and PCI versus SAVR and Taipei surgery, if we PCI plan, timing matter 1 stage or 2 stage. So it's current issue on TAVR and coronary artery disease, and there are many debatable issues. Frequency of concomitant severe AS, CAD is well known. However, impact of coronary artery disease in outcome in TAVR recipient is still debatable. Also debatable point is CAD management, PCI is required. Can PCI be performed safely with severe AS? Timing issue, aggressive revascularization PCI better than conservative OMT, still unknown. If you're gonna choose PCI, the drug-eluting stent versus bare metal stent choice is also issue. So this slide is a very well-known slide, and the TAVR recipient concomitant coronary artery disease is very high. Approximately half of patient has a concomitant significant coronary artery disease. This is also shown in the chain of a randomized clinical trial. It's a high risk pattern 1B, 2 intermediate, is more than half of patients, so coronary artery disease. Low risk trial pattern 3, low risk relatively low proportion, 20 and 30%. Also coronary revascularization pattern in chain of RCT, pattern 2, so TAVI, pattern 3, low risk trial, SAVR plus bypass surgery, much higher than TAVR plus PCI. Overall proportion decrease going to the low risk population. Impact of coronary artery disease outcome, SAVR or TAVR, and the data reported consistently coronary artery disease negatively influence outcome in SAVR patient. This is already well known. However, data on influence coronary artery disease in outcome in TAVR patient still conflicting, owing to different sample size, different baseline criteria, and different AS severity and different coronary artery disease. This is a well-known slide. In SAVR patient, the degree or the high status of coronary artery disease is also well associated with the higher instance of mortality. But in TAVR recipient, impact of coronary artery disease, this is observational study, meta-analysis, there is no impact in the mortality in TAVR patient. This is a contradictory finding to the SAVR. But if you're gonna clarify the stratified status of complex of coronary artery disease, and the low syntax score is no difference at all, but high syntax score can influence of the hard endpoint death stroke MI, even in TAVR recipient. So at this point, we should think about the pure treatment effect, TAVR as well as coronary artery revascularization. partner 1B trial, landmark trial, looking at the mortality issue, TAVR definitely better than the conservative treatment, nearly 50% mortality reduction. However, the pure treatment effect revascularization in terms of PCI compared to medical treatment, 0% mortality reduction. We should think about the pure treatment effect in patient CVS requiring TAVR as well as coronary artery revascularization. Recently, PCI in fragile elderly patient with ischemia concept. Ischemia trial is the most updated college trial. PCI versus OMT, there's no difference. Primary composite endpoint as well as all-cause mortality, nearly same up to 5 years. So in patients with coronary artery disease, we can expect revascularization was better than medical treatment if patient ischemic myocardial burden more than 10%. So, and looking at the current guideline, TAVR and CAD still, and this is 2017 European. Looking at guideline, the combined PCI TAVR feasible, but they require more data, and the intervention should be individualized depending on the clinical condition, extent of CAD, myocardial at risk. But this guideline recommend the PCI can be done in the primary indication TAVR with the coronary diameter stenosis more than 70% in proximal segment. This is class 2A, but unfortunately, level of evidence is C. So coronary artery disease in the US guideline, similar, and the US guideline more emphasize diagnosis rather than treatment. The screening of CHGH required before cardiac surgery due to high negative predictive value. Coronary CT angiography can be done in the low and intermediate risk, and the presence of the severe CAD might be helpful to decide surgical or transcatheter approach with the severe AS. Concomitant severe CAD is affect optimal treatment decision. So, and this guide recommend the severe multivessel CAD is maybe much better served by surgical AVR and KVG, and there is no sentence, no emphasis on PCI and the TAVR at this point. So, after review of literature research and guideline, how to treat my patient is a tight prox-LAD stenosis, intermediate and diffuse distal sub disease. So on the basis of literature review guideline, my selection is I can do coronary revascularization with PCI, revascularization strategy TAVR plus only LAD selective PCI rather than TAVR plus bypass surgery. And the remaining issue is the timing issue, 1 stage or 2 stage. You know, previous study is complete revascularization, treat all region versus incomplete revascularization, treatment of very tight region, remain intermediate region medical treatment. In TAVR patient, no difference at all, although this study was observational, but very nice result. And the timing issue, 1 stage or 2 stage, and usually same session or stage session is there is no definite study still unknown, but it may be worth to perform the both procedure during the same session to limit vascular access, resource consumption, and reduce the hospital stage. However, sometimes we require the stage the PCI, like impaired renal function, but there are many factors to decide the same session or steady session. I think the most important component is complexity of the CAD. That would be major determinant of this choice, same session or stage session. Definitely, and the 2 stage or 1 stage has a relative advantage and disadvantage. This is a well-known interventional cardiologist, but the simple answer, relatively complex region, we usually do 2 stage, PCI first, patient stabilized, and then do TAVR. And the simple, relatively simple region, we do 1 stage PCI. That was our practical recommendation on the basis of our experience. So, and my choice for this patient, TAVR plus LAD 1 spot PCI, and we do one-stage PCI. So, and the reasonable, concept in elderly TAVR patient, incomplete revascularization concept is revisited. This is in terms of reasonable incomplete revascularization. Complete revascularization, we usually do anatomic guided. However, if you're gonna do functional guided, sometimes physiology guided, you can do a much better, provide a much better treatment option for patient TAVR and coronary artery disease, and focus on proximal stenosis, supplying large myocardium on the basis of physiology guidance like left main or prox-LAD disease. And this research published a couple of weeks ago and well summarized the current updated issue and evidence for coronary artery disease management, the inpatient requiring TAVR, and published JAG, and the coronary artery disease, half of patient concomitant coronary artery disease. Future perspective, CTA is a reasonable alternative to coronary angio, FFR, IFR can be coronary access. Some problem is, benign anatomy is okay, but sometimes a very ugly, complex anatomy potential increase the difficult, as well as post-TAVR ACS and had a poor outcome. My practical thought, TAVR, CT, suspected coronary artery disease, no, just TAVR do. Suspected severe coronary artery disease, yes, we do coronary angio. After coronary angio, we just do functional angioplasty rather than anatomic angioplasty, in terms of large myocardium and the proximal disease and the disease modification. Summary, and the coronary artery disease in TAVR patient, approximately half patient TAVR candidate had concomitant coronary artery disease. Effect of the presence and severity of coronary artery disease on outcome post-TAVR still controversial, but impact of a high complexity of CAD is significant. Preliminary data reported the use of coronary CT angio functional invasive assessment is promising for a workup of a pre-TAVR, and there is no definite recommendation. How do we treat? When to treat coronary artery disease in TAVR patient? No definite data exists. The most appropriate revascularization strategy, as well as appropriate timing of PCI, that is also undetermined. The reason why we require the random trial to guide the optimal revascularization is still awaited, will be available in the coming years. My practical suggestion, last slide, given RCT are still scarce, treatment strategy should be determined on case-by-case basis with your own best experience. Simple case, you can do same stage PCI. Complex case, we recommend the elective the PCI, then TAVR procedure. And the selective incomplete revascularization seems to be reasonable in elderly TAVR patient. Definitely low-risk AS with complex CID may benefit from the SAVR plus bypass surgery rather than TAVR plus PCI. Thank you for your attention.
Thank you. Thank you very much for your comprehensive talk. Okay, let's move to the last talk of this session, which will be delivered by Professor Martin Ng from Alfred Cardiology, Royal Prince Alfred Hospital Medical Center. Dr. Ng graduated from the University of Sydney, and he is currently the head of structure heart program and the senior staff specialist in interventional cardiology, Royal Prince Alfred Hospital. He is also a professor of cardiovascular medicine and bioengineering of University of Sydney. Besides clinical work, he also spent a lot of time in research, seeking to address unmet need of the patient by developing new treatment for heart disease. And he is also a founder and the chief medical officer of Endoluminal Sciences Company. So I think he's the best person to present new TAVR devices. Let's welcome Dr. Ng.
Thank you, and I thank the organizers for inviting me to give this talk. So I'm going to give a brief summary over the next 15 minutes about new transcatheter aortic valve devices. So the devices I'm going to review are basically the new models of established platforms, both including balloon expandable valves, self-expanding valves, as well as mechanical expandable valves. And then at the end, we're going to address some novel valve platforms as well. So I think that, you know, when you look at some of the new models of established platforms, it's clear that the manufacturers are really taking on the issue of paravalvular leak. I think the two talks by the surgeons beginning at this session have addressed the long-term impact of paravalvular leak, even mild paravalvular leak, on outcomes of patients. The first talk addressed this data that I'm showing now, which is the 5-year outcomes from partner 2, showing there in the green bar here, in patients with mild paravalvular leak, that appears to be an impact on long-term outcomes that comes on after 2 years. That's a disadvantage compared to patients who have no paravalvular leak. And of course, patients with moderate severe paravalvular leak, we've known for a long time that there is a mortality disadvantage. But this, as we treat more and more patients with lower risk, paravalvular leak has become a more and more significant issue. And so, you know, the manufacturers like Edwards, in its latest iteration of a transcatheter heart valve, has tried to improve leak performance. So I'm showing here the SAPIEN 3 Ultra valve. So it's the latest iteration of the SAPIEN 3 valve. The important thing to say here is that Edwards looked at leak results for all the SAPIEN 3 range and noted that the SAPIEN 3 29 millimeter valve performs much better in terms of paravalvular leak than the smaller size valves, the 20, the 23, and the 26 millimeter valves. Its current thinking around this is that the outer skirt, the anti-leak skirt in the smaller valves is shorter relative to the 29 valve, and therefore what the Ultra, the SAPIEN 3 Ultra does is produce a 30% taller outer skirt, but uses a different material, which is textured PET. So you can see here it's a kind of furry kind of appearance with more conformability to try and reduce prosthesis annular incongruence. So you can see here on the with the SAPIEN Ultra range, there's no change to the 29 valve. The 29 valve remains the same. Importantly, you can look at the outer skirt here. The outer skirt on the smaller valves now become really a lot taller, up to 40% higher. And you can appreciate that with the 26 millimeter valve and the 23 millimeter valve, in fact, the outer skirt height in the SAPIEN 3 Ultra is now higher than that for the 29 valve. Now, the early data for the SAPIEN 3 Ultra appears to corroborate this idea that it is associated with better leak performance. So data from the SAPIEN 3 Ultra trial and the US TVT registry, small numbers suggest very high rates of patients with none to trace paravalvular leak greater than 80%, and very low rates of moderate PVL or greater. This is data up to February this year from the US TVT registry for the SAPIEN 3 Ultra patients. These are low-risk patients, showing 1.4% moderate severe PVL and a fairly low pacemaker rate. Obviously, you know, this kind of results a best-case scenario because these are low-risk patients. Now, this valve, the Accurate valve from Boston Scientific, has been around for a while. It was in Japan and in Australia 5 years ago, but then was kind of, because Boston took over Symetis, which was the startup that made this valve, its kind of availability in Southeast Asia has been variable. It's currently available in Australia, but not the rest of Southeast Asia. But I gather it's currently coming out again. It's a supraannular porcine pericardial leaflet valve. There's some unique features, including, if you look here, an upper crown in the middle of the valve that serves as elements that push down the native aortic valve leaflets to kind of enhance coronary clearance. This valve has a very low radial force, which actually favorably impacts its pacemaker rates. And the most unique thing about this valve is that unlike other current commercially available self-expanding valves, it's deployed from top down. In other words, aortic end down. So this is we showed a case yesterday, and I'm showing another case from us again. This valve is done without pacing, and it uses a cork-like sort of mechanism to fix. So you push down on the valve. So the valve is being positioned here. And once you push down, once you're in the right position, you open up the upper crown and the aortic element. So you open up from the aorta down. So top down kind of deployment, and you're pushing down on the valve the whole time, and then you rapidly deploy the ventricular end of this valve. This unique form of deployment makes this valve very easy to position and deploy, because essentially you're pushing down a prosthesis onto an obstruction and then deploying from top down. It's remarkably simple, actually, compared to a core valve or a portico. You can see in this case, we actually introduced the valve through the sheath at 324. The vessel closure was done at 328. In most of our cases, we do a transfemoral accurate faster than actually about the same time as a pop sock. The patient is then discharged at day one, and you know for the right case, the accurate valve provides a good outcome. So the strengths of this platform is because of the low annular, the low radial force, the pacemaker rates are very low. In our experience over 5 years in our institution, we haven't had a new pacemaker from this valve. Device success rates are high. And look, there was a randomized trial published recently comparing it to the SAPIEN 3 valve. And relative to the SAPIEN 3 valve, not surprisingly, for a supraannular valve, it has superior hemodynamics. However, the Achilles heel of this valve is that in the context of valvular or annular or subannular calcium, there are high rates of valve dysfunction. And this was shown in scope 1, where there was a significantly higher rate of valve dysfunction manifest by higher incidence of both mild and moderate paravalvular leak. Now, this is, I mean, early on, within the first year of our experience with this valve, we noted this kind of suboptimal leak performance in patients with moderate to severe calcification. So this is shown here is a breakout of the prevalence of leak depending on the extent of calcification. As you have more calcification in a landing zone, you get more paravalvular leak. And so in our institution, we actually only use this valve in patients with mild or non-hostile calcification on the annulus. And in that setting, the outcomes are outstanding. Now, Boston Scientific actually recognizes this, and the new version of the Accurate Neo 2 addresses this problem by extending the leak skirt higher, and I think also changing the material to make it more conformable to the annulus. I guess we'll see from further studies whether the Accurate Neo 2 addresses this Achilles heel of this system, which otherwise is very simple to use. And in Dr. Kentaro's first case of a sort of borderline low coronary height, low narrow sinus of Valsalva case, it is our device of choice for this kind of anatomy over the core valve. In terms of the Portico program, has announced that it is going to have a next generation valve called the Navitor. Like the other valves that I've shown you, a major focus on this new iteration is in PVL reduction. There is a new kind of polyethylene fabric cuff, which you can see here. It looks a little bit like a SAPIEN 3 cuff, like a wedding skirt type sort of billowing structure. There are also some changes in stent design to enhance radial force for the smaller sized valve ranges. There has also been introduction of a new FlexNav system that's already been introduced in a new Portico system. Essentially, this introduces quality of life contemporary changes for the valve delivery system that make it equivalent to a core valve delivery system, smaller size, finally a stability layer, which exists really with all self-expanding stent systems, whether they're stents or valves, to make the more accurate placement and a redesigned handle. So I think that the learning points that Abbott had from the Portico IDE trial, which randomized the Portico valve to commercial valves, we were part of that trial. You know, in the original Portico trial, without a dedicated sheath system, there were higher rates of major vascular complications. There was higher rates of permanent pacemaker rate, possibly due to inaccuracy of placement, and also higher rates of paravalvular leak compared to commercially available valves. Now, preliminary data of the FlexNav system using the Portico valve suggests that at least for the permanent pacemaker rate, this seems to be improved with a more accurate delivery system and becomes comparable to the CoreValve Evolut Pro platform. So this is really the design goals from Abbott in terms of its next generation valve succeeding on the Portico, really focusing, I think, primarily on greater spatial accuracy and also improved paravalvular leak performance. And there are currently studies undergoing for approval both in Europe and in the US and Australia. Now, this is another valve was known and available in Asia Pacific and Australia. But then in 2017, the Lotus valves were withdrawn by Boston due to a problem with the release mechanism. The Lotus Edge has recently got FDA approval in April this year, and I think we'll see reintroduction worldwide. For those who don't remember this system, this is a mechanically expanding valve where the valve frame sort of accordions down and gets locked onto the annulus. It always had this adaptive seal that provided it with one of the best leak performances of any transcatheter valve. The disadvantage of this system is high rates of pacemaker implantation, and the Lotus Edge introduced a sort of depth guard technology to reduce the depth of implant to try and mitigate the pacemaker implant rate. So the Lotus Edge, which was introduced in 2016, 2017, introduced this depth guard system to reduce depth of implant. It tried to make the locking system simpler and reduce the profile. Now, the Reprise 3 trial, which compared Lotus, the original Lotus, to CoreValve, did show advantages of this system in terms of stroke, lower rates of stroke, and lower rates of PVL. And this is a summary of the PVL outcomes in the Reprise trial, showing that the Lotus valve really has potentially class-leading kind of outcomes for leak, better than perhaps even the Sapien 3. But its real Achilles heel is very high rates of permanent pacemaker implant at around 1/3 of patients. So some data from this from the Lotus program with the depth guard technology suggests that there is improvement in pacemaker rates, with the Lotus Edge showing double-digit, still double-digit, but 12% as opposed to 1/3. So that is promising. And Boston has signaled that beyond the Lotus Edge, they will move to what the next generation, which is Lotus Mantra, which will retain the full recapturability features of this platform, but they're aiming for reduced height, reduced delivery profile, and also no need for locking assessment, which is a step that has really made the procedure a bit more complex relative to other platforms. Now, I'm going to move to talk about some novel platforms, particularly two novel platforms that may be trying to address real unmet needs in our field, which is particularly treatment of aortic regurgitation. So this is a Chinese valve called the J valve. It was introduced originally as a transapical valve, but now has a transfemoral form. It comprises 3 U-shaped anchor rings that are that actually grasp the native leaflets, and therefore, fixes uniquely by actually grasping onto aortic valve leaflets. Those rings are sewn onto a self-expanding nitinol frame, which carries bovine pericardial leaflets. It's delivered through an 18 to 22 French sheath. So this is a video here showing delivery of this J valve through a transfemoral delivery system. There had been a paper earlier on describing kind of promising results from a transapical delivery system. You can see those U-shaped rings being delivered, being oriented onto the aortic valve leaflets, and actually then there is, and then you can see that is linked by sutures to a self-expanding frame. This self-expanding valve is then expanded and coaps onto those U-shaped rings to fix onto the aortic valve leaflets. And then this valve is then released. I'm sure it's it looks much simpler than it is to do. I'm sure to orient the valve like that. But nevertheless, I think that there is potentially a place for such devices in AR. So there has been a compassionate use registry that's multi-center between Canadian and US centers led by the Vancouver group. This was presented at the recent TCT of 11 patients, all AR without significant aortic stenosis. Mean age of 72, 11 patients, and you can see that 9 of them were done transfemorally with 2 transsubclavian, majority GA procedures, fairly long procedure times compared to conventional TAVI these days. VARC acute procedural success was only in 7 out of 11 patients. In one case, there was a premature valve deployment, and the valve ended up being deployed in the aorta, and a second valve had to be deployed. There was one case of valve embolization requiring conversion to surgery, one case of high post-deployment gradient, and a final case requiring a SAPIEN 3 valve-in-valve to treat significant PVL. The 30-day clinical outcomes include 2 non-cardiac mortalities, as well as 1 non-disabling stroke and 1 pacemaker. And this is the echo outcomes, which are fairly impressive for severe AR, showing that no patient had greater than moderate AR and no patient had significant PVL at the end of 30 days. So I guess it's there was a kind of maybe reasonable rate of procedural success for an early version of this device, and more studies are planned for this system in this scenario. The final novel valve I'd like to talk about is the Jenner valve. This has been around for some time now. Many of you will know this valve. It was originally around as a transapical form. It took many years for the company to develop a transfemoral form. It has a nitinol support frame, and like the J valve, it has what this valve terms as locators, which clip onto the native valve to align the valve relative to the coronary anatomy, and therefore allow fixation not by radial force, but by clipping onto the native valve leaflets. This clipping facilitates valve alignment to the native coronary anatomy to maximize access to the coronaries and minimize depth in the LVOT. And so this is a case shown at the recent TCT of this. So the locators are being pushed down and aligned onto the aortic valve leaflets. And once they're down, you release the lower stent, and there's sort of annular sealing. And then finally, the upper stent structure is then released. And so this is a primary AR case, showing in this case an excellent kind of AR result with no residual AR. Now, the other postulated advantage of such a technique is because these valves grasp onto the native leaflets, that they may have a particular role in very low coronary height cases. And this is an example. These are 3 examples of the Jenner valve being deployed in low coronary height cases where the left main patency has been maintained in cases of very low coronary heights. So this, once again, like the J valve, this is a valve that grasps the coronary leaflets and therefore uses this novel fixation mechanism to perhaps treat AR, and perhaps has a role in low coronary heights. So in summary, the new iterations of existing valve platforms address existing problems such as paravalvular leak, reduction in new permanent pacemaker rates, as well as address the ability to address hostile and complex anatomies. And finally, with some of these novel valve platforms, we see that, by leveraging different forms of fixation, we may be ultimately address some of the other major unmet needs in TAVR, which is treatment of primary aortic incompetence. Thanks for your time.
Okay, so we still have 20 minutes for discussion. So I think there's some questions from the audience. The first one is as I mentioned before, do we have any experience to explain the TAVR valve for any reason? I think Dr. Bapat has mentioned a little bit about it, but how about Dr. Jian Ye? Do you have any much experience in this?
I think Vinnie has a more experience. He's now as doing the international sort of register for the surgery implant as a TAVI. We have some experience, but most is a pretty early experience, like an early TAVI rather than later TAVI. So in terms of explantation, I think different valve seems like a little bit different. I think the sapien a little bit relatively easier. To me, it's a relatively easier, and the longer standard valve a little bit difficult is because your aortotomy has to be pretty high rather than low because the stent is really high, particularly in the short ascending aorta. That can be quite a challenge in terms of do the procedure. I'm pretty sure early after TAVI is not that difficulty, but it's a later one. I think will be like 5-10 years later. I think it will be more difficult because the top part is probably a little scarring into the aortic wall, and you trying to the peeling off. That's probably what difficulty. But I personally I don't have experience expand as 5 years or 10 years later the valve.
So how about Dr. Bapat? Do you have any?
This is quite an interesting topic, really. So it's interesting because sapien being a smaller device, you feel that it will be easier to explant, but because it's a balloon expandable valve, what happens with that device is that it can flare a lot in the LVOT. So you have to be very careful about, you cannot just pull it out or not to try and pull it out because it will damage the conduction tissue as well as mitral. So we have designed actually two techniques. One technique is you crush the valve inside slowly, gently from all the sides, and then you keep crushing it till it becomes like an irregular crimped valve and then take it out. And that has actually worked well. The other technique, which is really simple, is you cut the stent frame in the middle somewhere, right to the bottom, and then hold it on one side and keep rolling it. Like sometimes we roll a sternal wire and it unfolds very nicely without damaging. And in fact, I got the idea from watching an Australian show where the alligators, turn around. So we call it an alligator roll. Tall devices actually are easy to explant from the annulus, which is interesting because they are 19-all frame. You can compress it. But from the ascending aorta, as Jian Ye said, you have to plan and you have to really patiently develop the plane. Once you separate it from the ascending aorta, it's very simple. And what we do is we systematically keep pushing it inside, and slowly the 19-all stent, you can explant, or you can attach 4 sutures at the top and crimp it down slowly with a sheath, and then it kind of comes in. So we are going to have larger experience with this. I suspect direct flow, which I've explanted only once, is quite difficult. A Lotus Eye, we don't have any experience at present, but I assume with so much wire frame, it might be challenging.
Thank
you.
So,
Vinnie, with the core valve, where it fixes on the ascending aorta, do you have to repair the ascending aorta?
Right. So in 30% of cases, we had to, in the registry at least, means I can tell you from 157 cases now. And that's many times because initially when we started doing these cases, we assumed we have to replace the aorta. So we didn't try and develop the layer. It's like a pseudo-endothelial layer. But now what we do is, in the last 3 cases, we have actually used an endarterectomy spatula to just create a layer and explant it. And actually it comes out very nicely. So there has been no need for removing the ascending aorta, unless of course the ascending aorta is very large. And then you have to replace it anyway.
Thank you. I think in the future the surgeons may have to. We will encounter more like this kind of a patient, and in the future the surgeons must know more about the removal of the TAVI valve. Okay. So the second question is to Professor Kentaro. The question is in implant stopping 3 20 millimeter and and the feeling where you worry about the long-term durability and the residual pressure gradient?
Okay, thank you very much for your question. So actually, even even with the 20-minute SAPIEN-3 valve, we had the acceptable hemodynamic if the patient has small body size. And for long-term follow-up, we don't have that much data about the patient with extremely small body size or a SAPIEN-3 20-millimeter valve. And of course, it might develop some pressure gradient, but I'm not quite sure that it will reach to the severe PPM or not. So we need to wait for the long-term data, I think.
So, Kentaro, I have a short question to you, and it's like a coronary stent procedure. Larger, the lumen size is always good, and Medtronic have some different system of AViV system. They emphasize in terms of PPM is AViV is much better than SAPIEN. Like for especially East Asian population, sometimes we require 20 small size SAPIEN valve. And Kentaro, do you have any comparing data AViV versus SAPIEN in patient with the small size the valve, annula or valve?
Sure, and our preliminary data shows that now we are submitting the data to the journal, but of course, AViV are demonstrated the better effective orifice or area compared to SAPIEN-3 in the patient with extremely small and less than body size. But the incidence of pacemaker is increased in the with AViV compared to SAPIEN-3. So we need to take balance, taking into account each patient's characteristics. If the patient has already received the permanent pacemaker, so we need to worry about the pacemaker. So I think the AViV could be better. And if the patient had the coronary artery disease or stenosis, repetitive, and who requires repetitive PCI, maybe SAPIEN-3 could be better. So we need to take into account all the characteristics to choose the optimal device.
Kentaro, can I ask you a question? It's just
sure.
popped into my head. In patients with low body surface area, is there a different cutoff where aortic stenosis becomes severe? What I mean is, we usually say 0.9 is severe aortic stenosis. Now, underinflated SAPIEN-20 is 0.9 area. So do you think that we also need to adjust the definition, or is this what you have seen, that patient one of your patient is 30 kilo, she actually become only symptomatic when the aortic valve area becomes less than 0.5. And it's just something I suddenly realized can happen as well.
Yeah, thank you so much for an important question. Actually, we have renewed our Japanese guideline in March. And in this guideline, so we mainly respect pressure gradient. And if the patient have the low stroke volume index, we think about paradoxical or classic low flow, low gradient aortic stenosis. So we don't see that much about the aortic valve area because our patient has really small body size, as you talked about. So we very much respect pressure gradient or other functional the parameter compared to the aortic valve area itself.
Thank you.
Thank you.
Okay, thank you. The third question will be to Professor Park. The question is, what is the current practice in Korea about a relatively young patient, namely the age less than younger than 75, with the aortic stenosis and the multivessel coronary heart disease?
Yes, there is Dr. Yin, very important question is last year there is a landmark trial, the low-risk trial, partner 3, AViV low-risk trial released. However, in reality, there are many cardiac surgeons still resist. There are always debate about TAVR should be default treatment age more than 75, but cardiac surgeon still very resistant, even though age more than 75, relatively low risk, surgical risk, they try to do the TAVR procedure. So I think still debate about age threshold, 75, 70, something like that. More than 80 is most surgeon, agree the TAVR would be best option, but less than 75 or 70 is still a lot of debate. But in our practice, less than 70 has concomitant multivascular disease. Definitely, we report to cardiac surgeon, SAVR plus bypass surgery. But the age, the gap 70, 75 still controversial. We are still a lot of argument between a cardiac surgeon and interventional cardiologist. And so I'm questioning to all the discussion presenters. Do you think about the TAVR should be default treatment age more than 75? Is how do you think it's Dr. Ye or Vinnie or Kentaro or Martin? Yes.
I think in my the update, I think a 75 is a pretty good for the TAVI. That's my opinion. 75, regardless of the risk, and I think the TAVI could be this first choices. But I think the less than 65, I think that this is a really need to consider surgeries as an option. That's my opinion.
Yeah, I think that's a very good point. But my question to the surgeon, I'm a surgeon, so I'm being a bit controversial, is then less than 65, we cannot do a tissue valve because that's not good, in my opinion. Because if we do a current bioprosthetic valve, we have to make sure that the patient will reach age of 80 without any intervention. And I think that's the knowledge gap we have. There are some promises like Resilia tissue from Edwards Life Sciences, which hopefully has longer durability. The second thing is we always emphasize that surgeons should plan the procedure with a CT scan before, because say from CT scan, Kentaro's patient, who has got a very small annulus, if I do a surgical valve without looking at the scan and I put a really small valve, then that's not going to last for 15 years. And then we can't do a valve in valve. So we have to do reoperation. So I think it's a slightly complex algorithm now. I feel in our practice, I'm slightly more relaxed about doing TAVR before. If I think that a patient is 65 and at age of 73 is going to be fit and healthy, I can explant the valve and put a surgical valve. So I'm slightly relaxed than before. But if I'm doing surgical valve, I look at the annulus, I look at the size I'm going to implant. I explain the patient if I need to do root enlargement or something before. And I think I discuss the benefits and downsides and then make my decision.
Thank you so much, Dr. Bapat. And I'd like to have some advice from Dr. Yin about this topic.
Well, if the patient is older than 75, of no doubt, I think TAVR and PCI would be the first choice. Below 75, currently in Taiwan, we will still recommend bypass and SAVR. However, regarding the patient preference, I think most Taiwanese or Chinese people don't want to be operated on. So I think TAVR and the PCI is still an option. And I personally also will consider the so-called Warren outcome issue, because from the recently released data, even in the TVT register, they show that 10% of the TAVR center could not reach a benchmark of performance. So I think this is also an issue should be taken into consideration in sending patients for surgery or TAVR. Thank you.
Well, I think that the patient needs to know all of the advantage and disadvantages of TAVR for the at any age, especially in the younger age. I think the doctors have to explain to the patient and the family about all the things before doing any decision. Okay, so the last topic is to our panelists. The question is, do you think TAVR crimping will have any effect on the long-term durability? Well, now, anybody want to answer this question? Maybe,
Martin? Do you want to say something? Crimping.
I don't think there's any information, right? However, there are papers in bioengineering journals using kind of pulse duplicator repeated testing, comparing stented transcatheter aortic valves versus stented bioprosthetic surgical valves. And in those papers, they report lower durability of surgical aortic valves. No, so low durability of transcatheter aortic valves compared to surgical valves. And I think that, you know, as Vinnie raised earlier, the transcatheter valve leaflets are much thinner than surgical aortic valve leaflets. And I think that those in vitro findings are not surprising. And, you know, they probably, well, we'll see from the low-risk clinical trials how they translate in terms of real-world durability in vivo.
The other important point is that commissural alignment. And you know that 4 years ago, we published the first paper with collaboration from Copenhagen, that one of the next frontiers for TAVR is getting commissural alignment. And that actually, again, extrapolating what we learned from the biomedical papers is that if you align a TAVR device in commissural alignment, the expansion is more circular. The other important thing is your coronary access can become better in certain devices. So I think the next challenge in terms of existing devices and new devices, such as probably J-valve and Yana-valve already have commissural alignment by default. Maybe it will become an important issue in younger patients because they may develop coronary issues at a later point.
Well, I think that people need time to prove this, okay, the durability of the valve, the TAVR valve, I think. Well, I think there's no other question. If anybody of you, panelists, want to raise any talk?
Okay. Yeah, I have one question. You know, this year ACC meeting, you know, Michael Mack presented the 2-year result of Partner 3 trial as already presented in the Dr. Jian. And so there is some interventional cardiologist concern about the long-term durability. Is the late catch-up phenomenon. Death is 2 times higher with the TAVR than SAVR, and valvular thrombosis is 3 times higher, and the stroke was 4 times higher. So I think that at these times, definitely we require more 4-year, 5-year, 10-year follow-up. So valvular thrombosis really doesn't matter in the real field. And, you know, the 20%, 15% Partner 3 trial replaced thrombosis, but the Galileo trial was failed. Although conventional recommendation is DAP therapy, aspirin plus Plavix, but we don't know what is the optimal the antithrombotic to ensure guarantee the long-term durability to reduce the valvular thrombosis. Do you think what is the option is less potent NOAC or different combination of the antiplatelet therapies? I want to hear some expert comment on that.
Okay, thank you so much for every one of you. They are our panelists and also our moderators. So for spending so much time in this session and your excellent talk. And I think people will be, you know, benefit from your talk very much. Thank you so much, everyone.
Thank you.
Thank you.
Thank you.
Thank you. We'll
thank you. See you next time.
Yeah,
thank you. Thank you.
We'll proceed to the next session. Yeah.
Okay.
Thank you.
Hope to see you soon. Thank you.
Thank you.
Yep.
Thank you.
See you. Bye.
Okay. Okay, now let's start this new session. The session is the so-called on the shoulder joint. I'm so pleased to be able to invite Dr. Tyrone David to give us a talk in this session. Let me make a brief introduction to Dr. David. I think most of the cardiac surgeons know you because you were the past president of AATS. And, well, you have received a lot of honors. Let me have a brief introduction for you. And Dr. Sure. David, he graduated from the University of Paraná in 1967. Then he received training in cardiovascular and thoracic surgery from 1970 to 1975 at the CCF in Ohio. Afterwards, he immigrates to Canada, where he became a cardiovascular surgeon at the Toronto General Hospital, where he is now professor and head of the Division of Cardiovascular Surgery. He proposed a technique for valve-sparing treatment for aortic insufficiency due to the dilatation of Valsalva sinuses. Dr. David's current research interests are centered on clinical outcomes of surgical treatment of aortic and mitral disease, aortic root aneurysm, and connective tissue disorders of the heart and the great vessels. Dr. David is also known for his knowledge and the use of a Rose procedure for aortic valve replacement. Well, today he's going to share with us his expertise in surgical aortic valve replacement and his classical aortic valve sparing root replacement. His topic will be David operation, past, current, and the future. Let's welcome Dr. Tyrone David.
Thank you. Let's see if I can get back for a minute here.
Yeah.
We have to share the screen.
Okay. So
let me know.
Can you share the screen?
Can you see the?
Well, yes.
Can you see?
Yes,
okay.
Yeah.
All right. Let me give a summary of our experience with this operation. When we first started, we were kind of reluctant because it was entirely moved from Bento, where many of these patients who have aortic root aneurysm, in particular those who bypass the aortic valve, like the one on the right side, the casts are fairly normal, but they have either aortic insufficiency or an aneurysm that requires surgery. What I noticed back in the late 80s was that the aortic annulus in these patients invariably was much larger than in other patients. A normal aortic annulus is 21, 23, 24 millimeter. This patient have about 25, 28, 30. I operated on a patient with an annulus of 47 millimeter in bicuspid aortic valve. So something had to be done to the aortoventricular junction, to the aortic annulus, during the operation. So between 1988 and 1989, when you're fairly familiar with the aortic valve repair and replacement with homograft or Ross procedure, we, unknowing that Shirmagi Yakubi had done this but never published, we developed an operation that we call the remodeling the aortic root, which doesn't address the anal dilatation. Then I combined with a band on the connective tissue of the outflow tract, and this fixed the dilatation. But from here to there was a simple jump. So why to do the operation in two parts if I can use a graft large enough to accommodate the whole aortic valve and put it inside? So in the summer of 1989, the first reimplantation was done. And I stopped doing for 2 or 3 months to make sure that this patient wasn't going to fall apart. Well, he hasn't. 30 years later, as you're going to see, the results are quite impressive. We changed the technique over the years, but in the past decade, we are back to the original technique. Put the patient bypass, open widely the aortic root, cannulate the coronary arteries, and leave the cannula there, and let the perfusionist worry about myocardial protection. So keep giving cardioplegia to keep the heart cold and arrested, and you start to work to do your operation. Excise the sinus valsalva, leaving a 4 or 5 millimeter of aortic tissue attached to the annulus. And then we suture the coronary arteries in the drapes away from the valve. And we don't know how to size grafts very well, but I believe that the silent tubular junction is likely the best measurement. So silent tubular junction is 28, take a 28 graft. If it's 30, take a 30 graft. If you're uncertain between 28 and 30, always take the larger one, because you can reduce the size by plicating, and you cannot make any bigger. And then this part of the operation is extremely important. We have to dissect the aortic root down to a level below the aortic annulus, at least 2 or 3 millimeters below. In this area, it's not possible because the atrium is attached to a higher level. So leave there. Then take the graft that you estimate the standard tubular junction, divide in 3 unequal thirds according to the size of the cusps. So if one cusp is larger, further apart from each other, and then secure the graft to a level below the aortic annulus by at least 2 or 3 millimeters. We prefer to put pledges ourselves. In other words, you pass the suture first and then pass through a soft Teflon felt pledget. The commercially available ones are pretty stiff. And I find that if you touch the leaflet or any part, might damage it. And of course, because this portion here of the outflow tract is dilated, we have to purse-string these subcommissural triangles. But the important thing is that the graft is secured way below the aortic annulus. Next, we suspend the commissures like doing a homograft or any stentless valve, placing the graft as high as possible, and try to make all 3 at the same level. And next, we use transfixing suture between the remnants of the aortic sinuses and the aortic annulus. That's the true annuloplasty, because you suture very close to the annulus. Reimplant the coronary arteries like we do for any aortic root replacement. And after the coronary arteries are reimplanted, we try to work on the cusps to make sure that they are properly aligned within the background graft. I find it much simpler to judge if the cusps are prolapsed or not after the reimplantation, because you have a fixed stenotubular junction, totally unelastic. And it's simple to judge if a cusp needs adjustment or not. So now, because the stenotubular junction is rigid in here, it's very simple to see that this cusp is prolapsing. And we do entirely by visual examination. Take 5-O-Prolene, plicate a 3 millimeter, and compare to the other 2. Of course, we have to obliterate the cul-de-sac that you create here. Otherwise, it might invert and can have aortic insufficiency. The important thing here is that the three cusps co-opt within the graft. In other words, inside the graft, not in the outflow tract. You can test it. You can clamp the graft, give cardiopulmonary at high pressure, and inspect the ventricle and look at the echo at the same time. The echo has to be focused on the cusps. You might be able to see a continuous flow. A vent, of course, is equally good. And that's the operation, basically. It hasn't changed very much in 30 years. We were very criticized when they first published this because this operation eliminated the aortic sinuses. And Bellhouse in the 50s published the importance of aortic sinuses to create edges and currents behind the cusp. And with that, it slowed down the opening and the closure. Well, we are confident enough after 100 or so operation that we could take a graft 1 or 2 sizes larger, placate the nadir of the aortic annulus by reducing 2 or 3 millimeters in 3 places, and then reimplant the aortic valve and placate again the intercommissure space to create a waist. And for 10 years, that's all the way the operation was done. And you do create sinuses. But the most important thing we learned in 30 years is this here, is that the valve co-opts inside the graft and at least 3 or 4 millimeter cusps touch each other. This is a great operation for bicuspid aortic valve, particularly Sievert's type 0, when the 2 cusps are fairly identical. Like in this 17-year-old, believe it or not, from Vancouver, operated in 1994, and he also has Marfan syndrome, and is entirely no AI, imperfect 16 years later. That's the patient. Cardiopulmonary bypass, and being 17-year-old, we did not do an angiogram on him, only to realize at surgery that the left main was coming off the commissure, so he couldn't detach the left main. We left attached. Look at the size of the annulus. You can put your hand inside. So we performed the annuloplasty below the annulus first. And where the left main was, we incised the graft vertically. And he's the left main now, right in the commissure. And then instead to reimplant on the outside, we simply reimplant on the inside, which we have done now 20 or 30 times in patients who have anomalous coronary arteries. So you do annuloplasty below the left main, and then suture the arterial wall all around the orifice, and the operation is done. Reimplant the right coronary artery, and only then we look for cusp prolapse. The conjoint cusp is elongated and prolapsing. Because this young man was done in 1994, you can see here there's 2 plication, creating 2 neo-aortic sinuses. In the operate room, he has 2 sinuses, no AI, and a truly bicuspid aortic valve at 180 degrees from each other. This type of bicuspid aortic valve do as well as the tricuspid. Sievert's 1, it varies. Closer they are to a tricuspid, more difficult to do the reimplantation. We recently presented a progress report at the virtual AHES. From 1989 to 2018, we had done 465 patients in Toronto, mean age 47. 78% were men. A third of them had a genetic syndrome, the most common Marfan syndrome. 33 had Taipei dissection, and 27 patients had the previous operation. One had a Ross, and one had a heart transplant. But the transplanted heart developed an aneurysm, so it did a valve sparing in the transplanted heart. The mean size was 58, but the interquartile range varied from 50 to 55. Most patients had tricuspid aortic valve. We didn't start doing bicuspid until approximately the year 2000. Two-thirds had a significant aortic insufficiency. Few had mitral insufficiency. 10% had coronary artery disease, and 5% an atrial septal defect. As I mentioned before, for about 10 years or so, every patient was operated on with a Neo-Sine Valsalva. Then we abandoned because we saw no difference in outcomes. But most of them in straight graft. The first decade experience, the second decade, and the third decade was back to straight. 38% required plication, the cusp for prolapse. And 24% had large fenestrations, and we repaired them by weaving a double layer of 7/0 Gore-Tex. The average graft was 30 millimeter. These are all comers, dissection, reduce, and 5 patients died for an average mortality 1.1%. These operations are associated with a lot of complications, though. 7.6% had to be reopened because of bleeding or a cardiac arrest. 23% had postoperative atrial fibrillation. 4 patients suffered a perioperative myocardial infarction. 1 patient had seizures, but the CAT scan and MRI showed no stroke. 1 sternal infection. 1 patient had a cardiac arrest. Somebody did a CPR, too vigorously torn the liver. They had to open and repair the liver. The second case that we are developing the technique left the OR with mild to moderate AI. Next day was moderate to severe. We took back and did a bento. And 2 patients before they went home required mitral valve repair. 1 for perforation until leaflet. In the days that I did not use pledget, I use only simple sutures. And 1 to systolic continual motion mitral valve. 9 patients require pacemaker. 5 of them in bicuspid aortic valve. So the pacemaker implantation is only 1% for tricuspid, 10% for bicuspid. I guess many bicuspid aortic valve don't have a membranous septum, and it's difficult to know where the bundle crosses the outflow tract. And more than half require platelet or fibrinogen or other blood product or blood itself. Because it's something that we develop in Toronto, we ask every patient to allow us to contact them. And unfortunately, some 20% are international, and those are very difficult to continue following 10, 20, 30 years later. So the follow-up used to be 100%, but it's dropping, unfortunately, and mostly because of international patients. Eventually, we're going to have to stop reporting whole experience and remove the international patients. And we try to retain an echo every 2 or 3 years. In this 465, we had 2,800 studies to examine. And we also recommend an MRI or a CAT scan every 2 or 5 years if the patients have a genetic syndrome. This slide summarizes the experience. 20 years later, 69% were alive and free from reoperation. 24.8 died. 6% require reoperation in the aortic valve. If you take a look at the aortic insufficiency, it's progressive over the years. Starts very low. Talk about moderate or severe aortic insufficiency. Starts very slow, but by 20 years, 12% had moderate or severe aortic insufficiency. Only time since operation correlated by multivariate analysis to development of AI. Size the aneurysm, how much AI before surgery, cusp repair, neostandard Valsalva, bicuspid aortic valve, nothing predicted AI except duration of the operation, indicating that this valve into a rigid conduit eventually is going to fail. It's not an elastic conduit, not being elastic. It's going to be a problem. And then during the follow-up, we discover new things, that there is a very high incidence, or relatively high incidence, of distal dissection. Removing those 33 patients with the preoperative dissection, 22 new patients developed dissection of the arch or type B. Most of them had genetic syndrome. So nothing happened in the first 7 to 10 years. It takes 7 to 10 years later for dissection to begin to increase. And indeed, in patient Marfan's and Lewis syndrome, 10% develop type B dissection. The other ones without genetic syndrome, only 2%. Another thing we discovered is bicuspid aortic valve, with the exception of severes type 0, they become progressive stenotic over time. Our experience is small, only 67 patients. The mean follow-up much shorter. And the mean gradient they left the hospital, peak systolic gradient was only 13. The overall did not increase very much after 6 years. But 5 patients developed gradient greater than 40, and 1, the mean gradient greater than 40, and required reoperation for aortic stenosis. The other 4 patients being followed, and their gradients increased progressively. However, bicuspid aortic valve was associated with probability of reoperation only by univariate analysis, not by multivariable. It's a great operation and durable. The valve-related complication is very low, and reoperation is uncommon during the first 20 years. In bicuspid aortic valve, in tricuspid aortic valve, the function remains stable for many, many years. In bicuspid, we have a proportion, 10%, developing aortic stenosis. Patient genetic syndrome are at risk of distal dissection, and our patients were in beta blocker, and in spite of that, they develop dissections. How about the future of this? Well, everybody talk about the graft, that the graft, a straight tube, is the wrong shape. However, the aortic valve is a cylinder. If you take the sinuses out, the aortic valve is a perfect cylinder. And the annulus evolve along a single horizontal plane. Only a cylinder allows this geometric arrangement. The commercial available Valsalva grafts, the cardio root and the gel weave valve, the sinus of Valsalva are spherical. That's not the right shape. Actually, if you implant correctly here, you're going to deform the annulus from a single horizontal plane to a curve. Is it better than a cylinder? Hans Siever came up with the answer and developed the unigraft, double sinus, which is straight where the commissures are reimplanted, but there's a bulge. Unfortunately, we cannot get this in Canada. It's not approved in Canada. But I think this is a promising graft that might have a beneficial effect on durability. The current thing now is to study flow, velocity, and stress through 4D MRI. And this image is a normal aortic root. You can see on both sides the what the sinus Valsalva do. Once you reimplant into a straight tube, there's no more edges and currents. It's a straight flow. You might believe to have some here, but not very much. If you reimplant in a unigraft, the way the Sievers described, is almost like normal. The question is, will the graft have an effect on long-term durability and reduce the risk of dissection? Remains unknown. In the next few years, we should be able to answer that. Thank you.
Thank you. Thank you, Dr. David. I will give my talk. Later on, we will have discussion from the audience.
Yes.
Okay. So now I'm going to talk about the David operation at Changchun General Hospital. Actually, I should say that to preserve the patient aortic valve is very important since when you replace the valve, you created another problem. So in the future for the patient, so the valve-sparing aortic root repair is very, very important, I think. From this figure this figure is from Dr. Lansek, the Institute of Mutualite from Paris. Okay, so from this you can see that there are several kinds of valve-sparing root to repair. The left the one is the Jacob's root remodeling, and the middle one is David operation. And Lansek, I think, is trying to solve the problem of the root dilatation after the surgery. So he used a subvalvular aortic annuloplasty to fix the size of the annulus, so that it will prevent the further dilatation after root remodeling surgery. From 1995 to recently, we had done 312 cases of aortic root repair. These include 274 cases for Bentos operation, chiefly used for the patient with aortic root dilatation and dissection. And we had done 38 cases in the since about 7 years ago. 21 is for the aortic root dilatation, and 10 for dissection, and 7 for Marfan syndrome. During the David operation, we had some concomitant operations in which 7 patients received total artery replacement, and 7 received aortic valve repair, and 5 received coronary artery bypass graft, and 5 received atrial fib ablation. In these 38 patients, we had actually, only half of the patients need blood transfusion. There is 1 surgical mortality, and we have the results shows that 36 patients has less than mild or mild aortic regurgitation. Only 2 patients had moderate to severe aortic regurgitation after the surgery. Up to recently, we have only 1 late death, and 1 patient who received heart transplantation due to the poor LV dysfunction since before the operation, and 2 patients who received TAVR for their recurrent aortic regurgitation. Both the TAVR patient was very well. Well, from our experience, we raised some questions about the DAVD operation, since sometimes we will have problem with the aortic regurgitation by testing the aortic valve competency. So we are thinking about how to manage the aortic regurgitation during or after DAVD operation. During the operation, we found that the annulus is a little bit too large, and we may have to reduce the size of the annulus. Then we made some stitches outside the graft. And sometimes we will have the problem with the prolapse, the valve cusps. Then we have to repair the valve cusp. And if we don't have any way, once the aortic regurgitation is still there, we will replace the aortic valve. It's quite simple and easy. We just need to insert the valve, and we can make running sutures outside the valve, then outside the graft. Then it's easy to replace the aortic valve. And after the operation, if the patient have some problems with the aortic valve, we can just do the TAVR. Why we can do the TAVR for this kind of patient? Because the nature of the non-stretchable quality of the graft. So then we can replace with TAVR, but this TAVR cannot be used for the remodeling method. Another problem we're thinking about is what if the patient who are going to receive the DAVD operation, but the patient still have the total dilatation of the aortic arch or dissection. So sometimes we need to replace the total arch. Well, people may think that because the DAVD operation may consume more time than Bentos operation, so some surgeons would suggest that to switch the DAVD operation to Bentos operation. And some may think that, well, it may take a lot of time to do the total arch replacement, so why not just to replace the ascending aorta only? But I still believe that we still need to do the complete surgery for this kind of patient. So usually I would do the Davis operation plus the total arch replacement. Well, I would like to show you a live demo patient, which is, we show that we did that on occasion of Change in Life and at the end of last year, and the video just shows the technical aspect of a complicated DAVD operation. The patient have a diagnosis of aneurysmal dilatation of the aortic root, ascending aorta and aortic arch with the severe aortic regurgitation and the chronic atrial fib. So we did the operations of DAVD operation plus total arch replacement plus the atrial fibrillation. So I'd like to use about 30 minutes to show you this surgery. Okay, so this is the CT before the surgery. So you can see that there was still dilatation at the arch. So first of all, we will isolate the arch vessels, and these are the arch vessels. we have to cut a part of the sternocleidomastoid muscle to isolate these vessels. So this is the echo showed the severe regurgitation of the aortic valve. And after clamping the aorta, we cut the ascending aorta. The patient was perfused with right subclavian artery and the left femoral artery during the bypass. Then we transected the aortic root. Then we did RF radio frequency to we use radio frequency to ablate the atrial fibrillation by the ablate the 4 pulmonary veins. Then we marked the coronary arteries. This is the right coronary artery. Then we cut off the excessive tissues with remaining about some of the coronary sinus valsava. Okay. This is the standard way of David operation. So this is we put on 3 stitches down the commissures of the aortic valve. Okay, this is we're making the stitches at the aortoventricular junction. Usually we would use about 9 to 12 stitches for the aortoventricular junction. Since this part of suture will be just for the purpose of holding the graft to the aortoventricular junction, so you don't need to use many stitches for this. Maybe only 9 to 12. We use a valve sizer to mark the commissures of the graft. This 3 sutures is for the commissure ones. Then we're making stitches from so-called the stitches coming from the aortoventricular junction to make it further on the graft. Then we're going to tie the sutures. Then we'll use a Hager dilator to put inside the graft, so that we'll achieve a good sizing of the graft. And then this is the stitches from the commissures, and we'll make it on the from inside to the outside on the graft. These are the 3 markers on the outside we made by the use of the valve sizer. Then after this, we are going to suture from inside the graft to suture the remnant of the coronary sinus to the inside of the graft. Actually, this row of suture is very important because this is for the bleeding check, for the hemostasis. If there is any bleeding, it usually comes from this row of suture. So it's very important to make it safe. This is a little time-consuming because you have to make many stitches over here. But maybe it takes only about 10 minutes more than Bentos operation. It's just because of this part of the procedure. So after finishing all these sutures. Then we'll test the valve by giving some iced selling. Then we will test the consistency of the aortic valve, of the graft. If the consistency of the graft is, the tension is good enough, then we think that the valve is competent. Then we mark the site for coronary anastomosis. The same, we would do the same way as Dr. David just shown. Well, we concerned a little bit about the height of the coronary artery. So we try to put the coronary artery, the button, a little bit higher, as high as possible, in case if the patient needs TAVR in the future. And if the coronary height is very low, then we might have to modify our technique. We would do the Cabros modification. Then we would do the coronary anastomosis at the posterior wall of the graft. And we also have to care about to be careful about the branch of the coronary artery. In this patient, the right coronary artery has to be anastomosed to the non-coronary cusp. Most of the time, it should be used to put down the site of the right coronary site, the right coronary cusp. But this patient, the anatomy of this patient is a little bit different, so we have to anastomose the right coronary artery to the non-coronary cusp. For this patient, the height of coronary artery is enough. It's more than 1.5 centimeters. So we will be, for this patient, if the patient needs the TAVR in the future, we still can do that. Then then we'll test and we'll give some cardioplegia solution at this time again, and also to check if there is any bleeding from the coronary anastomosis. Then we cut the left subclavian artery and the left carotid artery. It's easy to expose these two vessels just by partially, transect the sternocleidomastoid muscle. It's very easy, as you can see that it's, and it's also easy to anastomose the two vessels here. You can do the end-to-end anastomosis. It usually takes not much time. So after this, you can make another hole. You can cut the left carotid artery here. Then we're going to anastomose 8 millimeter graft to the left carotid artery. So usually it won't take much time to do this. Then we will perfuse the left carotid artery at this moment. Okay, now we are going to cut the right innominate. At this moment, the brain received the secretion from both the carotid arteries, one from the right subclavian, one from the left coronary. Then we isolate the middle portion of the aortic arch with 3 taps on it, and we sized the lumen of the aortic arch. This is a vascular ring connected, made of titanic ring. Then we insert the titanic ring inside the graft. So we're going to use this as elephant trunk. So on the right side, it will be the elephant trunk. Okay, then we fix the vascular ring connector inside the graft. Then we insert the guide wire from the femoral artery. And femoral artery comes from aortic arch. Then we make a knot on the guide wire. This knot is used to fix the tip of the graft to the guide wire. So we put on 2 stitches on this. So 2 stitches with 4 needles. Then this is then we made the stitches on the tip of the elephant trunk. Then we cut the needle. Then use the tourniquet to bring the tip of the 4 threads, 4 stitches through the graft. Then by putting the tourniquet, tightening the tourniquet, the tip of the graft will be fixed to the guide wire. Then we pull the guide wire from the femoral artery. Then the elephant trunk can be inserted into the descending thoracic aorta. Then we tie the tapes on the ring. Then we pull down the guide wire from the femoral artery. Then we put it back again, and we can remove the stitches on the knot. Then we use the stent graft to put inside the conventional graft. Then we cut both ends of the graft. Then we make the anastomosis between the 2 large grafts. Now the brain perfusion still goes through the right subclavian artery and the left carotid artery. And then we make a hole on the anterior wall of the dacron graft. And this is going to be used for the anastomosis to the bifurcation graft. This graft is usually used for the AAA surgery. So after this, we will have 2 arms for the arch vessels. One is for innominate artery. This is innominate artery. And another one will be, now that the heart resumed its beat, its contraction. And this left arm is used for anastomosis to the left carotid artery. So now the operation is completed. From the echo, you can see that there is minimal aortic regurgitation only. And the blood pressure becomes better. And 5 months after the surgery, the CT showed that there's a very good repair from of the aortic arch. Okay, this is our technique of our standard technique of surgery for this kind of patient. And so now my conclusion is that DAVD operation is durable and is probably the best choice of aortic root repair in aortic root dilatation, Marfan syndrome and aortic dissection. And DAVD operation can be easily switched to Bentos operation immediately after a failed DAVD operation. Third, due to the non-stretchable nature of the aortic root, TAVR can be used to treat aortic regurgitation during or after DAVD operation. Thank you. So I'm glad that Dr. Jian Ye is also our moderator. So I'd like to have any, Dr. David, you want to have some? You have some comment on this?
I was impressed by the aortic arch replacement. You don't do the anastomosis in the aortic arch at all. You tie a tape around the ring.
Yeah, That's the
You never had false aneurysms there.
No. That's not false aneurysm because in the past people worry about the so-called intraluminal graft because of the development of false aneurysm. Actually, the commercially available intraluminal graft in the past is made of a plastic ring. That's so-called. It's Medox ones. Actually, we used that for many years, and we found that the problem with that is because there is no furrow on the ring, so it makes the laugh. It just displays. So the false aneurysm is not due to the necrosis. It's just because of the dislodgement. Yes.
You don't like to have a frozen elephant trunk instead?
Okay. Well, I prefer to. For this patient, we can use frozen too, yeah. But for the aortic dissection, I don't like to use frozen ones because
dissection is good. No.
Yeah, yeah.
You end up tearing the false lumen and more trouble with more perfusion than anything else.
Yeah. You're certainly right. Yes, yeah. And may I ask Dr. David about the use of the Valsalva graft? I totally agree with you because in the past the conventional Valsalva graft probably there is no benefit from that. So nowadays we are only use the straight graft for this. And another comment on this is because now I'm concerned more about the height of the coronary orifices because in the future, probably, we need the TAVR for this kind of patient. So the coronary height is quite important, especially for the bicuspid aortic valve, because I don't have the experience with bicuspid aortic valve with the David operation for bicuspid, because I'm not so confident with that because worried about the future problem with the aortic valve. So, well, I think it's very good. You may change my mind. In the future, I might still do the bicuspid.
I can assure you, if it is truly bicuspid, in other words, severe zero.
Yes.
We have now 19 years experience in that. They don't fail.
Okay.
Now, the other ones are more complicated.
Oh, yes,
Severe one, which is the more common type bicuspid aortic valve, it depends on the phenotype.
Yes.
If you can dissect the root and try to make like as close to 180 as possible. Giabrino Curi has the large experience than anybody else with reimplantation in bicuspid aortic valve. In up to 10 years, his results are pretty impressive. Yep. 90% are free from reoperation. So for a younger patient, 20, 30, 40-year-old, likely is the best operation. Older patient, I'm not sure if there's any advantage. Once you turn 55, 60, you can put a bioprosthetic valve and then a valving valve, as long as you implant a valve large enough, but you shouldn't be able to in a bento.
Yeah, I think it's a very valuable experience with that because nowadays, because we have the TAVR for the treatment of bicuspid aortic valve, and if the patient is young and the valve is still okay, then even for the bicuspid aortic valve, we still can do the David for that. Well, maybe during the operation, we just have to care about the height of the coronary orifice. So
coronary arteries, yes.
Because your David operation is very good because it's non-stretchable site of the annulus, so we can do the TAVR. It's amazing because in the past I didn't think about it, but in the era of TAVR, that nowadays we can do that. Yeah,
that's correct.
Yeah.
Yes.
Yeah. So, Dr. Jian Ye, do you have any comment or questions for? Yeah.
Excellent talk, you both. I learned a lot. But one thing is about the Valsalva graft. I did switch from a straight graft to the Valsalva graft for a few years. The reason I switched because I started TAVI and the valving valve, and there's sort of some patient that does have a concern for the coronary obstruction because it's straight valve graft. And then I used the Valsalva graft, and definitely from valve in valve point of view, there's no issue with coronary obstruction because of Valsalva graft. And but since the graft, as Dr. David says, the graft is not really designed for the DAVR procedure. So my own experience, the critical part is the commissure. The top of the commissure has to put into the above the sinus Valsalva graft, because otherwise there will be big trouble. And
the height is a problem. The patient's commissure height may not be the same as the graft, so we have to adjust for that.
I usually
put the annulus almost inside the part that bulges to prevent this problem, and it looks pretty good, his results.
Yeah, you're right. Sometimes I have to fold the sinus Valsalva down a little bit with my stitch.
That's correct.
That way, the commissure height will reach the top tubular graft rather than inside the Valsalva graft. I think that's critical. But
okay, there is a question from our audience for me and for Dr. David. The question is, how do you choose the correct size of the graft, the tube graft?
It's difficult. To be quite honest, I don't know how, but probably the best way is to suspend the three commissures and take a geometric circle, a sizer, like a stentless valve sizer, and see which one allows the three cusps to co-opt centrally.
Yeah.
That's what I use more often. And if you're in doubt between two sizes, always put the larger one.
Okay.
Because if you find that the cusps do not touch the center of the aortic root, you can placate the intercommissure distance. And when you placate, you move the cusps inward.
So you placate the three commissures, right?
The space between the commissures.
From outside, yeah.
Right, from outside, yeah.
Yeah, I did that before. But, I have a little bit...
only if necessary. Not in your case, no.
Okay. Yes, I think you're right. But from my experience, for the Oriental people, maybe the body size is a little smaller. So the most common graft I used for that is the 30, 29, 30, 28, and 26.
That's pretty good, though.
Okay, then
That's the same as ours. 30,
really?
Ours is 30.
Okay.
My calcified valve requires a large one, 32, 34, 36 sometimes.
Yeah.
Oh, 36,
okay.
Larger cusps.
Okay.
But about similar experience then.
Yes. So how about Dr. Jian Ye?
I use put a larger graft. Usually, I use almost all above 30 Valsalva above, was 34, 30 larger graft usually. I have a question for you both. Sometimes, the annulus is quite dilated with central jet. Sometimes the central jet, due to the sinus junctions dilatation, root dilatation causes regurgitation. But some patient does have an annular dilatation. In this kind of situation, how do you decide the size of graft with the annular dilatation?
If there is no annular dilatation,
there's an annular dilatation.
I use my estimate for stenotubular junction. In other words, if it looks like a 30 millimeter, the cusps touch each other centrally, I take a 30 millimeter graft, or 32, or 34, or 28. So all depends on the size of the cusps. Bigger the cusps, bigger the graft.
Well,
so it's based on the cusp. Okay. But even like with annular dilatation.
Professor, you show three stitches, pull up in the air, and put a suction in between them until the cusps co-opt. And that's how we estimate.
Okay, for me, I use the body size, body weight. Okay.
Oh, really?
Because, yeah. So if for the small body size, I use 26, and I will use if for the 26 graft, then I will use 18 Hager dilator when I am tying the aortoventricular junction sutures. Okay.
One question for you both. I have some a bad experience when I started as a daily procedure. When I choose, sometimes I choose a little bit smaller, a little bit too smaller graft. I found that the leaflets actually prolapse into the LVOT.
That's
and
right.
of course, sometimes it may not be down enough. Like Dr. Dave would say, you need to really down to below the annulus. But sometimes as the graft is too small, even that the graft is low, I found that the leaflets on the echo, the coaptation zone is quite a low. Below sometimes at the annulus, sometimes below the annulus. Do you think that's due to the graft issue? They're too small?
Yes, no, absolutely. Too small graft. And this is a predictor of failure as well. If the coaptation is below the aortic annulus, usually they fail. So we try to put the cast really inside the aortic root. They reconstruct the aortic root. Almost like they are praying, you know.
Okay, so it's about time to close, and I especially thank both of you for attending, giving the lecture, and also for the discussion. Thank you again.
Thank you for inviting me.
Yeah, thank you so much. Thank you so much. Okay, thank you.
Bye.
Have a good day.
Bye-bye. Bye-bye.
Thanks.
Friends and my dear colleagues, and ladies and gentlemen, good morning, and welcome to this section. This section will be from 10 o'clock to 11 o'clock, and I'm Dr. CHGH Jeng from Chang'an Memorial Hospital, Taiwan, and this is Dr. Liang Zhang from the Jian General Hospital, Taiwan, and we also have some moderator and Dr. Vinayak, Bapat from USA. Yes, welcome. And of course, Dr. Yin, Professor Yin will perform the lab demonstration later. And we also invite Dr. Zhang Qi Ren from Chang'an Memorial Hospital, Taiwan. And also we invite David Smith from New Zealand, sorry. And we also have Dr. Simon Cheung-Chi Lam from Hong Kong. And also, Dr. Chao Dianping, he also will perform the lab demonstration later. So today, this section, the topic is regarding the valve involved for prospective valve failure. So I think it's a very interesting topic and also very informative in this situation. And at first, I would like to invite Dr. Bapat to give us a special lecture. The title is Introduction to valve-in-valve for Prospective valve failure. So Dr. Bapat, please. Thank you.
Thank you very much. I hope you can see my slides.
Yes, we can see.
Thank you very much again. These are my disclosures. I work with most of the valve companies because I've got a lot of interest in valve design. Valve-in-valve is definitely one of the most interesting indications and expansion, I would say, in terms of TAVR indication. And in my mind, when I say valve-in-valve, aortic valve-in-valve is the majority of the cases, followed by mitral valve-in-valve and other areas such as mitral valve-in-ring, mitral valve-in-MAC, pulmonic valve-in-valve, which is being done more and more now, and of course, tricuspid valve-in-valve and ring. But we are going to mainly talk in terms of aortic valve-in-valve to start with. So this is one of my first cases nearly 10 years ago now. As you can see, it's a transapical procedure. It's performed very quickly and easily. A 26 Sapien XT, Sapien 1 valve actually was implanted in a 25 Magna. And you can see it's less trauma, very fast recovery, hardly any contrast we used to use at that time, and an absolutely perfect implant zone. So it's at present approved in the United States only for high-risk procedures, high-risk patients. And the reason for why not in every patient is because we still don't know what is the durability of the valve-in-valve. We don't know the effects of residual gradient, if there are any delayed coronary obstruction events, especially if you have stented it, and what are the implications if the valve-in-valve combination doesn't work. So you may have to do reoperation at a much older age. So the main three important points for the aortic valve-in-valve is wrong position, high gradient, and coronary obstruction. So now we have become much experienced in this procedure. So what we want to do is we want to implant the valve so that it's secure, so it doesn't embolize. And at the same time, it can give us very good hemodynamics in a given situation. So as you know, that surgical valves are all different. They are constructed differently. Their frames look different under X-ray. And you can see that the top valve is made of pericardium. The second valve is made of pig valve. The third is made of pericardium, but wrapped outside. So each of this valve is very unique. So the first thing we need to know if we want to implant it in the best possible position is what is the neo-annulus. And we described this paper nearly 6-7 years ago now, that the narrowest annulus is always the sewing ring of the surgical valve. So if you can identify the sewing ring, you can implant your device in a very nice way. So if you know the sewing ring, what you should do is implant the device around 15% or 10% below that. And this is how we described it, that Sapien XT or S3, you should implant it 15% below. And if it's an Evolute R or a Portico, you should deploy around 3 to 4 millimeter below. And the reason behind it is it will not embolize, it's secure, but at the same time, it will give you very good hemodynamics. Now, there are some valves such as Mosaic, which are not seen very well, or they are seen a bit differently. So we need to be careful about these valves. Same thing with stentless valves. They are not seen under X-ray and under radiology. So it's very important that you take some expert advice before you do it. So in case of Mosaic, I think we need to be careful. And here's the example of a Sapien 3 in a Mosaic. I think what you have to do is make sure that the Sapien 3 is just above the eyelets, and then it will give you the best position possible. I just want to share with you the importance of positioning. This is an Evolute R in a Carpentier Edward porcine valve. The picture on the left side is the ideal way of implanting, but this is in the past, by mistake, we implanted like this. And what happens here is you can see that the leaflet level of Evolute R, ideally it should be there, but now actually lands up in this low position. So what I mean is if you need good hemodynamics, good positioning is very critical. And that reflects into high gradient. So if you implant low, the gradients are going to be bad. So the reason we have high gradients is because it's a small surgical valve to start with. It's a oversized sapien or evolutar valve and BMI of the patient, of course. The first important thing I always tell people is don't go with label size. And again, I defined a term called true ID. As you can see here, that all the surgical valves are different in their true ID. So the first example is a pig valve. And here what happens is the true ID goes down by 2 millimeters than the stent ID. If it's a pericardial valve, the true ID is 1 millimeter less than the stent ID. And if it's a design like MitraFlow or trifecta, the stent ID and true ID remain the same. So this is critical because if I use label size as my guide or a stent internal diameter as my guide, I'm going to misjudge the kind of TAVR device I'm going to use. So it's very important to use the true ID. And this information is provided in the app, and that's what you should use. So what do we do if the true ID is really small? What I mean by that is if the true ID is, say, less than 19 or 18, what are you going to do? So the first thing is try and choose a better valve. For example, most people prefer a supraannular device like Evolutar in this given situation. Second thing is if you are using Evolutar, then make sure you position it as high as possible, because there is no point using Evolutar and implanting it deep intraannular because you're going to lose the hemodynamic advantage of it. And the third thing now is, of course, can you do a valve fracture? I'm not going to describe this as we have a case which is going to demonstrate, but I'm going to raise some questions in your mind so we can probably ask in the next presentation and discuss them. So the first thing is there is a confusion about should you fracture it before or after? What balloon should we use? Again, what is the diameter you gain? Is there a recoil after a few months after you fracture? Is there a risk of annular injury? And more importantly in my mind is if you increase the diameter, is there a chance of coronary obstruction which goes hand in hand as you're pushing the leaflet closer to the coronary artery? There are some valves you can fracture, some valves you cannot fracture. So the valves you cannot fracture are Hancock 2, which is here, and trifecta, which is made of titanium, which is not in this picture, it's here at the top. So these two valves you cannot fracture because of the structure. Most of the other valves you can fracture quite easily, but you can see at a much higher pressure. So the surgical design has to change as well. And this is the Edwards Inspiris valve, which we implant regularly in Colombia now and in the United States. And you can see that what it has is a slight expansion mechanism, which may come useful in future when these valves fail. So we may be able to expand this at a much lower pressure than we are fracturing at a high pressure. So this is what is going to happen. A coronary obstruction is a big risk, and you must check on the CT scan. And again, what we have seen in our practice is that the PIG valves have low obstruction risk. As you can see, the leaflets are thinner and the true ID is smaller. But if it's a trifecta or MitraFlow design in a small anatomy, then the risk is much higher. And this diagram potentially explains that to you. And what we do now is what is described by the Vancouver group. We measure what is known as a VTC distance. If it is less than 4, it's generally not very good. 4 to 7 is borderline. And we are comfortable when it's 4 to 7 for PIG valves, but not so comfortable with pericardial valves. And if it is more than 7 millimeter, then it's generally taken as less risk of coronary obstruction. How do you protect this? So what we do normally is if there is going to be a risk for coronary obstruction, we put a wire and a stent inside. And if we need it, we can redeploy it. But if there is an obstruction, you should try and do PCI. And if not, then you have to do surgery. And that is why in these patients, we always keep cardiopulmonary bypass ready in case we have to go on cardiopulmonary bypass while we are trying to do PCI. The second important thing is if you have done a stenting because of coronary obstruction, then you must consider anticoagulation because there have been incidences of delayed stent obstruction and patients dying after such chimney stents. So I think, again, a topic of controversy and less experience at present. There are techniques such as basilica, which have been, proposed. This is pretty complex technique to do, especially for the right coronary cusp. I think we need better solutions in future if we are going to indulge in such techniques in future, because those who have done it will agree with me that this is quite a resource-intensive procedure. Very quickly about stentless valves. We heard a beautiful lecture about David operation. Similarly, there are centers who have used homographs, freestyle routes, and a lot of these patients come back. We are going to do a case on Monday, for example, of a homograft after 12 years. And what happens in this is you do not see them at all properly. So my suggestion is use a transesophageal echo to make your landmarks more visible. There are two types of stentless valves. One is implanted as a root. And in these patients, the risk of coronary obstruction is much less, while if they're implanted as a valve, the risk of obstruction is slightly higher in our experience. There are certain tips and tricks, again, just to give you a flavor of it. You can use multiple injections. You can put a wire in both the coronaries to give you a landmark. But more importantly, do a slow deployment and do repeated injections so that what happens is you know where the landmark is. And as you can see, we use transesophageal echo, such as in this case, to give you a very beautiful result. Very quick on mitral valve in valve. You can see here that the first frame which is running is a valve in valve. Most of these procedures are done now transseptal. It's a relatively straightforward procedure. Valve in ring, as you can see, and valve in MAC are an extension of this procedure. The results of valve in ring are not that good because of many reasons, and I'm going to summarize them very quickly in one slide later. Luckily, all the mitral valves are all stented. That means there's no stentless mitral valve, which is very good. Second lucky thing is all the mitral valves look exactly like the aortic counterparts. So for example, the second one is a Hancock 2 mitral. It looks exactly like Hancock 2 aortic. And so does the Magna, which is at the bottom, and Carpentier-Edward at the top. The main challenges in mitral valve in valve is what size you have to use, and secondly, LVOT obstruction risk, and thirdly, anticoagulation. I'm just going to say very clearly that most of these patients require anticoagulation because they are either in atrial fibrillation before, or majority of the time we have found that there is a high risk of leaflet freezing in mitral valve in valve. This is one of the cases. This is a very interesting case. As you can see, mitral valve in valve was deployed, very beautiful, ideal position, but it moved up and it embolized. Why does that happen in the mitral? Because the closing pressure in the mitral valve in valve is very high. It's a systolic pressure. And that is why we always need a 2 millimeter to 3 millimeter oversize in the mitral. And this is our recommendation, that what you have to achieve is a conical deployment. And this conical deployment is very critical in mitral valve in valve. And we have just submitted another paper on borderline sizing with SAPIEN 3, how you can achieve this conical deployment without oversizing. But I think you all can appreciate very well, this is the parallel deployment at the top and a conical deployment at the bottom, which actually leads to no embolization in future. If you think mitral valve in valve was complicated, there are at least 22 different rings which are implanted today. So you can imagine all these rings, how they can be suitable for a TAVR. For example, the top ring is called a Durand band. The second one is a Carpentier-Edward Classic, which is a rigid ring. The third one is a IMR ring, which is not only rigid, but it's asymmetrically rigid. So what I'm trying to say is that mitral rings are all different, and it's very important that you check whether the ring is suitable or not. I look at 4 properties of the ring before I say yes to a valve in a ring. First of all, can it become circular? If it can become circular, can it provide an anchor? Third, can it be seen under X-ray? Otherwise, do I have to use transesophageal echo? There are some rings which are not seen under X-ray. And the most important thing, which we all forget sometimes, is the size of the ring. Mitral rings, sometimes, not sometimes, most of the mitral rings are made up to size 40. So size 36, 38, and 40 are not suitable for SAPIEN 29. So even if the ring is suitable, it's too big for these valves. And that's, again, becomes very important. A quick example, as you can see, this is a rigid St. Jude ring. And once we do a TAVR device inside, it looks very nice on the side profile. But you will see it in the end that there's actually extremely large PV leak gaps on both sides. So you can appreciate how big the leak is going to be. While on this one, this is the Physio 1 ring, which is a semi-rigid ring. And once you deploy it, it becomes nearly circular. So you're going to get a much better hemodynamic result with this particular ring. If it's an incomplete band, you can see that it's not going to work very well. So please don't do a case if it's an incomplete band, because once in a while you may get away with it, but most of the time you're not going to get very good result. So this is the list of the rings. You can see that there are 8 rings currently implanted, which are ideal for valve in a ring. If you do it in any other kind of rings, you're not going to get good result for sure, and you may actually land up in some problems. Lastly, but not the least, there are 2 apps which we developed many years ago, valve-in-valve aortic and valve-in-valve mitral. These are available free, and these have very good educational resources and contribution from all the physicians in the world to simplify this procedure. Thank you very much.
Okay. Thank you, Dr. Bapat. Thank you very much for your very excellent speech. And because we are behind the schedule a little bit, so sorry I cannot open the question to the audience regarding your speech, but you can still join our discussion later, okay? Thank you again. And on the next, I would like to invite Dr. Len to give a case presentation. And the case is regarding the aortic valve-in-valve and the balloon fracture. I think that's regarding the balloon fracture. So let's give a warm welcome to Dr. Len. Dr. Len?
Hi, thank you very much.
Are you okay? Thank you.
Yes, so good morning, everyone. So it's very enjoyable to listen to lectures given by Vinnie. And I would like to carry on with a case which involves a controversial topic on valve fracture. So the reason to share the case is not because now it is the standard or this is the correct way to do it, but it's kind of sharing my experience, and also we gather experience from all around the world to see if it works, because it works in bench testing, but it's never proven in large randomized studies. But we know that especially for Asian population, the valve implant in average is smaller than usual. So for us, there are lots of epic size 19 valve implanted in our population. So with time, they get progressively degenerated, and we saw increasing gradient, and we have to deal with that in the future. So the first case I want to show is a patient with a Sorin soprano valve, size 20, implanted 6 years ago. This patient has gone through a magnetic aortic valve implant 24 years ago, and followed by this redo. And now it's the 3rd time the patient to go for a consideration for redo procedure. So definitely in the era of TAVI, then we will consider TAVI valve in valve for this failed bowel prosthesis. You can see the leaflets, they're really like sticking together and with a very small residual lumen. And then this is the echo showing that how tight the aortic valve is. And from the apps, it's really useful and rely 100% on this app. So this is a soprano valve of size 20, And the characteristics of this valve, you can see it's lucky that the stent internal diameter is exactly 20. So it gives us more room for a little bit slightly bigger valve to put in. And according to the app reference, we'll put a 23 valve. And the guide we learned from the apps is the way to put in. So the problem in this case is there's a low coronary height on the left side of 4.5 millimeter. There are lots of discussion whether we should fracture the valve beforehand because there's high risk of obstruction. But the good thing for the soprano valve is some kind of valve like APIC is a standard valve. So the leaflets are inside the frame. And we also rely on this distance between the prosthesis and the coronary ostium, because in theory, in the branch testing, when you fracture the valve, it opens around 3 millimeter to 4 millimeter larger than the original size. So if we think it may be possible to fracture this valve with this distance of about 7 millimeter. So so the procedure is straightforward, but the problem is the low coronary height here. And before doing the fracture procedure, we go back to the branch testing reference, but unfortunately, we cannot find the branch testing on this soprano valve. But at least this is not the kind of valve which is not breakable. For example, the trifecta valve or the Medtronic Hancock valve. From the bench testing, usually the pressure go up to 12 ATM or 18 ATM to fracture the valve. And the balloon usually used will be the true balloon or the Atlas gold balloon. So this is a picture showing that the aim is to fracture this polymer ring. Most of the time, the sewing cuff remain intact. So this picture is just to illustrate by cutting away the sewing cuff. So mainly we will break the inner component of the valve without like making the valve damage in pieces. So this is the setting we do. We do 2 inflators, the kind of Edwards inflators that we use, because we need a pressure gauge here to guide the pressure that we are going to go towards to. But the problem is the inflator comes with a pressure gauge, do not carry too many volumes. So we need 2. So either you have 1 additional syringe here to give you extra volume in first, and then you push this in and use a high pressure freeway, and then you turn it, and then you continue with your inflation with your ordinary inflator, or like us, because we have too many of these inflators on a shelf, so we use 2 because it's very easily to push. But we need 2 hands, so we need we use the true balloon, 2 inflators, and so the first part is to implant the valve first. So the other way is to break the valve first, but the way we do is to implant the valve first. So you can see with a 23 valve in a soprano 20, you can see the waist here, and the gradient is the mean gradient is 7. So you can argue that we can stop the procedure here, but in this case we try to carry on with the fracture of the valve. So we use the true balloon, the 22 balloon. So the way to choose the balloon is usually 1 millimeter more than the labeled the valve size, or the 1 millimeter more than the inner diameter. So we use a 22 in this soprano 20. So you can see that we have a coronary protection here with a wire, because we're still worried about coronary obstructions. Although we feel that the chance is less likely in this setting, so we have good coronary wire protection. So going back to this balloon, there's something interesting here. First of all, in the first start of inflation, you can see this is the first, using the first inflator. So when you turn the stopcock, it deflates a little bit, and then we push in the second one, and then inflate. And keep on the pressure going up to 14, and then gradually goes up to 24. And you can see it gradually open up. You can see it become broader, and then the waist a little bit going away. We have a balloon rupture here, actually. So this is dangerous. But of a true balloon, usually it comes out quite easy when, even if it is fractured. But so with a very high pressure, then we have this balloon rupture. So this is after the implant, and this is aortogram, which is quite nice with an optimal expansion of the of the valve inside the fractured original bioprosthesis without coronary obstruction. And you can see this distance is quite nice. It's actually protect against coronary obstruction. So we'll try to see where we break. So you can see there a little gap here. We guess this may be the point where the polymer component of the original stent frame were cracked. So the pressure dropped from 7 to 4, and the result is very nice. And the patient clinical outcome is very good. And this is before the cracking the valve, and this is after. You can see it become wider with improvement in gradient. So this is a case in which we put in a 23 valve in a 20 millimeter Sorin soprano, and with balloon fracture with a barred true balloon up to 24 ATM. So the second case is the EPIC 19. So this is more we've seen day in, day out. EPIC, even if it's labeled as 19, the inner diameter is only 17. So if you put in an extra valve in, first of all, you have to use a 20 millimeter valve, in which even if it is a native TAVR valve, if you put a 20, you see quite a little bit high residual gradient. And secondly, if you put in annular size of inner diameter of 17, then the constraint will be quite significant and give you extra high pressure. So first, we implant the 20 millimeter valve according to ABS into this EPIC 19. And you can see usually this procedure is very relaxed, but problem is you can see the waist here. We want to further optimize expansion. So we use a 20 millimeter balloon. So the size is EPIC 19, so we add one, you use a 20 millimeter true balloon. And so this is the procedure when we crack the valve. So you can see the waist, there's an indentation here because of the fact that the original stent frame limit the expansion, and it gradually goes away. So you can see it become wider and wider. And this time we do not have the balloon rupture, but so we can see once again, but you can still see the waist even we crack the balloon, because it you can see once again. So this is the original indentation, and with the balloon keeping going up from 10, 12, 13, 14, and 18, it suddenly gives way, and there's some point of breakage here, and the balloon can optimize in terms of expansion. But you can still see its waist here, and this is still a 20 millimeter Sapien S3. So we try to add extra volume to expand it, to try to improve long-term outcome in terms of decreasing gradient. So we use the same delivery balloon that comes with the 20 millimeter delivery system, and add extra 2 mil volume inside to try to overstress the annulus a little bit. And you can see there's some improvement in this indentation. We try to open, especially in a 20 millimeter valve, as much as possible. And so this is the final result. Is quite nice. So so these are just case sharing. I still don't know whether fracturing valve is good or not, but at least in these 2 patients out of our cohort, they do well and without major complications. And a lot of questions and then a lot of different ways to do it. So the major questions include, should we fracture the valve before you put in the TAVR prosthesis, or you should put in the TAVR valve first and then you crack the valve together with the new TAVR valve. The type of balloon to use, because we want to use non-compliant balloon, the chance to have balloons that are very tight and less chance of rupture. But no balloon would be ideal, because even if you use the true balloon, it ruptures at that point. Size of the balloon, I think, is controversial, but in summary, you can use 1 extra millimeter more than the size of either the labeled stent size or the inner diameter. So the valve selection for a TAVR is also a good thing to discuss, because overall you want to lower the gradient. So there's a suggestion you may want to put in a supraannular valve after you crack the original valve to further optimize the outcome or long-term results. So thank you very much for listening to the sharing, and we'd like to learn from experts with you and also all the experts around the world. Thank you.
Okay, thank you very much, Dr. Lan's very interesting case presentation. So we have about 2 to 3 minutes of small discussion, then we will move to operation room. So Dr. Lee, do you have any comment regarding this case?
Professor Lam, we have a short question because you do Edward balloon after the cracking. How do you think about it will open more? Because in my idea that the high pressure balloon just open the valve, have already opened the valve. Why do you think about another semi-compliant balloon will open the valve more?
Thank you very much for your question. So yes, this is for the second case. First, we put in a 20 millimeter Sapien S3 inside, and then we use the 20 millimeter balloon to crack the valve. And so the final touch of the valve is to give extra volume to try to see if it can further expand a little bit. So understand that your question, we don't know whether it can help, but visually it helps a little bit by further expanding the valve. So this is only for us, we only do it for our 20 millimeter valve because we really want it to be optimally expand. From the angiogram, there's some waste there, and if it's optimally opened, even a 20 millimeter valve, they have residual gradient. So we try not to leave any indentation there. So this is a reason why we put in the same balloon, but adding extra volume.
Yes, thank you. That's operation room is ready, so that we move to operation room later. We come back for discussion more about valve procedure. And hi, Professor Yin and Professor Lee. Yeah, do you hear the room? Please say hello. Professor Yin.
We can hear from you. Yeah.
Yeah. So let me introduce the operation team. That's Professor Yin and Professor Chao.
看镜头在那边，曹主任那边，这那个。
And Professor Lee and the key operator is Professor Lee Guozhen, and he was quite familiar about mitral valve. And please show the slide, please. Next. And this 69 years old female, he got dyspnea on exertion, leg edema for 6 months, and the situation went worse. Just a few months ago, he received gynecological cancer removal, so she did not want to receive another procedure for the open heart surgery. And she received mitral valve replacement with SEMJU, or Bioco EPIC 29 millimeter in 2003, and the stent ID was 27 and the true ID was 25. The stent height is 19. Echocardiography show later that we will show the transthoracic echo is a severe mitral regurgitation and the mitral stenosis. And here we show the LV function is good and the aortic valve is okay, and the Alain in mitral valve show the stenosis and the regurgitation. So the right side function is okay, and the much regurgitation, the area of the mitral valve is 0.5, and the peritoneal gradient is 36/16.
Okay.
So could you play? We already make the right thoracotomy for this patient. Before we make the thoracotomy, we can estimate the which intercostal space we should enter. So we can measure from the pre-op the CT measurement, or we can on-site with the echo probe to check the intercostal space, which one will be more directly and close to the apex. So based on the patient's CT and the echo, we choose the fifth intercostal space to make the thoracotomy. So can we plate the thoracotomy we done already? Actually, we make the tiny incision about 5 centimeters in length. Then we divide layer by layer. Please go faster. Okay, anyway, we divide layer by layer, especially in female woman. We should avoid some damage about her breast tissue. So then we enter the thoracic cage. Actually, the patient already received operation about 15 years ago. So we believe the adhesion about the pericardium and the myocardium is not so bad. So when we enter the thoracic cage, we will put a tissue protector for the patient. If the tissue protector can well expose the patient's the apex, then we just use the tissue protector to expose the apex. Once the tissue protector, some patient is very strong, the intercostal base is not so easy to open. Then instead of tissue protector, we also use the mini spreader to expose the apex. So in this patient, for demonstration, we use both tissue protector and also lung spreader. Could you play first faster? Okay, anyway, when we expose the apex, we will use the needle saline injection test to let the echo man to find whether there is some echo contrast in the LV, then make sure we can guide us which one is the best approach for the percussion suture for the apex access. So we can see the air bubble, some saline, you can see it's echo contrast in the left ventricle. Okay, I think that's already we already done. So now we that's our echo man, Dr. Xu Meng, to show the patient's echocardiogram for audience.
All right, Mr. Chairman, ladies and gentlemen. Now this is the T transesophageal echo we just did about an hour ago before the operation. As you can see now, this is the fortunate view. The patient has a pretty good left ventricle and the right ventricle function. Now we're going to the long axis view. As you can see, this is the aortic valve, and this is the mitral valve, and the tissue valve is thickened and it doesn't open properly. Now let's turn the colors on. You can see here large amount, at least a very significant mitral regurgitation that goes through the prosthetic tissue valve, goes through it. Now also the mosaic pattern in the left ventricle does indicate that pretty significant mitral stenosis too. This is the Doppler we put on the pulmonary vein. As you can see, there's some backward flow in the pulmonary vein. Also, you don't see the S wave at all. Let's go to the next one. This is a gradient across the mitral valve. And the peak gradient is 27, and the mean gradient is about 10 millimeters of mercury. Okay, next. This we just recorded. This is the en face view of the mitral valve. As you can see, the mitral valve is pretty thickened, and also that it doesn't open properly. The aortic valve is right here. Left atrial appendage is right here. Next one. And this one, we put the 3D color. As you can see, this is a pretty significant mitral regurgitation. And also, this is the surgical view. On top is the aortic valve. This is the mitral regurgitation. Now, I think the last one, we're going to use the true view to show you everybody worry about left ventricle, any chance about the ventricle obstructions. As you can see, this we look through the left ventricles. As you can see, the aortic valves right here. In the mitral valves right here, you can see the 3 straws. And the LVOT is open pretty widely, so I don't think there will be any problems for our experienced surgeons. And the tricuspid valves on the next slide. I think this is the echo report. Thank you very much.
Okay, after made the perfusion of the patient, and we make sure there's no massive bleeding, then we inject the heparin already. So now we will do a puncture over the apex. So this is the 18 gauge needle here. Okay, we put 6 French wire, fluoro please. We will try to use the wire through the mitral prosthesis. If there is some difficult, okay, the T can show us whether we already enter the left atrium already. Dr. Xiong? Yes. Okay. So now we will put the 6 French sheaths. Because the sheath and the dilator length is long enough, so we always can use the sheath and dilator through the apex into the patient's left atrium. Fluoro, please. Fluoro. Okay. Okay, we can see the dilator already entered the left atrium. Now we keep the dilator and sheath in place and retrieve the wire. Okay. Then the safari, the size of the safari wire is extra small. From our experience, extra small wire is best than other size of the wire because even the patient's left atrium is very big because if the loop is too big, may interfere the coaxiality of the procedure. So we choose the, okay. Is sheath already? Okay, now we take the 6 French sheath and the dilator out of the apex and keep the wire in place. So you can see the coaxis is quite good.
Yeah, Professor Yin.
You can see the, yep.
Participant, today's plan is because the true IT is 25. Do you think what kind of valve will you use today? The valve size.
Actually, Dr. You can comment about this
because we did not report our plan, so that's just bark before. Today, we have discussed.
We just do the procedure, and you can add some comment concomitantly. So we just focus on the operation. Okay.
So today's plan is we tend to use the 26 stepping 3 and overfill 3 more and inflate the balloon. However, we discussed before that you can use the 29. Later, we can ask Vinnie about when using borderline cases, larger is better or smaller one is better. And because this is neo LVOT is around 110, so that we try to use smaller valve and overfilling the balloon. And now there was S3 is good because just before we try a lot of ST, and ST need more room for the assembling the valve. However, the current generation of S3 we did not.
You can see the sheath in place. So now we will use the loader to load the S3 into the sheath. You can see here is the loader. So there is some resistance here, but anyway, it's safe. You can hear a sound or click here. Yes, already. Now we'll put the device a little bit further. Keep the wire and watch the wire in place. Okay, so now here is the deairing button here. We'll push the button. Okay, to make sure the theory was complete. Then we send the device further. Here we have some resistance here. Hold the right. Okay, it's good. So must make sure the balloon was in the center of the device. Sometimes there is some resistance and squash, and we hold the with migration of the device. There will be some problem once the balloon was not in the center of the device. Okay, we have to demake, please. We have to make sure that sheath is out of the device. Okay, yeah. So because the apical valve, the marker is not so clear, so we have to make sure.
So you just do the normal implant height or just a little bit deep into the left atrium?
We were a little bit into the left atrium a little bit.
I think if you're going to use the 26, it's going to shorten completely. So it's important to make sure that it's not too much into the ventricle. This looks like a very good position. Once you pace, I think you can adjust it 1 millimeter, 2 millimeter, and then if you are happy, you should deploy. If you are using 29, then we are more.
Yeah. So how about a little bit, Adrian? Okay, I push the device a little bit.
That looks very good. So.
Yeah. Thank you for your suggestion. Okay. We test run. We take a test run. Patient on. Patient off.
Please see the Vinnie. We do not need to see the hemodynamic. Please. Vinnie, please.
Okay. It's a test. So we will deploy the valve.
Deploy the valve.
Yeah.
Okay, please. Pacing on.
Pacing on.
Okay. Hold. 不上不下，让它松一点，不要推了，让它 ventricle 一点，让它 ventricle 一点。
Slightly.
好，顶着。1, 2, 3, 4, 5.
Okay, deep breath. We inflate again.
好 ，pacing off.
So was this a size 29?
It's 26.
26. Plus overfill 3 mil.
We inflate the balloon again, and draw the balloon a little bit ventricle side.
Okay.
这个注意一下哦。
This is a very nice position.
有歪拉一点，然后我们再 ventricle 一点点再打一次。
We do not need the hemodynamic peripheral.
有，一直都在。
Fluoroscope. Hemodynamic, please.
71, 80.
Okay, again.
不要切 hemodynamic 看了。
Okay.
不要了，我们这把它打大就好了。
Info order.
可以了吗
？Pacing on.
Okay, pacing on.
Okay. Pacing off. Demake. We will retrieve the wire and the device.
可以了，来踩。
孕妇踩。
Okay.
孕妇踩。Okay.
We pull back the device.
外一起拉，外拉，对。等我一下哦。Okay. Careful. Okay.
Let's come up.
T 可以看一下吗
Okay, please see the T. Dr. Xiong?
Yes.
Yes, please.
Now let's look lungs is filled without color. As you can see, the new valve was put in, and the Savine 3. And also you can see the leaflet moves very well. Let me turn the colors on. As you can see, this is a normal mosaic pattern. It's almost like a laminar flow in the LV. And I don't see any mitral regurgitation at all. I think this is an excellent procedure. But let me turn on the hemodynamic. Let's see the gradient across the mitral valve. There's almost nothing there. And the peak gradient is only about 8 now. So now let's see maybe see any sign of pulmonary vein.
I think it will be useful to see LVOT gradient as well.
Yeah. Okay, let me see the pulmonary vein.
LVOT.
Oh, LVOT?
Yeah.
Oh, sure.
But I think you can see very nicely that we, even with a 26, and that's our policy now, that if the true ID is 25, we tend to go with 26 millimeter valve, and we put 2 cc extra to start with if needed. And that has really given us good conical, implant and no unnecessary oversizing. So we have done that now in many cases.
So we need you told me that we always need a conical shape. And in this shape, there's a get a good hemodynamic or just for embolization prevention?
It's mainly for embolization prevention, because in the XT cases, we found that some valve will embolize even after 3 months. So we found that there were a lot of delayed embolization. So I think hemodynamics also become better because the commissures, instead of being straight, they're like this. So as you know that some of the valve design, in fact, Evolutar is a good example where the bottom of the leaflet and the commissure is actually like this. So it gives you a better opening when it opens. So I think the same thing happens in any valve really, and including balloon expandable. If you expand it undersized like this or flare, you're going to get less gradient as well.
Another problem is, my question is, we usually use the transapical because our team is familiar about the transapical access. And what is your opinion, transfemoral vein or transapical?
So we haven't done a transapical for a very long time now, and we do this transeptal nowadays. It's a very easy procedure now. It's become very standardized. You have to be careful about positioning because the valve's already tilted. So you have to just make sure your septal puncture is not too high because the wire can back up, and make sure that just go slowly to make it centralizes very nicely. And I think David and Simon can comment on that as well.
So yes, it would be our practice to do transeptally as well. But having said all that, that was a beautiful demonstration. And certainly when we do transeptals, it takes a lot longer than the operators have taken. And it is sweaty. And as Vinnie says, the position of the septal puncture is crucial. You can turn a very straightforward procedure into something that's almost undoable if you go too high. But yes, so we are comfortable doing these procedures transeptally under general anesthetic, although we talk about doing it with doing the puncture with ice. We haven't done it yet.
Dr. Cheung, do you show LVOT pressure gradient and the neo LVOT, because we are really interested about after valve implantation and the pressure gradient?
Yes, this is the, okay. All right, this is the pressure gradient I'm going to show you. I just got it. This is only about 5 millimeters of macris from LVOT, and also laminar flow in the aortas. There's no obstructions at all. So it's a good operation. So the valve was put in the very good position. There's no obstruction of LVOT.
Usually the risk is less in the pig valve, but the first ever case is demonstrated with alveolar obstruction was my case at London Valve. We had done 6 years ago, 7 years ago. And then 6 months later, she came back with massive alveolar obstruction. It was a mosaic valve. So I think we look at the CT scan now and plan it before for the new alveolar.
Dr. Cheung, do you make some opinion about how to make a good measurement of LVOT pressure gradient? Because I see a lot of hospitals cannot achieve a good pressure gradient measurement.
Oh, the LVOT gradient, normally, for this kind of procedures, we go to the transgastric views. And the transgastric view, you can get a parallel the flow to the aortic valve and also the left ventricle's outflow tract. As you can see, because of the color was blocked by the prosthetic mitral valve, aortic valve, mitral valve. So I don't see it nicely, but you can see the color. The aorta is right here, and the LA is right here. The prosthetic valve is right here. So you can see the colors right there. So if I use the colors, and then the guided and the continuous wave, so you can see that the gradients not much at all. It's just like only here, it's 5 maximum, the peak, the gradients. So this is the best view to get the LVOT obstructions. So this is the transgastric views. So LA is right here, left ventricle right here, LVOT is right there. This is the mitral valve, aortic valves right here, aorta's right here. This is the best view to get it. Thank you.
While you are talking, we have already finished the procedure, and Dr. Lee has already crossed the transapical wound. Yeah. So thank you very much for your attention. Yeah. You can keep going on discussion, and we can finish the whole things.
Can I ask you one question? It's a beautiful demonstration. Patient is in sinus rhythm. And
yes, yes.
Are you planning to anticoagulate this patient for 3 months at least?
Actually,
we will do that.
Any coagulant, if the patient tolerant, and just keep INR 1.5 or 2, because we have a case. The patient is under hemodialysis, and after we stop operating, the pressure gradient increase, as we need to reopen the valve. So that if the patient can tolerate, we just keep a low dose operating to prevention the valve thrombosis. And we did not have any other emboli from the brain emboli or other emboli event, and just for prevent the valve thrombosis. What's your opinion about the valve procedure?
So I feel very strongly that if there is no possible contraindication, for at least 3 months, we should give anticoagulation, because you can see that, this is still slightly underinflated valve. So, and we have seen higher incidence of valve thrombosis in mitral valve involved. So it's very uncommon in Western world to see a patient not in atrial fibrillation, to be very honest. But this is why I pointed that this is a dilemma. It's a sinus rhythm. And, some surgeons of older generation, they will argue that all tissue valves should have 3-month anticoagulation. So I think I have changed my practice now. I give 3-month anticoagulation with INR of 2. And then I stop, depending on if patient is in sinus, then we don't give it.
Okay, because time is limited, so thank you very much for all the moderators and the audience joining this section. So I have to close this session, and we will move to the next section regarding a hot topic in TAVR. Thank you very much. Thank you very much for your joining. Thank you.
Thank you.
And thank you very much, and good night.
Bye-bye.
So as we start this section because the Professor Chow will came here later. He's in operation room and he will arrive 1 minute later. And today our hot topic was in TAVR. And let me introduce Professor Michael Lee. And Michael Lee, please introduce the panelist in the section. So do you hear me, Michael?
Yes.
Yeah.
Yes, I can.
Okay.
I can.
And we have Kyoung Chang from Korea and Vincent Luke from Hong Kong, and Jimmy is from Singapore, and Mao Xin Lin is Taiwan, and Edgar and Minky Hong from Korea, and Daniel from Hong Kong, and Toru, are you there? And Toru from Japan. Okay. So that's we start this section.
Okay.
So the first topic is cerebral protection of the in TAVR, and Michael Lee was well known structural heart doctor in Asia, and he do a lot of cerebral protection, and we invited him to give us the review and his experience about cerebral protection in TAVR. Michael, please.
Yes, thank you. Let me share my screen first. Okay, can you see my screen?
Yeah, yes.
Okay, good. So thank you for the kind invitation. I think it's very good for us to gather together at this critical moment. And still, we are doing this TAVR valve summit at this particular time. I think it is very memorable. So my task today is talk to you about cerebral protection devices and the evidence during our TAVR procedure. No conflict of interest. Let me start with a patient, a very young patient, 54 years old gentleman only. He has got benign thymic tumor at very young age, 14. And at that time, surgery was performed, which was followed by post-operative radiotherapy. I think that's the crux of the problem. He's got radiotherapy at very young age. And then with time, he's got hypertension, slow AF with a pacemaker implanted. And then he noticed to have a severe aortic stenosis many years ago, actually, with symptomatic, with decreased exercise tolerance. And in October 2010, actually, he was referred to the surgeon, and the surgeon planned to perform aortic valve replacement. They opened him up, but then they found extensive fibrosis and thickening along the aorta, probably because of the previous radiotherapy. And then surgery was aborted. And subsequently, he was managed medically, and later on, he got more and more severe aortic stenosis with worse and worse symptoms, and then recurrently admitted because of heart failure and pleural effusion. So we discussed this patient in our heart team, although young patient, but he was a surgical turn-down case. And we performed CT scan for the patient and found this porcelain aorta, as you can see here, is a sort of a circumferential calcium along the whole ascending aorta, even at the sinotubular junction. Luckily, the coronaries are very, very high, so there's no risk of coronary obstruction at all. And he was actually a bicuspid valve patient. So with such young patient, porcelain aorta, calcified aortic valve, we have to try our best to minimize the complications. At that time, it was 2016 actually. At that time, we still don't have any protection devices in Asia. So that's the time that we talked to, at that time we have the Claret company. We talked to them about this Sentinel cerebral protection system bringing to Hong Kong and help us to perform a TAVR procedure safely in this particular patient. And finally, they agreed. So this was the device that we used. This is a Sentinel cerebral protection system with two filter system, one proximal filter at the innominate or the brachiocephalic artery and the distal filter in the left carotid artery. It's sort of one size fits all, and at the end is not going to interact with any of the devices along the aortic arch. It is a 6-French compatible system, goes through the right radial artery. So this was the day that we performed the TAVR procedure with the first use of this device in Asia. Actually, before that, we sort of make a 3D model of the patient's aorta and then try the procedure outside the body. And then we perform our procedure as planned. So this was the Sentinel device going through the right radial artery. We are deploying the first filter in the brachiocephalic artery, and then the device was pulled back a little bit, and then you can actually curve the tip of the device and put in a coronary 0.014 guide wire to the left carotid, and then push the second or the distal filter into the carotid, and then secure it in the So this is how we've done the protection system, prepared the system, and then we went on with our TAVR procedure. We put in the Absolute Pro 29 millimeter, a big valve, big annulus, and finally end up with a very mild paravalvular leakage. Withdrawal, retrieval of the device is again very simple. You just reverse the order, retrieve the distal filter first, push the catheter forward a bit, release the top, release the curve, and then pull back the proximal filter, and then the whole system can be pulled back out of the right radial artery. So very, very simple procedure. But look at what we can capture here. This was the debris that we could capture from our patient. And the procedure itself, it was not complicated. It took us only 3.5 minutes to perform our first procedure. So very simple to use. I would say for even up to now, stroke is still a very devastating complication of the TAVR procedure. And if you look at the various procedures done with interventional cardiologists, TAVR probably will end up with a lot more MRI evidenced brain lesions. And if you look at the different trials involving different devices, and if we even move to intermediate and low risk patients, you see this very consistent instance of stroke post-TAVR. It's between 2 to 5%. There's not really much improvement, even with the improvement in the devices, even we move to lower risk patients. Because this is unlike other complications, which were the complication will decrease with the number of cases that you do. High volume centers, you see decrease in mortality, vascular complications, bleeding complications, but not stroke. If you look at stroke, it's actually still very high, even in high volume centers. And we also know that for patients who develop stroke, they will have a much worse outcome. They will have a 4 to 6-fold increase in mortality after the development of stroke. And what we are seeing as the major or disabling stroke is just the tip of the iceberg. There are a number of patients with neurocognitive design, silent cerebral infarct that we cannot recognize, but this will end up with a lot of morbidity as well in the future for the patients. That's why protection devices are actually needed to prevent these sort of complications, especially when we move to younger patients and lower risk patients. These are the available protection system here, and the most evidence would be with the Sentinel device and the TriGuard system. If you look at the Sentinel IDE trial, within 3 days of the TAVR procedure, there was a significant 63% reduction in terms of the primary endpoint of stroke and stroke reduction. So it's actually very alarming for us to see this figure once we use the protection system. And this has been actually mirrored, substantiated by a number of single center studies. And this is one of the studies in the own study that they can show a 70% reduction in all stroke as well as all-cause mortality and all stroke about a week after the procedure. They've also tried to identify the predictors of this stroke. But unfortunately, the only predictor they can identify is when they are not using this cerebral protection system. So no other factors are not really significant enough. If you look at the safety of the Sentinel system, you see very, very little complications. Basically, the Sentinel device is actually very, very safe to use with very, very few device-related complications. And most of the time, I would say 98, 99% of the time, you will catch something. It differs from thrombus to calcium to fibrous material, even valve material that you can capture. The TriGuard system also shown a very significant reduction in the ischemic lesions as evidenced by MRI. If you use the TriGuard as compared with those who do not use the TriGuard system in the deflect-free trial. And in the after discharge, in the long run, there was more than twofold recovery of cognitive function with the TriGuard system as compared to controls at 1 month. So if you look at the meta-analysis of the different devices available, it has consistently shown that about 40% reduction in the risk of stroke or death when we use this cerebral protection system as compared to the controls of not using this. In our series, the stroke rate is not really that high, 2.3%. It's reasonably compared to all the other registries as compared to our Asian data. But when we are facing younger, lower risk patients, we want to do better. So we have been systemically use this cerebral protection device, the Sentinel system, from our first case, 2016 to now. We've done 113 so far. This is a sort of self-pay device by the patient. As far as the patient can afford to use the device, we will recommend the patient to use the device. So these are the patients that we've used. And we also use the device in 2 of our LAAO procedures. A very high success rate, 98%. We don't see any complications, except there is a 0.9% stroke, even though we use this device. So this was, there was a significant decline from 2.3% to 0.9% with the use of this device. So this is what we are very gratifying. And a lot of studies have tried to see what are the predictors of procedural stroke and late stroke. There are a number of suggested factors, like the patient factors. Patient may be having a high TAVR score, peripheral vascular disease, elderly patients, or if the procedure is long, we use a lot of rapid pacing, a lot of manipulation, retrieval of the valve, or post-dilatation. All these have been implicated as risk factors of stroke development, but none really have shown to be really related to, or if we can shorten the procedure time, for example, we can actually prevent the stroke. So this is something that we have to bear in mind. There's still no single predictors identified so far. So in the current era of our TAVI procedure, we are now aiming at 1% inpatient mortality, 2% stroke, and 3% vascular complications. We are trying to use minimalist TAVI approach, conscious sedation, or even LA, and then next day discharge. I think the instance of stroke in these younger, lower risk patients must be reduced in order to substantiate our improved TAVI outcomes. So to summarize, stroke is still, I think, a devastating complication of TAVI procedure. No definite predictors of stroke has been identified so far. The cerebral protection system is easy and is safe to use. And this system might reduce the incidence of stroke and ensure a safer procedure, especially when we move to younger and lower risk TAVI patients. This is all I have to present. Thank you very much for your time.
Thank you, Michael. As because of time limit, we need to move to the next lecture, and the next is Edgar Tai from the National University Singapore, and he will give a talk about updates in studies in TAVR. And please, Edgar. Edgar, please open the microphone. Thank you. Edgar.
Can you hear me?
Yeah. Thank you.
Okay, great. Okay, so I'm going to give a quick update on the studies that are relevant to TAVI over the last couple of months, because we have very little meetings that we could chat. And so there's quite a few pieces of information that has come up over the last few months. And I think I'll summarize it by saying that we can look at these study types. So one of them will be a follow-up of landmark trials, sort of clinical research as related to indications, procedures, complications, as well as comparison between valve types. So I'm just going to talk a little bit about a follow-up of landmark trials. There are really two important trials. One is the intermediate risk cohort that's being followed up to 5 years. There's a partner 2, and also some updates on the SIR-TAVI trial, as well as low-risk trials, the SAPIEN 3 trials followed up to 2 years, as well as the echo parameters. So for the partner 2 5 years study, we can see that up to about 5 years, there's really no difference between patients who undertook TAVR versus surgery, but there is a little bit more of a paravalvular leak in the TAVR compared to surgical arm. If you look at the outcomes up to 5 years, if there is paravalvular leak in this intermediate cohort risk of patients, those with moderate or severe PVR are the only ones that have impact on mortality. And the other valve parameters are actually quite normal. The SIR-TAVI 2-year trial actually looked at the intermediate risk cohort of the self-expanding valve. And at 2 years, again, there is no difference between the trials. Sorry, I think there's something wrong with my slide. Hang on. Not sure why it's playing like this. Okay, I'm just going to control it from here so it doesn't flip. So the partner 3 2-year follow-up trial, this is really important. This is actually a low-risk cohort patient. Remember, it's actually patients at transfemoral TAVI comparing surgery versus TF TAVI, and it's randomized 1-to-1 to TAVR versus surgery. And this was followed up annually, and this is reporting the 2 years follow-up. So about 950 patients were followed up all together for 2 years, and the follow-up was very complete. So you actually had good analysis of the results at 2 years. So remember, we presented the data when it first came out. It was very exciting. It showed a very large difference between TAVR and SAVR, and this was really in favor of TAVR, showing significant improvement in the outcomes of death, stroke, or rehospitalization. And this primary endpoint actually was maintained in this 2 years follow-up study between TAVR and SAVR. But what is important is really to look at the individual endpoints in this low-risk cohort. So if you look at the surgical cohort, the death rates seem to be plateaued, 2.5 and then 3.2 at 2 years. In the TAVR group, it was 1% at 12 months, and then at 24 months, 2.4%. So you see a little bit of a narrowing of the curves. This was a little bit of a point that was picked up by some of the investigators, as well as people who has been criticizing this and reviewing the study. So there's a bit of a narrowing of the curve at 2 years. And if you look at the causes of death, really the causes of death are pretty random. If you look at the actual amount of cardiac death, actually there's not much difference between TAVR and SAVR. Stroke-wise, there is really, again, a bit of a narrowing of curve, significant at 1 year, but no more significance at the 2-year outcome. So a little bit of a narrowing of stroke outcomes as well. If you look at the composite of death and disabling stroke, as you see, again, a bit of a narrowing of the curves, but this is not statistically significant. And the real driving point is that rehospitalization rates remain low in the TAVR arm compared to the SAVR arm at 2 years. And so this is really the one that drives the composite outcome at 2 years. What's important is also to look at the secondary endpoints. If you look at the TAVR versus SAVR group, one of the points that was picked up is really the valve thrombosis rate. There was a little bit more valve thrombosis seen in the TAVR arm compared to SAVR. And if you look at this, in this particular study of about 1,000 patients, 13 patients in TAVR had valve thrombosis compared to 3 patients in surgery, and that was statistically significant at 0.02. So this is something that we need to watch out for as we follow up these patients. And these valve thrombosis rate could result in some kind of clinical outcomes, although this study obviously was not meant to analyze this, but it did look like some patients who had valve thrombosis could be associated with a clinical event. And most of these were cerebral events, which was quite consistent with some of the other earlier data on valve thrombosis. Pibaro is one of the colleagues that actually did this study to look at the echocardiographic outcomes after TAVR versus SAVR in this low-risk balloon expandable cohort. And again, the same signal, mild paravalvular leak is still more common in TAVI arm compared to SAVR. And we also noted that what was important is that RV function was interestingly preserved in patients who underwent TAVR compared to those who underwent surgery. And this is probably because of the technique of surgery where there is sometimes an incomplete protection of the RV during cardioplegia. So that's the possible mechanism of these findings. The next set of studies really is to look at comparisons between comparisons between the TAVI arm, whether self-expandable valves versus balloon expandable valves were going to be any different in this current times. And so this is called the SOLVE study. This is an interesting study with about 450 patients randomized to either undergoing a self-expanding valve. Most of these would be, of course, the SAPIEN 3 valve, and then the other group would be the AViV R. And this is a study that looked at non-inferiority. And to really summarize the primary endpoint, they looked at outcomes such as all-cause mortality, stroke, moderate to severe paravalvular leak, and pacemaker. And this study actually showed that there was no difference or equivalence between the balloon expandable as well as the self-expanding valve in this particular study, although numerically, it seemed that the balloon expandable valve had a slightly increased signal of stroke numerically, while the self-expanding valve had a slightly increased risk of paravalvular leak. This is a little bit different from some of the other studies. For example, the CENTER study, which showed that actually stroke was a little bit higher in the balloon expandable cohorts. Okay, the next group we're going to talk a little bit is about studies that may influence the indications of whom we can treat in future with TAVR. So I'm going to focus a bit on the bicuspid aortic valve group. So as you know, bicuspid aortic valves are actually excluded in most of the previous clinical trials. And this recent set of data is interesting. So you have the AViV low-risk study looking at the bicuspid arm, and this is in patients who have been using AViV R or AViV Pro. In this particular study, they looked at pretty low-risk patients. So they excluded those who are very young, those with multivessel disease, and those who had surgical indications for aortic root replacement. And all those with very severe calcification actually also removed. So basically, they are selecting patients that are very ideal for TAVR in this bicuspid cohort. And the primary endpoint they're looking at is really all-cause mortality or disabling stroke at 30 days. So they essentially looked at about 150 patients where they implanted the AViV system, 50% Pro and 50% the standard AViV R. And in this cohort, a large proportion of them were type 1 bicuspid aortic valves. So 71% of them were bicuspid type 1. And if you look at the primary endpoint of death or disabling stroke, actually the outcomes are pretty decent. So that's about 1.3%. And this is, of course, a very short 30-day post study review. So we need to look at longer endpoints for this bicuspid cohort. And if you look at stroke as well as the other complications, they're actually pretty low. And this also tells you that because we're treating these patients who are usually about a decade earlier, so that reflects also the kind of lower clinical risk profile of these patients. Early on, we talked a little bit about the self-expanding valve using the AViV. This is really a study by Ron Waxman's group in Washington, and this is 61 cases. In this case, more of the patients underwent TAVR in this bicuspid group using the balloon expandable valve. And it look at 30-day outcomes. So it was pretty good, no mortality or stroke. And incidence of more than mild PVR was 1.6%. However, about 10% of patients had a leaflet thickening on CT. This is actually quite consistent also among the tricuspid valve, so not very, very different. In terms of a larger kind of review between tricuspid and bicuspid aortic valves, this is really a nice paper. I encourage you to read it in detail. It's really from the STS ACC registry, and they looked at patients, all the patients in the registry that had bicuspid or tricuspid TAVRs. And of course, it's quite clear that the age of the bicuspid group is younger, about a decade younger. And the outcomes are pretty good. You look at the outcomes on the right, the in-hospital mortality is about 2% for both bicuspid and tricuspid, although I would summarize that the device success rate after TAVR was still higher in the tricuspid group. And PVR was still better in the tricuspid TAVR group, which is quite consistent with our clinical understanding. This is the summary of the one-year outcomes when you compare bicuspid versus tricuspid. So on the left, the bicuspid, which is the blue line, is actually having a lower mortality at 12 months compared to tricuspid. And this could be reflective of really the age impact of the bicuspid cohort. And then this is the stroke outcomes. If you look at the patients who have early strokes, it seemed to suggest that the bicuspid patients may have a slightly increased signal of stroke compared to the tricuspid group. And of course, followed up for 1 year, this wasn't statistically significant. Okay, the next set of studies looking at some interesting things about the TAVI procedure and whether we can change our practice. So this is really looking at whether the question of whether pre-dilatation was important before TAVR. So there was two groups of patients that was randomized. So it was randomized essentially patients who had direct TAVR implantation with a balloon expandable valve versus doing a pre-dilation and then putting in the valve. And about 120 patients in each arm, and they found really no difference whether you pre-dilated these patients or not. It's a very small study, but it does bring up a few points. Firstly, of course, one of the criticism was that in some patients, the operator just before starting the procedure decided that it was too risky not to pre-dilate, and so there was some crossover. And in a small study like this, crossover could be impactful. But what's more important is our fear that BAV can translate into complications such as stroke. It's not so dangerous, so we can actually pre-dilate quite safely if we really need to. So I think this is really the important part of this study. Next, we turn on to complications related to TAVR. So I want to talk a little bit first about leaflet thrombosis. This is a very hot topic. This study really looked at the AViV low-risk sub-study. So they did CTs on most of these patients and looked at the amount of HALT, or hypoattenuated leaflet thickening, as well as the reduced leaflet motion in these AViV cases who are clinically low risk. And if you compare the TAVR and SAVR arm, about 17% of patients in TAVR and 16.5% at 30 days would have some degree of HALT. And this goes a little bit higher even at 1 year, about 30% and 28.4%. And leaflet motion reduction is also seen about 14+% in each arm. So you can see this both in surgery as well as TAVR. So it's not something that is totally just seen in TAVR alone. And this is something that we need to look at more in the long term to see what is the best strategy, whether these need to be intervened upon, or is this just something that we need to observe carefully. The next group of complication studies, which I thought was interesting to all, were looking at complications on the conduction bundle and the clinical impact of things like left bundle branch and a permanent pacemaker. So we know that many patients whom we treat, if we would implant the valve a little lower, or if we had a pre-existing AV nodal dysfunction, they actually can predispose to AV conduction problems. And there is an impact in this large meta-analysis, which showed all-cause mortality, heart failure, as well as the future risk of pacemaker was significantly increased if the patient was left with a new left bundle branch block. So it's not a trivial problem if the patient has a LBBB. And similarly, for patients who ended up with a pacemaker, there is some impact on long-term mortality. Although there wasn't so much effect on cardiac mortality, heart failure was also an impact when patients were implanted with a permanent pacemaker. So it's still very important that we try to achieve the best outcomes in terms of reducing AV nodal dysfunction. Any valves that can, in future, that addresses this would have some advantage for longer for the long-term outcomes of these patients. What about complications such as coronary occlusion? You know, coronary occlusion has been something that we have been discussing for the past few months. It's a pretty hot topic because of the fact that we're treating lower risk patients and the need to protect some of these patients' future coronary access. So this study I thought was interesting. This was really a chimney registry. You know, we do these procedures where we actually put in stents in the left main to protect these patients. And eventually, if there was a coronary occlusion, we put these stents and put the stents from the left main into the aorta. We call it a chimney. And there's a small registry that looked at what happens to these patients. And I'll just summarize that generally the outcomes are very short-term in the follow-up. Patients who had a kind of coronary protection done early on, meaning the chimney was placed before the patient actually had a true left main occlusion, had a much better outcome than those patients who had a chimney put in after the patient had a cardiac arrest or definite occlusion. So this is obvious in the sense the patient would be hemodynamically impacted during this emergency procedure. And in terms of the procedural death itself, you could see that it's actually here about 5%, so it's not a trivial outcome. So this is really we really have to look at whether some of these patients should really go for surgery instead of thinking about putting chimneys into these patients. The long-term outcomes, however, are not there yet, so we need more time to assess what happens to these patients. So that's my sharing of you for today. Really a lot of clinical data, just try to put it in a nutshell, and really I hope to see you soon again in future meetings. Thank you very much.
Thank you, Ekar. That's because we need to catch up our schedule, so we move to next speaker is Kiyuk Chang, and from Korea. That's a place. His talk is on anti-coagulation and anti-platelet TAVR. And I think he have some opinion to us. Chang, do you online?
Just a moment.
Okay.
Can you see my slide there?
Yes, yes, please.
Okay, thank you for inviting me as a speaker. So my topic is anti-thrombotic therapy after TAVR. 2017 ESC guidelines recommended oral anticoagulation may be considered for the first 3 months after surgical aortic valve replacement with bioprosthesis as class 2B and available evidence 3C. This is the only registry data to support this recommendation. 2012 JAMA published the interesting data. So discontinuation warfarin for the during the 3 months after surgical aortic replacement was associated with increased risk of stroke and thromboembolic event and cardiovascular death. So many Korean surgeons favor warfarin for at least 6 months after surgical aortic valve replacement. However, the ESC recommendation on anti-thrombotic therapy after TAVR, like this, dual antiplatelet therapy instead of warfarin should be considered for the first 3 to 6 months after TAVI, followed by lifelong single antiplatelet therapy. However, real post-TAVR patients are sometimes fragile elderly, women with sinus rhythm and small valve. So I always hesitate giving dual antiplatelet therapy, NOAC or warfarin to this kind of fragile women. So I usually prescribe the single antiplatelet therapy, usually clopidogrel, to my elderly fragile patient just after TAVR. Since 2 years ago, I checked for this CT at 3 months after TAVR. These patients is 3 months post-TAVR on clopidogrel showed the reprieve thickening and reduced reprieve motion. So as soon as I found this kind of reprieve thrombosis, I changed medication from clopidogrel to NOAC, and I checked the CT 1 year later. So when I see my post-TAVR patient, I always hesitate which antithrombotic regimen to this patient. So anti-platelet or anticoagulant. So in terms of anti-platelet, dual or single antiplatelet therapy, which is better. But I think individualized approach based on patient and their characteristics, such as high bleeding risk or increasing risk for reprieve thrombosis, seems to be better than one-size-fits-all approach. How is reprieve thrombosis made after TAVR? So the aortic sinus can be divided into two areas, diminished native aortic sinus and neosinus. Neosinus is in between TAVR valve and then TAVR valve leaflet. So this neosinus is the subclinical reprieve thrombosis made only in neosinus, not in native valve sinus. So in vitro flow model using particle image velocimetry have found stagnation of blood in the neosinus is the main mechanism for reprieve thrombosis, and supraannular valve has smaller stagnation zone and shorter resistance in the neosinus. So theoretically, supraannular valve has less reprieve thrombosis. Another important mechanism is abnormal endocellular hyperplasia. This animal experiment using swan model showed stable mature tissue growth at the time point of 9 days post-implant. But near autopsy data, you can find all of the reprieve thrombosis was associated with abnormal endocellular hyperplasia, which mainly happened during between 8 and 30 days. So within 30 days, there is a higher risk of reprieve thrombosis. So this autopsy data showed all explanted transcatheter valve had adherent thrombus on both aortic and ventricular side. And beyond 6 days, this thrombus was associated with fibrosis and beyond 4 years, calcification. So we can assume the reprieve thrombosis associated with induced fibrosis and calcification, and this induced structural valve deterioration. So we detect reprieve thrombosis at this time point. We can stop the progression of a structural valve deterioration due to reprieve thrombosis. Let me show what is real-world incidence and clinical implication of reprieve thrombosis. In 2017, Lancet published the incidence of subclinical thrombosis in large registry, including more than 750. So 13 patients have reprieve thrombosis on CT at around 3 months after TAVR. Dual antiplatelet therapy showed 15% of reprieve thrombosis incidence, and anticoagulant only 4%. As I already mentioned in mechanism section slide, Evolut and supraannular valve has less incidence of reprieve thrombosis than intraannular valve. Continuing DAPT medication showed persistence of reprieve thrombosis, but changing medication into oral anticoagulation, warfarin, and NOAC, all the depressed thrombosis disappeared and restored normal wall motion. However, the subclinical replete thrombosis was not associated with increased risk of old death and MI, but slight increase of ischemic stroke or TIA. Galileo is the first study to test the efficacy and safety of NOAC, rivaroxaban, compared to dual antiplatelet therapy in large number of patients. In contrast to our expectation, the Galileo failed, and then the NOAC, rivaroxaban, did not reduce the composite the outcome of old death, MI, stroke, and valve thrombosis compared to antiplatelet therapy. So this is completely the unexpected finding. Rivaroxaban increased the all-cause death. So the conclusion of Galileo is among patients without established indication for anticoagulation after successful TAVR, rivaroxaban 10 ml plus aspirin was associated with higher risk of death, thromboembolic complication, and higher risk of bleeding than dual antiplatelet therapy. However, they did not test it short-term course of NOAC monotherapy. This is another study subset. How about a single versus dual antiplatelet therapy after TAVR? Better or similar? This is a meta-analysis published in 2016. The dual antiplatelet therapy and single antiplatelet therapy has similar all-cause mortality at 30 days. However, the critical and major bleeding was less in the single antiplatelet therapy group at 30 days. Thus, net clinical endpoint, including all-cause mortality, MI, stroke, and major bleeding at 30 days, was favor single antiplatelet therapy than compared to dual antiplatelet therapy. So 2017 ESC guideline, based on this meta-analysis, they recommended single antiplatelet therapy may be considered after TAVR in the case of a high bleeding risk. So I studied the comparison, the occurrence rate of replete thrombosis according to different antiplatelet regimen. So the patient divided into 3: single, dual, antiplatelet therapy, and NOAC. At 3 months, I checked the 4D CT. And this is not a random study, this is registry data. So single antiplatelet therapy was more frequently female and slightly elder than the other groups. So surprisingly, the single antiplatelet therapy during the first 3 months after TAVR was associated with higher risk of replete thrombosis on CT, 21%, compared to 12.1% in DAPT patient. And NOAC patient does not develop any replete thrombosis on CT. And in all 3 groups, no death and no MI, no stroke, but NOAC group has increased risk of bleeding, so major bleeding, box 3. So my conclusion is the incidence of subclinical replete thrombosis on single antiplatelet therapy after TAVR was nearly twice as many as that of dual antiplatelet therapy. Thus, dual antiplatelet therapy is preferred to single antiplatelet therapy after TAVR for the first 3 months in reducing the incidence of replete thrombosis. A larger study is needed to confirm this finding. In summary, the incidence of replete thrombosis is around 15% in post-TAVR patient receiving anti-platelet therapy. Subclinical leaflet thrombosis seems to have no clinical impact during the 1 or 2 years, except for slightly higher incidence TIA, but it seems to be mechanistically associated with long-term structural valve deterioration, so should be treated. So NOAC monotherapy for the first 3 months will be a good option for post-TAVR patient with a sinus rhythm, but this hypothesis needs to be demonstrated in large trial. After 3 months, there is less risk of leaflet thrombosis because the endocellulation is already formed. So first 3 months NOAC and then single antiplatelet therapy would be a good option for post-TAVR patient. Single antiplatelet therapy should be reserved the post-TAVR patient with only high bleeding risk. Thank you for your attention.
Thank you, Professor Chang. That's I know you are in car, so that's, it's a way of you came here again to visit Taipei. And now we move to next is Myung Ki Hong, and we will share us his experience about how to preserve renal function in CKD patients in TAVR. Please.
Okay, can you hear me?
Yeah, please.
Okay, it is my honor to participate the Taipei Valve Summit this year. My presentation topic is how to preserve renal function in chronic kidney disease patient undergoing TAVR. My disclosure. As we know, the chronic kidney disease is one of the major comorbidity in severe aortic stenosis patient. What is the reported incidence of the chronic disease in a large randomized clinical trial is between 10 to 12%. However, in reality, it's actually the number of the patient with a chronic kidney disease quite high. In the several numbers of the registry report that the incidence more than 37 to up to more 70. The one meta-analysis report that the presence of the baseline chronic kidney disease shows the increased early and 1 year mortality. This is our lab's data. What is the percentage of the chronic kidney disease? It was 45%. Among those patients, what is the incidence of the acute kidney injury? AKI was at 11.9%, quite high percent. This incidence, when we divide two types, in patient without the chronic kidney disease, the incidence of the AKI was 4.1%, maybe some reasonable acceptable. However, in patient with a chronic kidney disease, the incidence of the acute kidney injury was 24%, significantly higher. Actually, we have a lot of the experience of the zero contrast TAVI for this patient. Therefore, this is the first live demonstration. And 3 years ago, the Korean Society of Cardiology meetings, and another live demonstration for the 2 years ago, TCTAP is the zero contrast TAVI. In this patient, was the EGFR was 16, very, very low. Very high risk for the renal shutdown during the procedure, and STS score was 15. In this patient, you can enjoy the full scenario and the story in the YouTube when you type the TCTAP 2018. This is the part of the list of our patient for the zero contrast TAVI. In this patient, there is some bicuspid aortic valve and the porcelain aorta and the others. The preserved the renal function in this patient, the balance between a TAVI procedure versus the amount of the contrast dye is the key point. So therefore, the absence or minimal use of the contrast dye is the key point in this patient. The treatment strategy was depends on the patient level of the function, renal function. when the patient eGFR less than 30, we seriously think about the treatment. TAVI should be a zero contrast TAVI. When the patient eGFR more than 30, is that we will consider the minimal contrast TAVI. At the time is that the total amount of the contrast may be 10 to the 15. When you consider the zero or minimal contrast TAVI, following factor should be considered. At the stage of the screening of the TAVI, first the coronary angiogram, non-contrast or minimal contrast CT, and for the evaluation of the peripheral vessel by the ultrasound, and for the reconstruction of the aortic valve using a transesophageal echo. And at the timing of TAVI, at that day, we do the sono-guided femoral artery puncture and the closure after the TAVI procedure, and the zero or minimal contrast TAVI, and the TE-guided evaluation of the adequate placement of the valve. And usually, I prefer the predilation for the minimal or zero contrast TAVI. And what is the selection of the valve? I prefer the Evolut rather than the Sapien for the zero or minimal contrast TAVI. For the screening of the TAVI 2 weeks ago, we do the angiogram, only 3 cut. For the 1 cut for the right coronary artery, 2 cut for the left, and then confirm there is no significant narrowing in the coronary artery. And using the Doppler, and we also confirmed that what is the severity of the peripheral artery disease in this patient is very minimal, and the vessel size is quite larger in the iliac and the peripheral artery. And the TEE evaluation is quite very, very useful. And using this software and the TEE, and we can measure the annulus status, minimal or maximal perimeter and annular area, also as well as the coronary arterial height from the annulus to the coronary, each coronary artery. And the zero or non-contrast CT is very, very useful. Now, when you look at this image, we cannot 100% accurate measurement. It is impossible. However, roughly we can measure the information. In this patient, was the area was 460 and the perimeter was 77. And we also estimate that the arterial height from the annulus to the each coronary artery. This patient is a right coronary artery for the 11 and the left coronary 9.7%, 7 millimeters. And the information for the TAVI procedure, what is the 3-cusp view for the planar view for the TAVI valve deployment. This information was also from the non-contrast TAVI. Finally, the non-contrast CT, as you see, we can roughly evaluate the status of the descending aorta course and the severity of the calcium. And using that information, we do the TAVI. And when we start the TAVI procedure, sono-guided puncture without the use of the contrast. And after the end of the TAVI, and we also close the peripheral vessel, and finally confirmed by the sono ultrasound. Usually, the predilation is preferred zero or minimal contrast TAVI. The reason why, because we do not use the contrast. It takes us more time during a valve deployment, so we prefer the predilation. And during the deployment of the Evolut valve, we confirmed what is the position of the distal margin of the valve using a TE imaging and confirm and several check it. And if the position is correct, the process seems to be a good position without the interference of the mitral valve position. And there is no significant aortic probable leakage by the TE. And then we will try to deploy it carefully. And this is the fluoroscopic image after the deploy. And roughly we confirmed that there is no significant the narrowing in the evolute valve. And we finally evaluate what is the final result of the valve status with the TEE and confirm the good working of the prosthetic valve without any other structural abnormality. This is our labs data with a patient with a chronic kidney disease. And among those patients, we divide two groups. We do the conventional TAVR with the usual use of amount of the contrast and the zero or minimal contrast TAVR. The patient number is the 53 and the 29. The patient age is early 80. And the eGFR is the 37 in the conventional TAVR, and the zero or minimal contrast is at 32. And in the zero or minimal contrast TAVR, the most of the patient was fixed by self-expandable device, and the SAPIEN was used 4 cases, 4 patients. This is the progression of the chronic kidney disease status in patient with a conventional or zero contrast TAVI. In conventional TAVR group, the AKI was developed 20%. Among those patients, the start the new hemodialysis was 13 patients. What about the in zero or minimal contrast TAVR? In the AKI was developed 13.8%. Among the 29 patients, only 1 patient, 3.4 patients started the hemodialysis. It's a quite different incidence. 13.2% and the 3.4% is the hemodialysis. When you imagine that they start the hemodialysis in the around the 80 is a real tragedy. So we have to try to avoid this kind of situation. We have to do our best to avoid this kind of situation. Ladies and gentlemen, therefore I'd like to conclude that zero or minimal contrast TAVI should be considered in the severe aortic stenosis patient with a chronic disease for renal protection according to the level of individual patient renal function. Thank you for your attention. Thank you.
Yeah, thank you, Dr. Hong, for your excellent talk. You have a very good clinical result to prevent acute kidney injury in chronic kidney disease patients for TAVR. Because we are far behind the schedule, so we will proceed the next speech. Thank you, Dr. Hong. And the next speaker is Dr. Daniel Tai-Leung Chan. Dr. Chan is from Hong Kong. His topic is minimal invasive surgical aortic valve replacement. Dr. Tan, please.
Thank you. Could you hear me?
Yes, we can hear you.
Okay, so I believe you see this screen. So greetings from Hong Kong. I'd like to thank the organizer for inviting me to join this wonderful meeting, and also to put this surgical topic in between the TAVR section. I think this is wise and meaningful. So these are my disclosure. And one important disclosure is that I am a cardiac surgeon, but I love doing TAVI too. So I think this is important. And that's why my cardiologist asked me a question. So do you think that surgical AVR is a dying procedure? So that's why you love TAVI and change your specialty? Well, obviously, my answer should be no, because if you see on the number per se in the recent years from the registry or our local data, you can see that although there's an exponential growth of the TAVI, the number of the SAVR didn't drop or even rise a little bit. Second reason is that I still believe SAVR has advantages over TAVI. So this was covered this morning by Dr. Jian Ye and Dr. Vinnie Bapat by their excellent talk. But some highlights for paravalvular leak is not a concern for surgeons. And also for surgical AVR, the pacemaker rate is much less. So, and everyone knows that these two factors have a direct impact on the long-term outcome of our patients. And also the durability. We have lots of long-term follow-up study for our surgical valves. And usually I would tell my patients that your tissue valve, if you choose, that will probably last around 15 years. But for TAVI valves, I could say that 5 years should be very good, but longer than that, we need more data to support. And there are long discussions about which kind of TAVI valve to choose if you want to do a future PCI. But I can say that among all the prophysis, surgical prophysis have the lowest profile. This is one of the new tissue valve. The average height is only 30 millimeters. So they allow PCI in the future easily. And also all the prophysis have a rigid frame. So in valve would be quite easy. Of course, TAVR can cover wider indications. For those we call the difficult anatomy that patients could exclude from the TAVI, which is no problem for surgeons. And also we can do AI, active endocarditis, emergency situation, and also other associated diseases. Now, having said that, all those benefits of TAVR, here, nobody will argue that this is the era of TAVI. And I'm not saying that TAVR should compete with TAVI. Instead, we should be a team. We complement each other and act as a team to work against aortic valve diseases. And I'd like to share my opinion or my observation on the change of the practice about TAVR in recent years. Now, for our patient group, definitely now becomes younger. We are doing more concomitant procedures, and we are dealing with more difficult anatomy, because this is logical. When it's old and favorable anatomy, all these kind of patients go for TAVI. Having said that, even though our patient group is younger, we observe we have a higher risk patients group, and also more patients choose to use the bioprophysis. This is some local data and some international registries saying that about half of the surgical AVR nowadays needs some concomitant procedures. Most likely is the CAPH, followed by other valve or MACE procedures. And also there's a slowly increase in the overall risk score. Also, about 2/3 of our patients using bioprophysis when doing the surgical AVR. And another big issue is that there is increasing use of a minimally invasive approach in doing surgical AVR. And also, if you see the recent registry report, the surgical AVR mortality and morbidity is pretty low. And I believe the minimal invasive approaches have some effects on that good outcome. So going to the minimal invasive AVR, it has been first described and published by Cleveland Clinic in the early 90s. The percentage of use increased over time. For now, our institutes, about 50% of our surgical AVR performed by minimally invasive approach. Some experienced centers can up to 80% of their TAVR. And for the benefits, there are more than 1,000 studies reporting the results of a minimally invasive AVR already. So these are the proposed benefits for using the minimally invasive approach, like less infection, less transfusion, less pain, and most importantly, we bring our patients faster recovery and back to their normal work early, and also better cosmetics and also better quality of life. And I like to quote this latest meta-analysis, including all 19 comparative studies comparing sternotomy approach to the MIS approach. This is the conclusion. So for the mortality and stroke, it's quite similar in the two groups. This is logical because at the end, we're still doing a cardiopulmonary bypass, a surgical AVR. And the MIS approach takes longer time, but this does not translate to a higher risk. And the MIS approach has a significantly less atrial fibrillation after operation, and the patient stays shorter in the hospital. Now, one of the reasons why the comparative study doesn't give that much of confirm that much of a benefits for the MIS approach is that a lot of different ways to do that. We still call them minimally invasive approach. I broadly divide into 3 categories. One, we call the parasternal approaches. So a vertical right-sided incision and cutting the rib, we can do the surgery and see the aorta here. Another group is a hemisternotomy. By far, this is the most commonly practiced wound worldwide. So instead of cutting the whole sternum, we cut half of it, go into the 4th intercostal space. And another group is the thoracotomy approach, either from the anterior thoracotomy or from the lateral thoracotomy. There's been reports saying using the robot, but personally, I don't have any experience on that, so I won't touch about that. So people will ask why there are so many approaches available and still available. And the good reason is that there's no best way to do a minimally invasive surgical AVR, and different approaches have their pros and cons. Now, first, pre-operative preparation. Normally for full sternotomy, not all patients have a CT before, although I proposed best to have all CT for every patient having an aortic stenosis, because we can see the position of the aorta and also the quality of the peripheral vessels. If it is a favorable position and a good peripheral aorta, we can choose a peripheral bypass and use a smaller wound. But if we worry about the quality of the aorta, and also if there's no CT available, we can use a bigger wound approach, the parasternal approach, or the hemisternotomy approaches. And second is about the difference of the exposure. Exposure always been the #1 issue about of surgeons doing the surgery. So you can see the hemisternotomy and the parasternal approach. You can see the aorta and the valve quite nicely, just like a full sternotomy. But for thoracotomy approach, the anterior forecourt or the lateral forecourt, well, you barely see anything. So most of the time, we need an extra endoscope to aid our view of the whole aortic valve. So that imposes a certain technical difficulties. And most difficult part is putting in the sutures and the knot tying. So it takes up like half of our surgical time. For the hemisternotomy approach and the parasternal approach, is more or less the same as the full sternotomy. So I give a high marks for them. Having said that, sometimes for small wound, the sutures may be very messy and take up an even longer time. So for these two approaches, we need long instrument to tie the knot to put in the sutures, or sometimes we have some new aids to, we call the core knot. So just like the tie gun, just a pull of the triggers, it will replace our knot to secure the sutures. Now talking about speed, it's inversely proportional to the wound size and the invasiveness of the wound. So when surgeons like to go from a bigger wound to a smaller wound, actually the operation will become more complex and takes up more time. And also it's more difficult to learn, to master their skills. But most surgeons will love to go from the bigger wound to the smaller wounds, because we believe that once we didn't touch sternum, didn't touch the rib, we offer better benefits to our patients. And besides the speed, and also there's some potential, like doing some concomitant procedures. Particular wound can do with aorta, like the hemisternotomy, or we can do the double valve replacement from some of the wound as well. So have a quick review comparing different kinds of wound. I would like to say in the future, like I said, half of our patients will have a concomitant procedures during the SAVR. So in the future, I would say for those patients need a CABG, they really need a full sternotomy. Otherwise, we can deal with the aorta through the hemisternotomy approach, or deal with the MACE procedure or the mitral valve as well through the parasternal or lateral thoracotomy approach. For those remaining half isolated surgical AVR, we can do the endoscopic assist thoracotomy approach, namely the anterior thoracotomy or the lateral thoracotomy. So some upcoming new technologies can help us. One way is to use the rapid deployment valve. So in the market, there is the peripheral valve or intuitive valve. So after putting in, it looks like that. From the studies, it can save us for 20 minutes or above. Although there are criticism, the different sizing techniques, and also question about the durability, just like TAVR valves. So there's a randomized control trial called the PERSIST AVR, which is still going on for 1 year. 1 year results comparing the sutureless valve to the standard prophysis is quite similar. So we wait for the longer results to ensure the use of this rapid deployment valve. So for the another hand, we can use an automated suture device called the RAM device. So it's basically, instead of putting in individual sutures, so we just pull the trigger, a double-bladed sutures with a placket will go to the annulus. So this is from the hemisternotomy. So this is from the lateral thoracotomy. So you can see, just pull the trigger, the sutures go to the annulus of the aorta. So in that sense, we can still choose the new generation of the tissue valve to ensure the long-term outcome. So both of these techniques, I think, will make the minimal invasive approach technically easier and faster. And hopefully, we can disseminate the technique and improve the overall SAVR results worldwide. So I like to come to a conclusion is that I still believe SAVR have advantages over TAVI. However, we are teammates. We complement each other to provide the best treatment options to our patients. And minimally invasive SAVR offers the same surgical results, but offer better quality of life to our patients and less morbidity. There are different approaches of doing minimally invasive AVR. Well, that will help us deal with a different condition of the patients and also different concomitant procedures we needed. With the experience and the new ACE, I believe that the minimally invasive approach will be even more common in the coming future. So thank you for your time and attendance.
Dr. Tang, thank you for your excellent talk. We will have a panel discussion at the end of the section. So I would like to introduce the next speaker, Dr. Toru Naganuma. Dr. Naganuma is from Japan, and his talk today is how to complete the transfemoral TAVR. Dr. Naganuma, please. Dr. Naganuma, can you hear us?
Yes, now I can.
Okay. Yeah, you can start your talk.
Yeah. Can you hear me?
Yes, we can.
Okay. So thank you very much for your invitation. This is Toru Naganuma speaking from New Tokyo Hospital, Japan. My talk today is how to complete transfemoral TAVI. This is my conflict. And now two valves are commercially available in Japan, SAPIEN and Evolut family. In our center, we started TAVI with SAPIEN XT. We strongly believe that TF TAVI is much better than non-TF TAVI, even in combination with endovascular treatment. We have had more than 500 cases. Out of these, we performed transfemoral TAVI in 97% of cases. However, of course, to complete successful transfemoral TAVI, we need knowledges and skills of endovascular treatment. This is a basic knowledge about Edwards ECs, expandable Cs for SAPIEN 3. To deliver a SAPIEN valve, we use so-called ECs. We need 14 French for 23 and 26 millimeter valve, and 16 French Cs for 29 millimeter SAPIEN valve. However, keep in mind, when we advance a SAPIEN valve inside the Cs, it becomes more than 24 French. Expand. On the other hand, Medtronic supplies two different delivery systems. One is inline, which is like a sheathless system. Another is a conventional one. To deliver Evolut Pro with an outer skirt to reduce PBL, we need a larger sheath. You have to remember 2 French up. Let me show you a case with a narrow calcified iliac artery with a bending of aorta. In this case, we felt a lot of resistance at iliac calcification. Even after balloon dilation, we couldn't advance 14 French sheaths. So we implanted a biobound stent, which is a covered stent. Then finally, we could advance the sheath through up the stent. However, we felt resistance again at the bending. So we placed one more stiff wire, which is a round kist from left side. Then we could go up the TAVR system. This is a body wire technique to manage such bending. This is another case showing more challenging anatomy. As you can see on the right panel, we could straighten the aorta with body wire technique. Let me introduce a crossover technique. These are my favorite tools. 4 French IM catheter, 8 by 14, 40 millimeter over the wire balloon. The lumen is 0.035 inch, and the cruise wire, which is a 3 meter length. So this is a right femoral case. As you can see, the IM catheter has a good shape at the bifurcation of terminal aorta. Advance a long cruise wire through the IM catheter from left side, a puncture and fluoroscopy guidance. Be careful of heavy calcification and bifurcation. After valve implantation, you can gently dilate at the iliac to reduce inflow. When removing a cyst, you can get complete hemostasis very easily. You can inject minimum contrast from the tip of the over the wire balloon to confirm hemostasis. That's why we use 0.035 inch over the wire balloon. We can place 0.014 inch cruise wire inside. When do we perform crossover technique? We can do it whichever situations, elective or bailout, when vascular complication occurs. We have to distinguish 2 different scenarios whether a problem occurs, puncture site or iliac artery. This is a case of prograde failure. You can find stenosis at the puncture site. This was managed by gentle balloon dilatation, like this. This is another case of a bleeding case. This is also a prograde failure case. You can find the bleeding. We advance the contralateral cyst as much as possible, then implanted a covered stent. The result was okay. This is another case with iliac perforation. Once you need to advance the TAVI cyst immediately for quick hemostasis, then dilate a balloon from contralateral side and advance the cyst with anchor technique like this for hemostasis and advance the cyst. Then implanted the covered stent like this. The covered stent is very bulky, so better to advance the cyst as much as possible. Let me show you our data presented in PCR Tokyo about this year. We examined the patient who underwent TF-TAVI in combination with EBT. We found 51 patients. Study objectives were delivery success, or death from any cause, amputation, and TLR. Despite high-risk population, the results were quite acceptable. No cases, we switched to alternative approaches. No deaths related to lower limb ischemia. This is another case. You have to remember that a sapien can go not only through Edwards ECs, but also through 20 French dry seal. What is the advantage? Sometimes we need longer Cs to go over this kind of bending. So ECs has 36 centimeter length, which is not enough. As you can see, in such a case, we need 65 centimeter Cs for such case. Let me show you a unique case with a heavy calcified stenosis of abdominal aorta. As we couldn't advance the Cs at the point of the stenosis, we performed rotation atherectomy. This is for coronary use. And finally, we could advance 14 French ECs and subsequent sapien 3 valve. These are chips for successful transfemoral TAVI. You have to remember crossover technique from contralateral femoral artery, or you can do it from a radial or brachial. Dilators or balloon, you have to stand by covered stents. Long Cs, such as dry seal, body wire technique with 2 stiff wires, atherectomy maybe, and sometimes propofol as a lubricant. Thank you very much.
Yeah. Thank you, Naganuma, for your excellent talk. Is there any comment from the audience, from the panelists?
I'd like to start that the Toru is actually the use of the femoral artery is various, depends on the other situation in each institute. But Toru, the overcome the peripheral disease in a different way. Therefore, the percentage of the transfemoral approach is quite high. It's a very nice
Yeah.
the presentation. Excellent.
Thank you very much.
Toru, congratulations, very nice cases. What we have also used recently is we use the peripheral shockwave balloon. I don't know whether you have it. The peripheral shockwave balloon is very easy to use, and then you can actually crack the calcium and then allow you to put a ship in. We have a couple of recent cases successfully done and go with the ship.
Sorry, what is the name of the balloon?
Shockwave balloon. Shockwave IVL.
Diamond back.
Thank you.
And then other people are using the orbital device. I don't know whether you have the peripheral orbital OAS device. Orbital atherectomy is another device that you can use. I think, there are reported cases with great success.
Already, sounds very nice.
Yes.
Total for the rotor operator, I think the rotor operator compared to the aorta is very small device. Do you think it can effectively ablate the calcium in the aorta, or how many rounds you need to go to ablate enough calcium?
As you say, it's too small for aortic disease. So what we did is during the atherectomy, we rotated the guiding catheter 8 French to change the pathway. And we performed several times from right side as well as left side to make many crackles.
I think it's a very good idea, yeah. So what wire do you use? Floppy wire or extra support wire?
The floppy wire.
I have two surveys for the panelist. First is which kind of the anti-coagulation or anti-platelet procedure, and the second is when do you use the alternative access? As maybe everyone can share their experience. And my colleague, do you share first?
Yes. The first question is about antiplatelets. We have a lot of elderly patients, a lot of patients with very high bleeding risk. And there have been several single center reports about the use of single antiplatelet. So we sort of switch our practice to single antiplatelet therapies. We only give aspirin nowadays for most of our elderly TAVI patients, unless the patient is young without any bleeding tendency. Then we probably will still keep the dual antiplatelet. We have not used the NOAC so far because we don't really have a good outcome result to support us. Galileo has been terminated prematurely, and we are waiting for a lot other NOAC trials. But I don't know. Our practice might change with more evidence coming out, especially after listening to Kiyuk's talk. Very, very educational talk. Although the number of your series is small, but it shows very clearly that NOAC might probably be better than dual antiplatelet and single antiplatelet therapy with the use of NOAC in terms of subacute mouth thrombosis.
The using of the anticoagulation or antiplatelet therapy, I think is the selection of the best treatment, medical treatment should be divided in the patient, the underlying situation, age and status. Kiyuk Chang's present that the patient is really fragile. So when the prescribed in the anticoagulation, and you have to keep the level of the anticoagulation level is a PT is more than a 2 and then 2.5. It's too strong for such kind of elderly and fragile patient. So even though in such kind of patient we prescribe the anticoagulation, the INR level should be a lower, not that the small stages of the Asian patient compared to the more big size of the Western patient. Therefore, the INR level should be a lower. So ideally 1.5 or between a 1.5 to the 2.0, not more than a 2.0. So there should be the individualized.
So what you do first is antiplatelet or offering first? It's a normal patient, yes, for you.
Usually the dual antiplatelet first, and 6 months later in the single agent. Okay.
Because we have run out of the time, and I would like to close this section. Thanks the contribution of all the moderators and panelists. Thank you very much.
Thank you.
Okay.
Hello, I'm Dennis Chao from Jian General Hospital, and we will start this section. So this is a wonderful surprise from Professor Wei.
Well, today is Dr. Chao's birthday. I'd like to ask 3 other Gemini girls to come. They are also, they are all Geminis, okay? Just to say, want to say happy birthday to all of you.
Thank you. Happy birthday to you.
Okay. Okay.
Professor, thank you very much. It's so touching. Yeah. So I would like to invite Professor Yin to join us. Yeah.
Oh, hi, Yin.
Okay, dear friends, this is the second part of the TAVR session regarding the past, present, and future of the TAVI. We have several distinguished guests, Lars Søndergaard and Michael Lee and Milky Hong, me and Dr. Cao. We will join this session. And Eric also. Sorry. So let's start with taped lecture from Alain Cribier, Dr. Alain Cribier, who will give a talk entitled TAVR in the Future, How Do We Improve Our Life?
Dearest colleagues and friends from Taiwan, let me tell you something. It's a great pleasure to be with you and to participate in this TAVI Summit 2020. Of course, I regret of not being there with you physically, and also I was unable to be online on this special day, so I decided to send you this recorded lecture. I hope you will forgive me for that. You very kindly asked me to talk about the future of TAVI. We say TAVI in France. How do we improve our life? And I will show you these slides. First of all, my disclosure. So this is my first slide. We were extremely happy, and I consider that as a privilege, to have done the first TAVI implantation in April 16, 2002. After 15 years of intense research, the dream came true. And you probably heard about this case, but it was dying patients, very young, 57 years of age, with multiple comorbidities and an acute leg ischemia that prevent to use the transfemoral access. So it was a very moving day for us. You can see here the valve implanted using the transeptal approach from the right femoral vein and the valve in place. And these are 2 pictures that I love so much, the picture of the patients immediately after implantation and the patients 8 days later totally resuscitated. You know that the publication of this case in circulation a few months later had a bomb effect in the medical community, and this was the beginning of an unbelievable and incredible story of TAVI. So where are we today? You know that TAVI has a spectacular worldwide expansion with, in 2019, almost 150,000 cases performed in the world, 15,000 cases in France, 65,000 cases in the United States, and there is an expected growth of this technology of 40% per year. This is definitely a breakthrough technology with an incredible expansion worldwide. Most of our knowledge has been obtained from the studies done with the SAPIEN Edwards balloon expandable valve and self-expanding evolute valve. We have today a very high number of procedures in the world, probably near 1 million cases performed in 1,400 centers and 600 centers in the United States. And I am so pleased to know that this technique is in full expansion in your country. So how did we get there? I will just show you 5 slides to remind you the main steps of the procedure of developing TAVI. And everything started actually in 85 with the onset of balloon aortic valvuloplasty. We did the first in-man case in September 85. And tens of thousands of cases of balloon aortic valvuloplasty were performed worldwide. But a major limitation occurred, the earlier is stenosis, and so the technique was progressively abandoned. And I had to think about overcoming this limitation, and then came the idea of a percutaneous transcatheter valve, leading finally to the first in man many years later in 2002. The initial goal of TAVI for me was to treat non-surgical candidate by implantation of a percutaneous valve. And this is what I said in 90 during a meeting. I wanted to implant a valve prosthesis within the disease-calcific native valve on the beating heart using percutaneous catheter-based technique and local anesthesia. And this is exactly where we are today, even though it was a kind of a crazy idea, considered generally like impossible because of the amount of AV calcified of calcifications on the valve, and also dangerous on the beating heart because of the surrounding structure. Actually, the project that I had in mind after many years of research, post-mortem studies and work in the lab was that it was technically impossible with major life-threatening issues, and it would never be approved by the FDA. And in general, the experts who were all cardiac surgeons in all the biomedical companies that I contacted said that it was a stupid idea and that had to be urgently forgotten. So we did, nevertheless, a first series of patients in Rouen using the transseptal approach on compassionate use only with imminent death, and it was extremely challenging. We used the transseptal approach in 33 cases with 85% of success, and the retrograde transfemoral approach in 7 cases, but with some failures due to the lack of a specific delivery system. This is the way it worked. We were using our prototype developed by Percutaneous Valve Technology, our startup. We had a crimping device. We were using a new med balloon and a 24 Frenchies in the femoral vein with the guidewire exiting from the femoral artery on the other side. The prototype of the valve is shown here. It was made of first of equine pericardium and then of bovine pericardium with a single size of 23 millimeter. And in these dying patients were supposed to die within two weeks. This was the definition of compassionate. We had many patients who did survive several months or year. We had 4 patients surviving more than 5 years and 1 patient surviving 6.5 years. And I just would like to focus on this patient who was definitely extremely important for the acceptance of TAVI in the world. The patient's number 3 was a dying lady of 83 years of age in cardiogenic shock. And you can see here the clinical follow-up after the valve was implanted at day 15, 6 months. At 1 year, she was invited in Washington and she was able to fly to the TCT meeting. And you can see here her activities up to 6.5 years. So this was extremely encouraging. Also, I would like to remind you that we did the first ever planned retrograde TAVI on patient 10 with the results that you can see here. We did that because the patients had also mitral stenosis, the reason for which I could not use the transseptal approach. But these patients gave us a first and good vision of the future of TAVI. In 2005, you know, TAVI takes its flight in the world only in compassionate cases. And at that year, we had 100 TAVI cases performed. And then came the new era of TAVI with the acquisition of our startup by Edwards Life Sciences and the development of the transfemoral approach and simultaneously of the transapical approach. So at this stage, no one could have predicted the incredible and fast acceptance of expansion of TAVI, and the reason of success are double. First of all, the improved technology and skill of the physicians with a better patient screening and the very significant role of the development of CT scan, a better experience of the team, improved devices, valve delivery system and femoral closure devices, and procedural advance leading to a stent-like procedure, but also, and importantly, a large body of scientific evidences with registries and evidence-based trial in high-risk, intermediate-risk, and low-risk patients showing the non-inferiority or superiority of TAVI versus surgery. So, as you know, the devices have been tremendously improving with time. With the consequences were the procedural simplification, improved safety and results. You can see here the different generation of the balloon expandable valve, and on the other side, the self-expanding valve from Medtronic, the core valve, also made a lot of progresses with today the possibility of using multiple sizes between 20 and 29 millimeter of diameter with a decreased sheath size. And the consequence of it is that the transfemoral approach is becoming the default strategy almost everywhere in the world. Actually, the transfemoral approach can be used today in more than 90% of the cases, and we have many alternative routes in case the femoral artery is not available. And the last one is the vena cava to aorta connection, you know, approach, which is a kind of promising, but most of the cases are done either transapical or by direct aortic or a transcarotid approach. We have been pioneering, and this is extremely important when the improvement of the patient's life is concerned, the transfemoral minimalist approach. So we were among the first to use it. It has been pioneered by us since 2010 with the onset of the SAPIEN XT valve from Edwards. The technique is today performed using local anesthesia, sedation only on demand, no transesophageal echo during the procedure, and we use, of course, transfemoral closure devices. Today, TAVI procedures last between 30 and 45 minutes, sometimes less than that, but the very important aspect is the possibility of early discharge of the patient between day 1 and day 3 in 75% of the cases, going directly back home without any need for rehabilitation. This is a technique that we use in Rouen in 92% of all TAVI cases, and it has also been demonstrated that it was cost-saving in United States, like probably in your country. Today, in 2020, the transfemoral minimalist approach is leading even in United States, where they were initially quite reluctant to use the local anesthesia, but today the transfemoral approach using local anesthesia is used in the United States in 80% of the cases, and again, early discharge is obtained below 3 days in 75% of the cases. What about the scientific evidences? The Edwards clinical pathway has been kind of remarkable, and the company has sponsored a number of registries between 2002 up to 2007. I don't enter into details, you know that, but most importantly, they have been sponsoring very important randomized trial in inoperable and high-risk patients with partner 1, in intermediate risk patients with partner 2, and in low-risk patients in partner 3. And this has been obtained by using the 3 consecutive generation of valves. And as you know, the FDA has been approving all these indications, as I will show you later. On the other side, Medtronic core valve had also the similar clinical and very interesting pathway with many national and international feasibility and follow-up registry up to 2014. And then they did exactly the same randomized trial in high-risk, intermediate risk, and low-risk patients. All of these studies including thousands of AS patients. One of the most important, the first initial important step was to demonstrate the superiority of TAVI in inoperable patients. As you know, this was partner 1B, showing a reduction of mortality sustained with many years of about 25%, showing that TAVI is superior to medical treatment in inoperable patient. Then came the high-risk patient, where TAVI was compared to surgery, and you know these results very well. Similar improvement of the patient, similar mortality rate after TAVI than after surgery, the same with core valve, and showing that TAVI is equal or superior to surgery in the high-risk population. Also, partner 1A in high-risk patients showed no alarm on the durability of after TAVI implantation up to 5 years. So this was also a very important message, comparable to surgery. The final milestone was the partner 3 results in the low-risk population with partner 3 using the SAPIEN 3 valve with a primary endpoint which was death, stroke, and rehospitalization, showing a high superiority of TAVI over surgery in population above the age of 65 at low risk. And some other secondary endpoints plays an important role in the acceptance of TAVI today, and especially the less stroke at 30 days and later on after TAVI than after surgery. Among the different other messages, the similar rate of pacemaker after TAVI and after surgery. So from these partner 3 studies, I don't enter into details, I have no time, but TAVI can be considered a valuable alternative to surgery in AS patients, whatever the surgical risk. And Medtronic core valve led to a similarly good result, showing a similarity of the results on mortality and stroke at 2 years after TAVI or surgery in low-risk patients, again, above the age of 65. So the other lessons from Medtronic core valve were that there was a better safety recovery, but more moderate PVL and pacemaker in the studies, and at 1 year, fewer strokes, less cardiovascular rehospitalizations, and better valvular function. So after these results, you know where we are today. The FDA approved the TAVI for low-risk patients in the United States, and it was the final surgical risk category to be approved by the FDA. In Europe, we are a little late, and we had some new recommendation in intermediate risk patients coming after partner 2. The new recommendation was that below STS score of 4% surgery was better, and that TAVI was better above this STS score, above the age of 75 years. And we have today, we are expecting the acceptance of TAVI in patients above the age of 65 years in low-risk patients. This is expected to be obtained in 2021. Interestingly, the health authority in France are up to approve TAVI in patients above the age of 65 years at low risk at the end of this year. So this is a very important step for us in France. The TAVI valves will be reimbursed in France, even in patients younger with an age limit of 65. Today we have also many promising new valves. I don't put all of them here, but we don't know exactly whether these valves are offering better results than the previous valve, the Edwards and the Medtronic, but they are there and they are hugely investigated. I believe that the MyValve from Merrill, which is a balloon expandable valve, has a great future and with maybe a better price than the Edwards, so more available to be used in Asia. So TAVI in the future might become the default therapy for a vast majority of aortic stenosis patients because the procedural advantages of TAVI clearly outweigh its potential limitations. TAVI today offer valve implantation with local anesthesia, no sternotomy, no scar, early discharge home. This is extremely good for the patients. Less mortality, less stroke, less AF. The similar amount of PVL, the same amount of pacemaker in the SAPIEN 3 series, shorter length of stay and faster recovery. At the opposite, surgery may keep some good indications, especially in some bicuspid valve, especially when they are massively calcified in younger patients. Age below 65 years, I will come back on that. Less pacemaker than with the core valve, for example. Easy reaccess to the coronary artery. Associated valve disease is also a good indication for surgery, as well as associated coronary artery bypass and acute endocarditis. Age and patient-informed consent will be key in the decision in the future. There is absolutely no doubt about it, even though there is no alarm so far on the durability of this TAVI valve beyond 5 years. Concerning this, we had 6 trials showing that there is no alarm so far, including the one that we did in our department with the longest follow-up, showing a total structural valve dysfunction of 3.2% up to 8 years. And reintervention rate in the all studies is between 0.7 and 1% beyond 5 years. So nothing really that we can fear. There was also some studies comparing the bioprosthetic valves and TAVI followed by echo, showing that finally even the surgical bioprosthesis shows some hemodynamic valve deterioration on the follow-up, which is quite comparable or even more important than after TAVI, with early hemodynamic valve deterioration below 2 years in 12% of the cases, and a midterm HVD of almost 21%. So more or less, you know, the evolution of these valves are quite comparable. So now that we are dealing with younger patients, the questions of the bicuspid valve versus tricuspid valve is there. And I don't think that we have to fear any discrepancy on the results as shown in many studies coming from Asia, and also in the STS-ACC TVT registry comparing bicuspid and tricuspid valve, showing that more or less concerning the all-cause mortalities, the results are quite similar. So I would like to show you my personal views on the possible treatment options according to the age in the future. For us in Rouen and generally in Europe, above the age of 75 years of age, there is no questions about the superiority of the indications of TAVI versus surgery, knowing that in case of hypothetical early structural valve dysfunction, we can always do a valve-in-valve procedure, and the same in case of late structural valve dysfunction. So above the age of 75 today, we are pushing the patient to accept TAVI. Between 65 and 74 years of age, we have to inform the patients about the possibility of having a surgical bioprosthesis as an option, knowing that in case of dysfunction of the surgical bioprosthesis, we can always do a valve-in-valve procedure to solve the problem. Below 65, personally, I am pushing the patient to be operated on in Europe. It may be different in Asia. But below 65, I think that clearly we can say that surgical bioprosthesis is an option, as well as mechanical heart valves, which are always there. And if the bioprosthesis has a structural dysfunction in the future, it can be treated by redo surgery or valve-in-valve, depending on the patient age. In this category of patients younger than 65, I think that TAVI can be done in case of absolute refusal of patients to surgery, which is, I must say, often the case now. So age is key in the discussions and will remain key in the discussion in the future in younger low-risk patients below the age of 70. But in the absence of anatomical contraindications to TAVI, well-informed patients, whatever his age, refusing surgery, might have in the next future the deliberate choice of undergoing transfemoral TAVI, keeping in mind that surgery remains an option, emergency, urgent, or planned in case of unsatisfactory result or a valve failure during a follow-up. As you know, next to come, but already there, some other clinical indications on TAVI on the future. Bioprosthetic heart valve failure, we know a lot about it since thousands of patients have been included in the valve-in-valve TAVI registry. Concerning the bicuspid valve, I have shown you the slide of the US trial showing a similar outcome. And so I think that it's not a real problem, but we have to investigate a little more about it. We have also the indications of TAVI, which is investigated in severe asymptomatic AS patients. TAVI for moderate aortic stenosis and heart failure, with an international randomized trial ongoing. Maybe high-risk aortic regurgitation in some cases, and also are investigated TAVI in aortic stenosis with concomitant disease and in low-flow, low-gradient. So expansion and future of TAVI, we are reaching today, and this is good for the future, a new paradigm. We started TAVI for patients who are not optimal candidates for valve replacement. And today, surgery will be indicated in patients who are not optimal candidates for TAVI. Thank you very much for your attention.
Well, actually, thanks to Professor Alain Cribier for his comprehensive review. I think he's the father of TAVR, and who is telling us how he devoted himself during the past, I think, 30 years in this field, and turned out to be a very great outcome and revolutionized our treatment for valvular AS. I think this second talker is also interesting, from Professor Lars Søndergaard. He will give us a talk entitled Midterm and Long-Term Follow-Up After TAVI. I think the durability issue is really a concern. Please, Lars.
You can see my screen now?
Yes.
Okay, so let's just go back here.
Yes,
so
please.
I think, yeah, thanks a lot. I just want to show you a few slides. I think it's very important to give credit to the people who actually took the leading step here. Did Alain Cribier perform the first TAVI procedure in human? Yes. Was TAVI Alain Cribier's idea? No. So just remember back in 1986, there was an introduction of coronary stent, and there was actually a very young cardiologist attending this meeting to see this presentation. His name was Henning Rud Andersen. On his way back to the flight, on a flight back from the US to Denmark, he got the idea that maybe you can use the same concept for valve disease, using a big stent with a valve inside. And what Henning did when he came back late 1980s was that he made his own stent from a sternal cerclage he found in the surgical department. He went to the butcher, he bought a pig's heart, explanted the valve and sutured that into that stent and crimped it on the balloon. And he actually showed already in 1989 that it was feasible to do it in a pig model, to implant it in the aortic position. And he published that the year after in the European Heart Journal. And the concept of TAVI is based on his patent. Remember that. It was not Alain Cribier who actually invented TAVI, despite he wants the credit for that. He did the first in human, but Henning Rud Andersen, actually, it was his concept who ended up with Edwards and led to the first in human implantation of a TAVI valve. So back to what data do we have on TAVI nowadays? And what we have seen in the last year, we have seen that TAVI has been studied in patients at low surgical risk. We also have seen data on TAVI in bicuspid aortic valve. We have seen important data on the durability of these bioprosthetic aortic valves. And we've seen data on antithrombotic therapy after a TAVI procedure. So let me just address these 4 issues. So starting with patients at low surgical risk who has been randomized and studied in large cohort. Partner 3 included 1,000 patients randomized between the SAPIEN platform and surgical aortic valve replacement using a little bit odd endpoint, all-cause mortality, disabling stroke, and rehospitalization for heart failure. So 2 very hard endpoints and a more soft endpoint. And using that, they showed that TAVI was superior to surgery. Medtronic performed the Evolut low-risk trial, which was a more strict study, only using all-cause mortality and disabling stroke, and showed that TAVI was non-inferior to surgery at 2 years in 1,400 patients. And we have seen that there's been a meta-analysis of those 7 randomized trials which have been performed today between transcatheter and surgical aortic valve replacement, showing that all-cause mortality at 2 years in 8,000 patients now studied is reduced by 12% if the patient is going for TAVI instead of surgery. And if you look at the patient who has been assigned to the transfemoral arm, it's actually a 17% reduction in all-cause mortality in 2 years in patient in the TAVI arms. And the same for stroke at 2 years, again, 8,000 patients in those 7 randomized trials, and 19% reduction in stroke rate for patients going for TAVI. So certainly TAVI is a very attractive treatment option. And we also got at least intermediate term outcome. So these are data from the Notion 1 trials published last year. We can see at 5 years using all-cause mortality, stroke, and myocardial infarction. Out to 5 years, TAVI is non-inferior to surgical aortic valve replacement. This is using the CoreValve platform. So if you look at the partner 2 intermediate risk patients treated with SAPIEN platform, you see that curves start to divide after 3 to 4 years, and particularly if you use the patient arm assigned to transthoracic TAVI, you see there's a clear inferiority for the TAVI cohort. So Concluding for this, if the patient needs a transthoracic approach for a TAVR procedure, send your patient for surgery. He's going to do less well with a TAVR procedure. So now you may say that these patients at low surgical risk who can be treated by a transfemoral approach should go for TAVR. But remember, all the trials looking at TAVR versus surgery have included highly selected patients. So you can ask, what do you actually mean about low risk? And of course, you can say, if you read the papers, it's patients who are at low surgical risk. But also remember, particularly in the partner 3 trial using the Saplan platform, patient who was included had a low risk for a suboptimal outcome after TAVR. So the patient not only needs to be suitable for a transfemoral approach, but he should be suitable for a safe transfemoral access. The coronary arteries need to have a high takeoff, so there was no risk for coronary occlusion. The patient needs to have a tricuspid and not a bicuspid aortic valve, and the valve could not have severe calcification, and there could be absolutely no calcification in the left ventricular outflow tract. Otherwise, the patient would not be included in the partner 3 study. So these studies do not represent all common patients at low surgical risk, the patient we're treating every day in our cath lab. Some of these patients may be better served with surgical aortic valve replacement. Alain Cribier was also saying that now it's going to expand to much younger patients, down to 65. But we have absolutely no evidence of that. All the patients who's going into these trials have been elderly patients. So despite we've seen 7 trials now from extreme risk down to low risk, looking at the ST score from 12 to less than 2%, remember the mean age has been 80 years. And despite it came a little bit down with the partner 3 and the evaluate low risk, it's still 74 years of age. Very few patients in these studies has been younger than 70 years of age. And if you want to go to younger patients, you're also going to see more patients coming forward with a severe aortic stenosis based on a bicuspid aortic valve. And once again, these patients never went into one single randomized trial between TAVR and surgery. The evaluate low risk and also the partner 3 had a single-arm cohort looking at TAVR in patients with bicuspid aortic valve. These are from the evaluate low risk single-arm study or registry. 150 patients a bit younger than they were for the tricuspid low-risk trials. And most patients had a bicuspid valve type 1 with a left to right fusion of the commissures. No patient had a type 2. So if you do have a patient with a type 2 bicuspid aortic valve, don't send him for surgery. Don't send him for TAVR. He's going to do very poorly of this. And the outcome looked quite promising. Low mortality rate, stroke rate was low, but again, remember, Raj Makar published a propensity match study based on the STS registry on comparing patients with bicuspid and tricuspid aortic valve, and he found there was a significantly higher stroke rate if you treat a patient with bicuspid aortic valve compared to a patient with a tricuspid aortic valve. And also remember, these outcomes are at 30 days. And we're talking about younger patients with bicuspid aortic valve who's going to have a much longer life expectancy. So you cannot conclude anything about that it's safe to perform a TAVR procedure, and the hemodynamic is going to be similar to what you see for tricuspid aortic valve. You need long-term outcome before you actually start to expand TAVR to patients with bicuspid aortic valve and a much longer life expectancy. And particularly, durability of these valves in patients with bicuspid aortic valve can be a major concern. So most of these patients, as you saw, have a type 1 bicuspid aortic valve with a raphe, and often that raphe is going to be calcified, meaning that this stent frame is not going to expand to a circular configuration, but it's going to be elliptical. And how is a valve going to perform if it's not circular, but it's elliptical? Is that going to impair the durability of these valves? So again, we need to see randomized trials between transcatheter and surgical aortic valve replacement in bicuspid aortic valve before we even consider to offer this treatment to patients at a low surgical risk. And again, as I said, one of the main considerations when we start to talk about TAVI in patients with longer life expectancy is the durability of biprosthetic aortic valves. In the past, it was very difficult to talk about that because we don't have a clear definition what we meant with durability. Surgeon was classified patient who went for a re-intervention as valve failure. But what about the elderly patient who had a failed valve but wasn't offered re-surgery due to comorbidity? That patient didn't count. But in 2007, we saw European consensus on durability for biprosthetic aortic valve, talking about valve dysfunction and valve failure. And if you start with valve dysfunction, maybe the most important part of those four classifications is structural valve deterioration, meaning that the peak gradient is going up or there's a significant central aortic regurgitation. And we now have data from the Notion 1 trial, the first trial, which included elderly but patients at low surgical risk, out to 6 years. And using these European consensus definition of valve dysfunction, you can see at 6 years, the rate for patients with a transcatheter approach was much lower, 1% compared to the surgical cohort, which was 12%. But this is for the core valve platform. If you look from the Partner 2 study, patient at intermediate risk, using the balloon expandable SAPIEN platform, you're going to see an opposite pattern. Patient who's going for TAVI got a much higher rate of structural valve deterioration at 5 years, almost 9%, compared to 3% in the surgical cohort. So there's a difference between different transcatheter valve platforms. So balloon expandable valve seems to do less well than self-expanding. And if you look at the other entry, valve failure, defined as severe structural valve deterioration with very high grade and a very severe central aortic regurgitation, patient who's going for a valve re-intervention, a patient with a valve-related death, again, going back to the core valve platform or the self-expanding platform, you see at 6 years, the rate is the same between surgical and transcatheter valve implantation. But if you look at the SAPIEN platform, you're going to see a different pattern. Again, surgery is going to do much better at 5 years than patient who's treated with the SAPIEN platform. So keep that in mind. If you're going to expand TAVI to patient with longer life expectancy, you're going to have a much better outcome at 5 to 6 years using self-expanding technology compared to balloon expandable technology. And even though we can be encouraged about these positive outcome at 5 to 6 years, remember, it's still early days. So if you look at some of the very poor surgical biprosthetic aortic valve, like the Toronto stentless valve, which no one uses anymore because of poor durability, look at 6 years. Everything was looking fine, and then it starts to go squared. So before we can conclude that the transcatheter heart valve is doing as well as the surgical heart valves, we need much longer follow-up data. We need 10, 12, maybe even 15 years of durability before that conclusion can be made. And then finally, I'm going to move to the last topic, which we have seen data on within the last year, antithrombotic therapy after TAVI. That's been a big discussion how we're treating these patients best. We have seen that the ART trial, which was a quite small trial, including patients after TAVI with the SAPIEN platform, randomized between dual and single antiplatelet therapy, that dual antiplatelet therapy is actually going to cause worse outcome than single antiplatelet therapy in these elderly patients. And in 2019, we saw the Galileo trial looking at patient randomized to rivaroxaban 10 milligram daily plus aspirin for the first 3 months, compared to dual antiplatelet therapy for 3 months, followed by aspirin. And again, in this elderly patient who was heavily treated with antithrombotic therapy had a worse outcome. So you can see here all-cause mortality for the patient in the DOAC arm was higher than the patient in the antiplatelet therapy. So again, as for the ARTIST trial, less is better for these elderly patients. One interesting sub-study for the Galileo trial actually looked into subclinical leaflet thrombosis, which is a finding we see both in transcatheter and surgical prosthetic aortic valve. It's something you see on a CT scan if you do that, but we still have no evidence that it's actually going to impact on the patient outcome with regard to development to clinical valve thrombosis with high gradient and symptoms, or it's going to lead to early valve deterioration, or whether it's going to lead to stroke or TIA. There's no evidence for that. But it's something we see that if you apply this CT scan, advanced CT scan to these patients. And the sub-study on the Galileo using 4D CT scan at 3 months showed that very interesting, despite the worst clinical outcome for the patient assigned to DOAC after TAVI, there was a much lower rate of subclinical leaflet thrombosis in these arms, both with reduced motion and leaflet thickening. But again, we need more and longer prospective data to actually conclude whether this have any impact for the patient. And then also we saw the popular trial presented at ACC this year, again, where the Galileo trial included patients with no indications for oral anticoagulation prior to the TAVI. Popular TAVI included patients who had an indication for oral anticoagulation, mostly due to atrial fibrillation, and randomized them to oral anticoagulation plus clopidogrel or only oral anticoagulation. Quite small study, about 300 patients in total, looking at the endpoint at 12 months. And again, we saw that patient who was more heavily treated with antithrombotic therapy had a much higher bleeding rate than patient on oral anticoagulation alone. But also these patients are elderly, 81 year in mean age, so we cannot really say how this data is going to apply if we in the future is going to expand TAVI to younger patients with less comorbidity. And also in the popular trial, we looked at thromboembolic events, patients with cardiovascular death, ischemic stroke, or myocardial infarction, and again saw a worse outcome for patients assigned to dual therapy. So I think I'm going to stop here, and we can discuss these findings and how we should imply that in our daily clinical practice.
Okay, thank you, Lars. Thank you for your excellent talk, providing some in-depth analysis on the data. And we have another talk from Eric. So after Eric's presentation, maybe we can have a discussion. Thank you very much. Eric, please. Microphone, please. Eric, can you share us your slide? And turn on the microphone.
Okay. Okay, can you see it now?
Yeah, please.
Okay. And can you hear me as well?
Yes, very clear.
As a matter of fact, I think that after Lars' talk, my talk is quite a waste of time, but nevertheless, no, we're gonna. I didn't know that he's gonna talk about that, and he's always talks better. But I'm gonna tell you about a true patient of mine. He is 72 years old, male with risk factors. Otherwise, he's completely healthy. Now, he's a widower. He's got 4 kids. And recently his wife died, and his younger daughter is living with him, and she's on the spectrum. Now, this is his echo and gradient. His coronaries looks quite good, as you can see. And his aortic root looks fine, symmetrical, not too heavily calcified. And even the femorals are acceptable, okay? Now, he asked for the less invasive procedure to treat his aortic valve. As a matter of fact, he insists. He says, look, with the situation today, I'm not going to go to surgery. So the question is whether the patient should go to TAVR or to surgery, and the heart meeting is meeting, and the heart team. And you know, as always in any other place, there is a debate. Sometimes it's a gentle debate, sometimes less gentle, but you know it. Now, a week later, I got an email from my patient, and he writes me, hey, Professor Finkelstein, I have met the surgeon. The surgeon invited him, and I'm a bit confused. And I ask him why, and he says, well, he claims that for a low-risk patient like me, surgery is better. And I'm asking anything more he told you, and he said, well, yes, he has told me that the valve is not closing enough, or I'm going to have some kind of leak, or what? And I said, and what else? Oh, I'm sorry. And what else? And he says, well, he says that the valve is not going to last for many years. Talked something about durability. I don't know. I didn't really understood. And is there anything more? I'm asking him. And he says, well, as a matter of fact, yes. He says that I'm going to have a pacemaker, and I have maybe 2 leaflets, and it's bad, etc., etc. So what I'm telling you is what I was answering Mr. Gantz, as a matter of fact. Whether the surgery is better for TAVI for low risk, what about the PVL, the durability, and the pacemaker? So that's what I'm talking about. Now, you know that we know our data from randomized control trials, from registries, and from small observational studies. Now, you know that we had so far even more than 24 randomized trials that has recruited more than 15,000 patients and published in so many leading journals so far. Now, what we know more than anything is the papers about the partner, about the balloon expandable, and on the opposite, on the self-expandable in the partner 1, 2, and 3. Now we're talking about low-risk patient, and I'm not going to tell you again everything that you know. Just remind you that the mean age was 73, the STS score was less than 2. It was really low risk. Now you all know the results. I'm not going to emphasize it again regarding death, disabling stroke, rehospitalization, and even the hemodynamic was either non-inferior or even superior. And this was true for almost all subset of patients. And in parallel, that was the self-expandable with very, very similar results, and even in a better hemodynamic superiority because it's supraannular, and you know it. So what about the PVL, the durability? Somebody is not on mute. Okay, so the PVL, we all know it. It started somewhere with the old core valve, but as we improved ourselves and the toys that we're getting improved, it became better and better. And that was for the Evolute Pro, and that for the S3 as well, as compared to surgery in the S3 trial. And if there is more PVL, when it is mild, it means nothing. and you know that. Now, what about the durability? Well, I think that about the durability, Lars have told us everything we should know. But, you know, clinically, the years just passed, and we saw no difference in clinical results as well as in hemodynamic results along the years. You know the notion, Lars presented it better than any way I can do it, and the hemodynamics as compared to surgery. What Lars was not emphasizing is that in the S3, yes, you are right, Lars, that was some superiority to the surgical valve, but this was with the Sapien. When you add the S3, it looks like this, and this is not superior by surgery. So we're using now, you can see it here very clearly. So we're using now the S3, we're not using the XT anymore. What we don't know is about the surgical valve, because I don't think that so far before the TAVI era, anybody really had a very strong data about the surgical valves. And nobody really knew accurately, as we are trying to understand today, what is the durability of this surgical valve. What we do know, according to the valve and valve, that the main time of failure of the valve that we see is somewhere between 6 to 10 years. This is true here, and this is in the Israeli registry that we published, again, between 6 to 10 years. Oh yes, about permanent pacemaker. You know that a long time, the permanent pacemaker rate is getting down. If you're looking at Ron Waxman, the low risk trial, it was around 5%. In the Tamburino registry, it's somewhere around 8.5% with no significance compared to surgery. And if you're looking at our center, we're going down and down and down, and we went into 6% in about 2,000 patients we have done here in our center. But let me talk a few words about the guidelines. You know, the last guidelines we have are here. And they are based, you know, these are the guidelines. And they are based on this paper of the Surtavi. And the Surtavi, mind you, started in 2012 and ended somewhere before 2017. What is more important is that 86% of the valves used were the old core valve, and the prerequisite of participants, of operators, were more than 40 cases. Do you remember what was your experience after 40 cases? Well, later on, they continued the continued access of the Surtavi. And then 93% were using the second generation valve. And it changed the whole idea and the whole result. The mortalities were zero. The disabling stroke rate was 0.5%. And there was no mortality at all. And we are improving. We're improving in mortality from time to time, from study to study, and we are improving in the paravalvular leak, as you can see in any study that we're doing now. But still, the Surtavi was published in the New England Journal of Medicine, and still the guidelines are according to this paper. I'm bothered because we are talking now about the S3 trial, and the S3 trial ended in 2019. And you know what? And the low-risk trial by the Evolute, they added the Evolute Pro only on the last third of the study. And still, it is published in the New England, and still, according to this, are going to be the guidelines within 2 or 3 years. And this is the problem with guidelines. They are developed and published by international organizations, usually prepared by volunteers writing groups that are covering the whole topic. They are very long, And by the time the guidelines are published, they are too conservative and out of date. And I'm saying this because my guidelines is a little bit different. In other words, do I think that every patient should go to TAVI? No, I think like Lars, definitely not. We should be humble. And this is something that Lars saw. What does it mean, low risk? It means patient at low surgical risk? No, we're working those days on what we call TAVI score, TAVI risk score. And TAVI risk score should be based not mainly on the mortality score, which becomes more and more rare, but should be based on the score of my confidence that the TAVI will end with perfect results, because we don't compromise anymore. So the score should not be anymore what is the surgical risk score, but rather the suitability, the anatomical suitability for TAVI. So if I'm looking at this patient, you look at those two stones here, and those two stones dictates me that I don't care what is the surgical risk, but I know that this patient is gonna end with this piece of calcium here, is gonna end with this ugly result. And if I'm looking at the patient with this piece of calcium here on the LVOT, I know that he may end in TAVI with nice result, but with this ugly dissection in the aorta. And I think that the heart should work like this. A patient with severe symptomatic aortic stenosis, we should combine the surgical clinical risk to the TAVI anatomical risk and dictate it for what doing with the patient. And severe symptomatic aortic stenosis, if he has a high surgical risk and no anatomical risk, he should go to TAVI. I don't care what his age and what his risk of surgery. If he has got low surgical risk and high anatomical risk, he should go to surgery. If he has got low surgical risk and low anatomical risk, we should consider them both with advantage to TAVI. And if he has high surgical risk and high anatomical risk, we should think of both, but probably mainly for surgery. And I think that this flowchart, which is well known, should take mainly the decision-making with the patient as well, because the patient is the patient. And that's the way he looks after 24 hours after surgery. And that's the way he looks after 12 hours and even less after TAVI. And you know that Michael Mack has said previously, he said that when two procedures are equal, the less invasive procedure wins, like we see it here. And the problem came because, you know, Nicola Piazza put this nice slide a few years ago. And we all saw at the intermediate risk, low risk, high risk. You know, the problem was that the intermediate and low risk are not well presented in this coffee cup. The armar should be presented like this. And when the surgeon understood that this is the relationship, then the war started. Well, maybe we should have put it like this, then they would love it some more. And you know that this study will never ever be published in the New England. You know why? Because the same people are doing this and this. Not like in our profession, in which the interventionalists are doing the TAVI and the surgeons are doing surgery. And that's why I'm dictating my surgeons and I'm pushing them to come to my lab and know and learn how to do TAVI. Because Charles Darwin have said many years ago that it is not the strongest of the species that survive, not even the most intelligent, but rather the one that is most responsive to changes. Thank you very much for your attention.
Thank you. I would like to ask Dr. Cao to chair the discussion.
Thank you all the experts. Excellent lecture. Is there any comment or question from our moderators or panelists?
I'd like to have one comment about the three presentation. We have a very strong the confidence and the evidence about the TAVI procedure in the severe aortic stenosis. That is the viewpoint of the interventionist. But when we have the heart team discussion, the surgeon have a very strong resistance to the selection for the TAVI. So therefore, one of the wise method is Dr. Finkelstein said that the shared decision making. What I mean is that during the heart team discussion, we will always the hot debate about it, surgeon, particularly in the age is less than 75. So even though the attending physician, the patient prefer the TAVI, but the surgeon in the heart team discussion, this is the good candidate for the surgery. So you have to say to the patient, the patient take the surgery. So I think we emphasize the patient have a more strong their opinion to the surgeon and the attending physician.
Michael, do you have any comment?
Well, I think I enjoy both presentations very much. I think the important question nowadays is when we move to younger, lower risk patients, how should we sort of advise the patient, or how should we tell the patient according to the evidence? And then, in Asia, we have a lot of patients who would definitely refuse surgery, as Eric's case. He would tell us 65, 68 years old gentleman, I'm definitely not going to the OR. Either I will not receive anything, or I just will agree for a percutaneous transcatheter approach. That's very common in Asia. And in the guideline, patients' wish should also be taken into consideration. That's the first time that has been added to the European guideline. So can I just ask both of you, how much should we take the patient's wish into consideration, or their opinion into consideration? Knowing all the evidence at hand, even low risk, 73, 74 years old, but if a young patient comes in, strongly requests the procedure to be done, how should we advise them?
That's a good question, Michael. And I think we got quite robust evidence on TAVI versus surgical aortic valve replacement due to the last decades of trial. But again, we should be critical about the evidence. Don't be opportunistic. Look which patient have you actually studied and which patient have you not studied. So I think the heart team 2.0 should actually look at each individual patient, both physiology and also anatomical, and make a decision what would you recommend for the patient will be the best treatment option. And then you're going to sit down with the patient and try to advise them. But again, as Ariel was saying, it's going to be a shared decision-making, meaning that at the end of the day, it's the patient who's going to decide what kind of treatment does he or she want. What do you think, Ariel?
Personally, for me, I explain the whole thing is objectively. And sometimes it is some debate for the interventionist. Sometimes it is the surgeon. But the final decision from the patient. Well, when we look at the patient, the 75 years patient, the main problem of the patient is only isolated severe aortic stenosis. No, some patients have 5 years ago, I have a cancer surgery. 3 years ago, I have a prostate surgery. And I'm planted another surgery, extra cardiac, a lot of that. And then this year, you have planned to open your chest, only is a low risk. So final decision should be the patient and their family. Explain everything scientifically and everything, and final decision from the patient and their family.
In our hospital, we have very good cooperation of cardiac surgeon and cardiologist, because we perform the TAVR with the cardiac surgeon and the cardiologist. So we explain the indication to the patients, and patient's willing is the most important determinant. If the patient agrees to undergo TAVR, then we, after the discussion of her team, we proceed to TAVR. So
the changing hospital is I think is most the ideal hospital who cooperate the surgeon and the cardiologist. The other hospital in the world, maybe I don't think so.
Yeah, so we are running out of time. Can we have a last question before the?
No, I
yeah.
I just want to respond, because I think that we're going a little bit too far with what we mentioned, that we should consider the patient wish. There is a big difference between considering the patient wish or doing what the patient wants. Because I don't know a single patient in the history of my career that prefers to go to open heart surgery and not doing anything transcatheter. But I think that we should help the patient to get the right decision. And you know that the French says, c'est la ton qui fait la musique. It's the way that you are telling the patient what is better for him. And if you are thinking that the best thing for the patient is not TAVI, since he is young, he is having a bicuspid calcified valve, you can convince him that surgery is better for him. The bottom line should just tell him, hey, if I was you, I would go to surgery. So I just want everybody to understand that there is a difference between consider the patient wishes or doing what the patient wants.
Okay, thanks. We have a very good lectures and discussion in this section, but because of time, so I would like to close this section. Thank you, everybody. Thanks.
All right.
Thank you.
Thanks.
Bye.
Bye.
Hello.
So we have
hello, all my dear friends. I'm Dr. Yin from Jian General Hospital, and I think the next session will be a very, very attractive and interesting one, because we get together the surgeons and the interventionists together to discuss the therapies of mitral valve disease. With us will be distinguished guest Dr. Norman Pan and Dr. Meng Xu, Dr. Thomas Modine, Dr. Moderator, Tramaso, me and Dr. Gu Tianxiang, and beside me is Dr. Li Yongzai. We will have several lectures, including a case in a box, two cases in a box. So I would like to invite Dr. Nguyen Van Fan to present the first talk. The first talk is entitled Surgical Mitral Valve Repair is Still Gold Standard for Mitral Regurgitation. Dr. Nguyen, please.
Thank you very much, Dr. Wei. Good afternoon, ladies and gentlemen. So my talk will talk about the mitral valve repair is a gold standard. And we have almost more than 30 years experience on mitral valve repair in our center. So that I would like to show you our experience here in Vietnam on mitral valve repair. And as you know, from 1992 to 2018, repair 2,754 severe mitral regurgitation in our center at Ho Chi Minh City, Vietnam. So in the past almost 30 years, I worked in the same hospital, the same heart team, and I using the same technique of mitral valve repair. I mean, cap puncture technique, and we have the same method of follow-up. This is our center, Heart Institute, located in Saigon, Vietnam. So the capacity of surgery, we perform about 1,700, including genital and adult surgery. And we have the training program for mitral valve repair, 12 years. Many surgeons come from come to learn from our center. And I work with almost the same team in the last 30 years. And I use the same technique of Alain Lars in Paris. We almost perform exactly the technique I learned from him from Paris, also in Vietnam. So the feasibility of repair mitral valve depend on pathology. For rheumatic disease, we repair 75%. Degenerative, we repair 96%. Endocarditis, we repair 72%. And for congenital MR, we repair almost 100%. In the past 30 years, we already tried all the techniques to repair the mitral valve for both anterior leaflet and posterior, like the chordal transfer, chordal shortening, chordal plication, papillary muscle sliding plasty, and so on. For posterior leaflet, we do both a resection technique and a preservation technique with the artificial cork. And for type 3 disease, mostly seen in rheumatic valve, we also perform many different techniques like resection of secondary cork, penetration of the fused cork, papillary muscle splitting, leaflet extension, and so on. So I would like to mention now first how to repair the posterior leaflet collapse. Of course, for posterior leaflet collapse, we have two main techniques: preservation of the valve and resection. So the resection technique we have done many years ago, and almost more than years. And the resection technique already proved a very good technique. Maybe we do triangular resection or quadrangular resection, and on the severity of the prolapse also depend on the location of the prolapse. So the first video clip I would like to show you, so this is a P2. In this case, you can see we have the P2 prolapse with perforation of the posterior by ancient endocarditis. So the leaflet tissues are thickening, some fibrosis, and we decide to resect the valve in this case because the quality of the leaflet is not good. So when we repair the posterior leaflet prolapse, the decision to repair or preserve the valve depend on the quality of the prolapse tissue, and also depend on the the severity of the prolapse tissue. So in this case, we just remove a carangular resection, and then we need just 1 or 2 application suture for the annular, and then to approach the leaflet together. So this is the fundamental technique for posterior leaflet prolapse, and I do know that we already performed this technique for many years, and the long-term outcome of this technique has proved very good result. In our center, we perform this technique more than 25 years, up to 30 years, and the long-term results are also very good. So I know that actually we have another technique to preserve the valve by neocore, and the long-term results of this technique also are good. But I think the resection technique we should keep because in case we cannot perform the preservation technique, at least we also have another solution to go. So after resection the prolapse part of the tube, now we do the suture, and normally we need about 12 to 14 ring suture for the whole periphery of the mitral valve. So this patient, the anterior leaflet corresponded to the size of number 30. We test the valve before we implant the prosthetic ring. So now we slide down the ring number 30, tie the suture, and then we test again. So we have a very good result. So the long-term outcome of resection was improved for many years. You can see here for posterior leaflet prolapse alone, Dr. Carpentier's team showed that after 10 years, 98% of the patients do not need reoperation. And after 20 years, 96% of patients do not need reoperation. In our center, more than 25, we also have a more than 95% of the resection technique patients do not need the reoperation. So besides this technique, we also have another procedure that is a preservation of the valve. In this case, you can see we also have P2 prolapse, but the valve tissue is very good, not very thickened. The prolapse is due to rupture. And I think in this case, we should preserve the valve. We preserve the valve by implantation some artificial core. So first of all, we do the ring suture. You know, actually, when I do the ring suture, I never take the valve tissue with my pickup. I try avoid to touch the valve tissue with your pickup. It easily damages the tissue. And I call this is a no-touch technique. It means that we repair the valve, but not touch the valve tissue so much. So this case, we can use the anterior papillary muscle for the first neocore, and we pass the neocore through the tip of the papillary muscle, and then the needle go through the valve tissue. So the distance between its needle is about 5 mm. You see the distance between the suture from here to here is 5 mm and 5 mm. All right, then we will tie down the suture at the same level to the reference point, my reference point is located here, and then the needle will pass down to the ventricle. We tie down one more time, and then the knot bury will in the ventricular side. So in this case, we can use the ring number 28, physio ring. Then slide the ring down, and then we test. So for posterior leaflet prolapse, you can do both resection technique or preservation technique, and I think both techniques are good. Now we move to the second part, endocarditis repair. So for the Anderson endocarditis, the principle of repair is the same with the other pathology. for the acute phase of endocarditis, it's more challenge for the surgeon. For example, in this case, we have the visitation at P3, and this is acute endocarditis. The visitation first. Then I would like to expose the mitral valve better with the ring suture. In case the left atrium not big enough, like this case, we expose the mitral valve. And then now we continue to dissect some vegetation at the other location of the valve. So this patient has a severe mitral regurgitation due to endocarditis attached to the rheumatic mitral valve. So we found out very good secondary cork here. So in infection tissue valve, I don't like to use the neo cork. I like to use the native material more than the artificial material. So before we implant we transfer the nail cork to the freeze. Of course, we need to clean the leaflet tissue with betadine many times. So in this case, you can see we can move a good secondary cork from A2 to the freeze at the junction between A2 and A3. And then in this, in case of acute endocarditis, I also try to avoid the ring. I just like to use the pericardial strip to do annuloplasty. Fortunately, in this case, the dilatation of the annulus not too much severe, so that we can use the pericardial band just from commissure to commissure. So we slide the band down, and then we tie down the suture. So we verify everything before we test. So we also have a very good coaptation. Now we move to the other situation, commissural and bileaflet prolapse. This is one of the most delicate situations. So sometimes we have the prolapse at the adjacent area to the commissure is A3. In this, I prefer to do coronary transfer here or artificial for this area. Or in case we have the P3 prolapse like this, you can resect the valve and use artificial core in this case. Now it's more complicated, is that if we have the A3 prolapse and posterior commissure prolapse, so in this case, you can do the coronary transfer and edge-to-edge technique here. At the commissural area, I just like to close it with some inferior stick here, because we need to do very good repair at this area, because we have some leak come out here. It's very close to the ring later, and it may have a hemolysis when the leak touches to the ring. So, and if you don't want to preserve the valve, of course you can resect the tissue here. The most delicate situation is you have both leaflet prolapse. I mean A3 prolapse, P3 prolapse, and the whole commissure prolapse. The same thing with the anterior commissure. If you have A1 prolapse, P1 prolapse, and the whole anterior commissure prolapse, so you can resect the valve here. But if you want to preserve, I suggest we can use artificial P3, and then the inferior stick at the commissural end, like this case. In this case, we have the A1 prolapse, P1 prolapse, and anterior commissure prolapse. So I like to expose the mitral valve with the suture first. I will show you how much prolapse in this case. You see the prolapse should be located here, both anterior, posterior. You see, by rupture of the cord, we localize the prolapse by the two-stage suture at the junction between. So now we use the first. Now we use the first neocork pair for the A1, and then one more pair for P1. And here the anterior commissure prolapse here. I don't like to use the neocork here because it's not easy having the perfect resolve at this area. And if we have some leak come out here, it's very dangerous because it can be touched to the ring after that, as I have mentioned before. So normally we need the 1, 2, or 2 stick, 5-0, just to close the commissure. We test the valve before the ring. The valve already have a good function, and then we will select the ring. So in this case, I can use the Physio 2 number 32 ring, and now we slide the ring down. Okay, we test one more time, and I satisfied with this result. All right, now how about rheumatic mitral valve repair? So rheumatic is still presented in more than 60% of patients in our country. And the most frequent technique I perform is the cordon transfer. In rheumatic disease, we can do cordon transfer because we always have a very good and strong secondary. So we have a series of 324 patients cordon transfer. 85% of patients we transfer the cord from anterior leaflet to anterior leaflet. 15% of patients we transfer the cord from posterior leaflet to anterior leaflet. So one of the most important valve lesion in rheumatic disease is a valve is commissural fusion, and you can see it caused the mitral stenosis. So totally we repaired 3,600 patients, more than 2,000 mitral valve regurgitation, more than 1,000 patients with mitral valve stenosis. So to open the commissure, we follow this this principle. We open, open lastly the commissure until 5 mm to the commissure. Then we should do papillary muscle splitting and mobilize the posterior leaflet. All right, I would like to show you another video clip. In this case, we have a rheumatic patient with fusion of both commissure, anterior and posterior commissure. We have a hypertrophy of papillary muscle, very short cord. So we call this is a cord shortening syndrome. The leaflet tissue seems good, more than 15 mm. So now we open the anterior commissure. We start the incision at the middle first and then go to the commissure. So we stop the incision at 5 mm to the commissure. To avoid very small leak come out here, I like to do a magic suture, just run up the commissural area down to the ventricle, and then we can do papillary muscle splitting here, just to inside the papillary muscle. Now we move to the posterior commissure. This is a fusion line of the posterior commissure. We start open the posterior commissure and also prolong close to the annulus, a magic point to roll up the tissue, the leaflet tissue at the commissural area. We section some secondary cord to retract the posterior leaflet down. Totally, we can resect about 12 to 15 secondary cord to mobilize the posterior leaflet. Sometimes we need to resect some fibrous bridge between the papillary muscle, and here we can do papillary muscle splitting with the anterior papillary muscle. Resection some secondary cord for the anterior leaflet too. So totally we need to do many different techniques to repair the rheumatic valve more than the degenerative disease. In this case, we can use the 30 ring, and then we test the valve. You see, we also have a very good coaptation. It's just one example to repair the rheumatic valve. So the second technique I also prefer when we repair the rheumatic patient is the leaf extension with pericardial pericardial pass. So totally we perform more than 200 patients from 1992 to 2008. And you see in this table, after leaflet intention, we can use the last ring, even 30, 32, or 34. And even in the children, we can use at least 26 ring after leaflet intention. So this video clip, I show you how to extend the anterior leaflet. So this patient before extending the leaflet, surface area of the anterior leaflet just corresponded to the size of number 26. So we need to extend the anterior leaflet with pericardial pass. Inside, we inside the leaflet at 5 mm to the annulus, and go to the both commissure. The incision will stop at 5 mm to the each commissure. And to avoid the overcorrection of the pass, you can see here, we just use the two hook, just pull gently the anterior leaflet down just to the posterior leaflet. And you see this hole, we measure this hole. This hole will correspond to the size and the shape of the pass should be used. So this pass, this is autologous pericardial pass, was taken from the patient at the beginning of the operation. It was treated with glucuronidase at room temperature for 8 minutes. Now we fix the pass to the annulus with the 5-0 running suture. We also start at the middle part of the annulus and then go to the both commissure. So when we extend the leaflet like this, I like to put the smooth side of the pass in auricular side to avoid a very small thrombi can form in the pass. Then the pass was sutured to the mobilized anterior leaflet tissue with another 5-0 suture. We also start at the middle and then go to the both commissure. So by using this technique, we can increase the surface area of the anterior leaflet up to 30 to 40% the surface area, and it helps to increase at least 1 to 2 size of the ring used. For example, in this case, after extension, we can use the ring 32. So this technique have proved we already have a very long-term follow-up series of this technique, and the long-term results was quite good. Now, a question, how to perform a good mitral valve repair? Of course, we need a good heart team. So it's composed of cardiologists and the surgeon. We have to discuss together decide the technique used for the patient, and of course, we need a training program on mitral valve repair. I would like to introduce two training programs in our institution. We perform in more than 10 years. We have a 2-level for the basic course, called Advanced Mitral Valve Repair Workshop. Then when you have more experience on mitral valve repair, you can go back to my center again to move up to the second level, master, we call Master the Art. So this is an example of the basic course we call Advanced Mitral Valve Repair, performed in our center. And this is a higher level, we call this Master the Art. So the structure of the formation composed, number one, the participant will examine the patient by himself with the and then the doctor will discuss with cardiologists before surgery with TTE about the patient. We will do surgery the next morning. Then we will discuss, next morning we discuss about the patient before we go to the OT. We move to the OT. Then we watch the TEE again, discuss with the cardiologist about the pathology and also the technique we can do. Then we do surgery together, so the participant can join operation with me. And after that, we also have the wet lab. The participant will perform exactly the technique they have watched during the surgery. And these are some picture about the activity. I just like to limit the group no more than 10 participants, so that each of them can join me for operation. Totally in 3 days, we can perform 9 live operation, and then we have a chance to discuss about the surgery. So in conclusion, number one, repair the anterior leaflet collapse. I think we should preserve the valve more than the section, because the ring selection was based on the anterior leaflet tissue, so that if you resect the valve tissue, you have a less chance to use the last ring possible. But for the posterior leaflet collapse, in my opinion, either resect or respect is also good. So the surgeon should know both techniques, because one day, if you cannot preserve the valve, at least you can resect the valve instead of you change the valve. And of course, we did the quality training program for mitral valve repair. And I hope that with this training program, you can have a more advantage in this reconstructive surgery. Thank you very much.
Thank you, Professor Fan, for your comprehensive lecture about the mitral valve repair. Because we have a little bit behind the schedule, so maybe after all the lecture, then we have an open discussion for each other. So I'm Dr. K.C. Lee from Zhenxing General Hospital. Let me introduce the next speaker. The next speaker is Professor Meng Xu from Beijing Hospital. As we know, the Professor Meng Xu is expert about the mitral valve repair, no matter in conventional or minimal invasive for the mitral valve repair. So currently, Professor Meng Xu is the director of the cardiac surgery, the chief of the cardiac surgery doctor in Beijing Anjing Hospital. His talk is his title in mitral repair in rheumatic heart disease. Let's welcome Professor Meng Xu.
Okay. Good afternoon, everyone. So I'm glad to introduce the Chinese experience on the rheumatic valve repair.
Could you share your monitor with us?
Let me.
Okay, we can see the monitor. Yeah, great. Go ahead.
Yeah, okay, thank you. So for the mitral valve repair, so it's the Carpentier said in 1983. So that's the first time in the history of the valvular disease. So patients can be cured for the rest of their life. But how about the rheumatic valve disease? I think this is the big confused problem in China for most of surgeons. We confused about that. Very few repair can be done in China. So what's the problem? I think the main reason is we have no a standard procedure that's easy to be sprayed or repeated by most surgeons. Recent years, we have reached researched some pathological characters of the rheumatic mitral valve in Chinese patients. So we can find some features like this slide shows. In the pathological evolution order, the commissural fusion and the valvular edge thickening are most the proportion. The severely valvular thickening or calcification less than 20%. So according to our study, we think abnormal mobility of the rheumatic mitral valve results from the fused, stiff, and thickened commissure. The fused and the stiff commissure hamper the stretching and the retracting of the leaflet during the cardiac circle, which lead to the cooperation failure. So valvular edge thickening do not affect the cooperation of the leaflets. So we think if we have the good manage for the commissure pathological change, maybe we can finish a good functional mitral repair. So this is the square procedure. We can call that the 4 steps. The square procedure include the first one is the shaving, and the second is checking. Third is the commissurotomy, and the fourth is the subvalvular relaxing. So that's shaving. This means firstly we remove the commissure fibrosis plaques. Then we can recover the mobility and the flexibility of the commissure. Second is the checking. The checking means after the first steps. So when we losing both leaflets, we can find the groove at the commissure area. Then we can detect the exact natural shape of the commissure border, which is the commissurotomy, line and the cutting endpoint with knife. So third is the commissurotomy. That means we perform following the natural shape of the commissure border. Then the cutting line is the stop the commissure leaflet edge. So after the first 3 steps, if the open distance of the leaflets were not enough, so we have to do some papillary muscle spleen, then fuse the subvalvular apparatus. This is some key points. We think the order of the 4 steps cannot be changed for most of the patients with rheumatic disease in China. The anterior leaflet area is enough. Most of cases, that's enough for the repair. The thickened leaflet edge and the shortened cord do not affect the cooperation of leaflets. So it's very important that surgeons recognize the relationship between the cutting line and the commissure leaflets. So if you do any injury to the commissure leaflets, is the main reason for the surgical regurgitation. So this paper that's received by the GTCVS. So the magazine provided the link to our video of the 4 steps procedure. So let me see the video. This is the female old woman. So you can see that's the before operation. That's the echo and then the pathological change. So that both the commissure confused and the severely shortened cords. So firstly, we remove the tissue plaque. That's the first step. Then lose the the leaflets, we can find the groove. Then according to the groove, we can show the natural shape of the commisure. Then we do the commisure rotary. Last, do the papillary muscle spleen. Okay, let's finish the anterior commisure plasty. So for the posterior commisure area, the similar procedure repeated. Remove the tissue plaque, and checking, find the groove of the commisure line, then do the commisure rotary. Okay. We need to manage some the cord, a shortened cord, or some the valvular edge thickening. Just the water testing. Then measure the size of the artificial ring. Put in 22 artificial ring, then test. So post-operation, we can that guy that's the Ariel can get the 3 cm square and no regurgitation. So the paper we showed that this time the 1,600 consecutive the patient with rheumatic heart disease. So repair about the more than the 600 and replacement the 1,000 cases. From the entire study population, 529 matched pairs with the similar demographic and clinical characters were obtained by the PS analysis with the reasonable standard differences. So the mean age is about 54. Female patient occupied 70%. The mixed lesion type occupied 75%. The average the follow-up time about the 5 years. So the reason we can the result we can see the death from any cause the death. So for the repair compared to the replacement, only the 0.38, and the risk of the valvular related complications for the repair compared to the replacement about the 0.44. So the conclusion is the score procedure is the standard procedure and easy to be performed. This procedure can be performed by more and more Chinese surgeons. Okay, that's all. Thank you for your attention.
Thank you, Professor Meng-Xu, your excellent talk. As we know, Professor Meng-Xu also master in some neo-coast mitral valve repair. So I think we after the subsequent lecture, then we discussion together. So let's move to the next speaker.
The next speaker is Thomas Modine. He's a professor of the Lily University, just moved to Bordeaux University Hospital, and he was quite famous in China and French, and he did a lot of work in mitral intervention and open surgery, including minimal invasive mitral valve repair. So that we hope to hear about the percutaneous mitral valve intervention, repair versus replacement, and he will share us a case in the box about transcatheter mitral valve repair. So that's please. But Thomas Modine.
Good afternoon, everybody. Can you see my screen?
Yeah, that's not yet. Please share
Okay.
us the screen.
Only your camera.
Yeah, okay. And now you must have it.
Yeah. Yeah. Great.
Yes?
Yes.
Okay.
We see your
good.
screen. Yeah.
So, good afternoon, everybody. I'm very pleased to be with you, and hopefully next year we will get together physically and meet face to face. I'm very honored to be part of this session. After these two wonderful talks by great friends and surgeons about mitral surgery. So this positioned the question, and very important to repeat what have been said before. Mitral valve repair is superior to surgery, to replacement, but you have to master all the tools of repair and not limit the use of repair as it's done currently to edge technique. So mitral surgery repair, which showed superior results to replacement, is a combination of different techniques that have been shown by Professor Meng and Professor Nguyen. So it's really very important to understand, because the objective is always to offer the patient the best therapy we can get. So I am a cardiac surgeon, but who has a lot of interest in interventional cardiology, and this is very important. And it's my honor to share this experience with you. So you may know that mitral valve disease is much more prevalence is much more superior to aortic valve disease. So I think it's very important to keep in mind that we have more patients, but patients with different profile. And whatever is the profile of the disease itself, degenerative functional, and if it's degenerative rheumatic, or only because of a Barlow or fibroelastic disease, we have to keep in mind that the patient who have a mitral regurg, even if it's asymptomatic and don't treat the mitral regurg. So I think it's very important to change the way we look to mitral disease and not wait too long before operating on these patients. I think this slide, this work from Enrique Serrano, which is 15 years old now, to be sent to surgery very quickly. So again, mitral valve surgery have some rules. It has been reminded. So we have to try to repair whenever it's possible. But I'm sure that Professor Meng, Professor Nguyen had a lot of patients in their hands, and sometimes repair is not feasible. And sometimes the replacement is possible in that case, and you have to replace if you cannot repair, but you have to consider replacing if you think that the result is not good. And also you have to replace if at the end of the procedure or after the procedure, the repair is failing because the control is not good. And I think in this landscape of mitral disease, we have also to understand what have been stated before among time. So the surgeon sits with the echocardiographer, discuss the case. We look at the etiology. We look at the expectancy of life. If the patient is young, is old, and also the comorbidity. If we want to make the operation short, at high risk, long cardiopulmonary bypass duration, or if you want to be sure that you want to do a short cross-clamping time. So I think it's very important to keep all this in mind. And again, you have to consider different techniques if the disease is mainly needs a leaflet repair, calder repair, annuloplasty, or all of the above. So this is the landscape of the cardiac surgery for mitral disease now. However, we have to know that mitral valve replacement, if you look at the global activity all over the world, is 50% of the patients that are treated are getting mitral valve replacement. So we cannot ignore this therapy, and we have to see if we can make it better or not. I'm really personally shocked by all the results, because this is not our experience, that we have more complications after mitral valve replacement versus mitral valve repair. In real life, when you try to preserve the posterior and the anterior apparatus, if you respect the codes as has been said, and you replace the valve quickly, it doesn't give that much complication, except the complications related to anticoagulation when it's needed or not. So it's really very important, and I prefer to leave the patient go home with 0 grade mitral regurg than grade 1 with the mitral repair. So I think this is very important to keep in mind, but we have to fully spare the mitral valve, because if you want to achieve a good replacement, you have to preserve the anterior and the posterior mitral valve, because otherwise, if you just cut a part of the valve, even a part of the valve, the results are not as good, and that is why I think repair is much better. So when it comes to percutaneous treatments, so usually there was always some surgeons behind the idea of repair percutaneously. It's not only an engineering or a cardiology idea. So we wanted to replicate, to repeat what we have been doing in the operating room, and do it percutaneously. And this is why and how the first edge-to-edge implantation has been done in 2003. So in 2003, 1 year after Alain Cribier did his first TAVI in man, we had the first in man done in more than 17 years after. We cannot say that edge-to-edge has been showing as the results as good as we have with TAVI or the mitral repair, that we do it surgically. And if you look not only at the publications or the randomized controlled trials, which are on highly selected patients, controlled and monitored by committees who accept or decline the patient. If you look at real life, so what happens in registries that we collect, and we are very grateful to have this level of data collected at the TVT STS registry. You look at the registry and see that in real life, the results are not as good as we want them to be, neither in terms of mortality, length of stay, and outcome. And you can see here that even in the leave the one month after this, it doubles. So we have to know why an operation which works in the hospital, when the patient leave, go back home 1 month after, it doubles. So this is not really satisfactory. And 1 year after that, it's not also very giving it the satisfaction we want. So, but surgery could teach us a lot. This is a paper. Remember, the edge-to-edge repair has been shown to be superior to medical therapy. It has never been shown to be superior to surgery so far. And if you look at what we have learned from surgery, that in mitral valve repair, if you compare it to replacement in patients with severe ischemic mitral regurg, which is a huge percentage of patients that we have to treat, it showed clearly that if you only repair, you have much more, significantly more risk of recurrence of the mitral regurg if you replace, shown to be more effective therapy on the mitral regurg itself if you replace it. Then we had mitral FR and coax, which were two studies. The problem with these two studies are showing, so they are addressing two different populations with two different approach, with two different selection bias that cannot give us the satisfaction we want. And we still really don't understand who's a good patient for edge-to-edge repair in the functional mitral regurg in comparison to what we could do it with surgery. But I think we have to look back at the results we have in our real life with the surgery, as I've been saying. This is a very important slide. It shows taken from Everest 2 realism cohort. And it shows clearly that the results in terms are not the same if you are addressing on P2 prolapse, which is the easiest one, and in comparison to the posterior flail, anterior flail, or B-leaflet prolapse. Of course, the more the disease is complex, the less the results are good. And it ends up with a qualification or scoring of the mitral regurg, which always turns around 2+, 2-. But if you look at all the literature of surgery, you never see in the mitral repair, we have a mitral regurg of +2- or less. So we have created a new self-satisfaction after the mitral clip or edge-to-edge repair, which I think we cannot accept or wish to our patients. And I think in that case, we have to look at something else. This is corroborated by, again, the TVT registry results, where it shows clearly that if you have a residual mitral regurg of 3 and 4, it has a negative impact in terms of survival versus grade 1 and 2. And this is really not important. So we have to think carefully about the way we treat our patients. The same thing, if you, from this registry, it shows clearly whatever you are doing or treating functional or degenerative mitral disease, with your follow-up over time, we still have a mortality rate ranging from 24 to 50% at 1 year. And I think this is unacceptable from any therapy, except if you don't have any choice. One of the other disadvantages of the gold standard of percutaneous repair systems today is that if you put a clip after a couple of months and you have a mitral regurg again, what do? So you can add one more clip, but you take a risk of having a higher gradient. So you treat the regurg, but you induce a mitral stenosis, which is not very for the patient, or you have to put the patient on the table and operate on him where you didn't want to send him to surgery from the beginning. So I think the selection of the patients is very important, and the long-term outcomes are not only 1 or 2 years in this population, where the mitral regurg patients, you have seen it in the slides before, are usually younger than the aortic stenosis. So no confusion. So these are the limitations of percutaneous edge-to-edge repair, and it applies for the mitral clip itself, but also it applies to the new game player, which is Pascal from Edwards, which is more or less the same approach while trying to grasp the anterior and the make the system a bit bigger. If you don't want to treat only the leaflet disease, or you cannot treat only the leaflet disease because you have a disease which is related to elongated cords or ruptured cords, you can use what we call the neocord and the harpoon. The neocord and the harpoon are so far still transapical systems. So they have to be done by cooperation between surgeons and cardiologists, which is a very, very good for a heart team approach, but it's not fully percutaneously done. And the neocord is approaching a transeptal system, and some other competitors are coming soon. We will have the chance later on to talk about them. I think next year we'll have new technologies coming from the side. And the advantage of neocord, for example, is that if you have a young patient with only elongated cord, you put 1 or 2 or 3 cords, and you still can do a surgery in the future. You just delay the date of the operation itself. Usually it needs more than 2 or 3 cords to achieve perfect coaptation thanks to these cords alone. And the disadvantage, of course, you have to accept it, that there is no annuloplasty. You have seen it almost in all the cases when you do mitral repair, and I think this improves the durability of the repair. We add an annuloplasty, surgical annuloplasty, that fix the repair itself. So this is a new game player. It's called CardioMech. It will come probably next year. We have the chance to talk about it. It's a transeptal neocord system. If your disease is related to the annulus dilatation, achieve an annuloplasty. And to achieve annuloplasty, you have the indirect annuloplasty with one of the eldest systems, which is the Kang-Yin. But you can immediately see the limits of such system. First is a partial, very partial reduction of the annulus itself. It's made of nitinol, so you may lose some radial force over time. The problem is also depends on the anatomy of the coronary sinus itself. And in patients with dilated hearts, the coronary sinus is not anymore at the level of the annulus. So, and because it's above the annulus, it's unlikely to be effective to reduce the annuloplasty. This is how it works. It's a very easy and quick operation. The issue is the efficacy of the operation. There is a new system now that we have, with which we have started a CE mark study, but it's also a study running in US, which is called AccuCinch, and are addressed to patients with functional mitral regurg, and it reduces the basis of the heart. It's more to reshape the ventricle, but sometimes it ends up with reducing also in the same time the mitral regurg. So sometimes you need to do a direct annuloplasty, which is more similar to what we do in surgery. And this is what has been suggested by Mitraline, which reduces the anteroposterior distance, or supposed to. Mitraline had the CE mark, but this technology disappeared. You have also the cardioband, which is an indirect annuloplasty. So this is one of the, it's direct annuloplasty, but incomplete one. This is one of the disadvantages. And the other disadvantage is it relies very highly on a perfect imaging. So you need not only one learning curve, but two, and the imaging is much more difficult. Have also this system called Millipede from Boston Scientific, which is supposed to achieve full circular annuloplasty. But again, you can imagine with all this metal that the imaging is not going to be very easy, because the catheters are interposing between the mitral valve and the TEE probe, and it renders the operation much more difficult. This is a system that we have tried also in Lille from a startup called Valcare, the Amend. It's still to date a transapical, fully rigid annuloplasty. It's really very effective. We tried it, and we did the case 3 years ago, and the patient is still doing very, very well without recurrence of the regurg. But again, isolated annuloplasty addresses only a minority of patients that we have. So you see, in the landscape of replacement or repair, we have different approaches because they are dedicated to one view or another of the disease itself, and that never combines what the surgeon is capable of doing. And we have to be very careful when we select the patient. But it's definitely not a fight between those who believe in percutaneous therapy and those who do not believe. It's not a fight between the cardiologists and the surgeons. I think it's the way where the future is going, and I think we have to combine our efforts to make this a success, because many patients will need it, because many patients cannot be operated, and many, even if operated, they cannot always be operated by skilled surgeons like we have on the panel today. And this is why mitral valve replacement, I think, is the common denominator between all these techniques. As I said, remember that more than 50% of the patients all over the world are still replaced surgically. And if we consider that the operation itself is at high risk, we have to reduce the morbidity, and because this is an unmet need. So in 2012, the first in man with the transcatheter mitral valve replacement has been achieved. And since that time, there's a lot of efforts to take and make iterations, reduce the profile of the valves, and from transapical make the move to transeptal. The advantage of the replacement is that it treats mitral regurg, but also mitral stenosis. And the biggest, I would say, player is the Tendyne mitral valve system. I know that Maurizio will be talking about this, so I'm not going to overlap. So this is a valve that is attached with a pad using a tether. I think Maurizio will show you also a live case. It's extremely easy to implant, as you can see it here. and it's also extremely efficient because it eliminates mitral regurg, and the patient does not leave with mitral regurg 2 plus or minus. He has or he doesn't have a mitral regurg, and I think this is the way we should approach it. This is quickly the results at 1 year of the first 100 patients in which we included the first patients that have been done, which means with the learning curve, and it shows a very good satisfaction in terms of 1 year survival. What you may know is that these patients have been contraindicated for everything. So these patients are usually only left to medical therapy. So they have been treated with the Tendyne system. And as what you can see here, that the efficacy in terms of eliminating the mitral regurg is just fantastic. You can see it, and the result is stable over time. We next week at Euro PCR 2 year, and it's exactly the same. So in patients who are contraindicated for everything, being able to achieve this kind of results is really very, very exciting. And it eliminates, as I said, this is what the patient needs, in a mitral regurg in the majority of the cases. What we have learned with this catheter mitral valve replacement is that even if the majority, because this is the case, more than 80% of the patients had functional mitral regurg, replacing them had a clinical benefit as it's reflected by NYHA functional class improvement, and which remains stable over time. So it's not true to consider that patients who have a functional mitral regurg cannot be operated, and eliminating mitral regurg does not have any benefit. It does have a benefit. Now we know it thanks to this replacement done perfectly. And of course, we have to show a clear benefit, and this is why randomized controlled trials have started. The summit with the Tendyne system, and the Tendyne also has been used in the MAC, in severe MAC. I will show you. Look at this massive amount of calcium. This patient has been done by Paul Soraja team in Minneapolis. And we know, even as surgeons, there's a high risk of annulus rupture here or dislocation. And we want to avoid this. So the Tendyne system is very effective in that case. You can see it here, started by a valvuloplasty, and then the valve has been implanted, and it gives great, great satisfaction. I think we are very happy with this. The second biggest player is, of course, the Medtronic Intrepid system, which also ease of use. It's transapical so far today, but the iterations, I'll show them to you. It's extremely easy to implant, and the new generation of this catheter makes this valve recapturable and repositionable. And it's also, this is one of the patients that we did in Lille again. It's more or less the same implant technique as with the Tendyne. You have to open the valve in the left atrium, bring it back to the level of the annulus, and then check everything on echo. And you use the biplane view just for the mitral clip. Oh, sorry. Just as for the mitral clip. And then there's a new iteration coming with the transeptal system, transfemoral transeptal system. This is how the Intrepid valve looks, an outer disc and internal disc. But we'll talk about it later. So today we have a recoverable system, transapical. We are this valve implantable transfemoral, and other iterations are coming in the future to reduce the size of the catheter itself. Just as I showed you with the Tendyne, the Intrepid system showed a clear efficacy where patients leave the hospital without moderate to severe mitral regurg. It eliminates mitral regurg, and I think this is going to be a game changer. There is a randomized controlled trial running in the US, and it's coming to Europe soon. And there is an arm also in which we show that Intrepid is also implantable in MAC patients. And I think this is a very important thing for the patient. Some other devices quickly. The Tiara valve, which is a D-shaped valve. It's a very old valve, actually, that works very well. And it's implantable using transapical approach, the M3 from Edwards, which reminds you very quickly the S3 covered by more tissue, and it needs a duct that runs around the cords and submitral apparatus, and in which you come and implant the Sapien M3 valve, M3 for mitral, of course. The ancestor, so the EVOKE is the iteration, the latest iteration of cardiac Q with which the first in man has been done. It's also now tried at the level of the tricuspid space. This is a European valve called High Life. It started transapical, and now they started a new CE mark study and a global study with the transceptor system. There are some problems or limitations of the transcatheter mitral valve replacement so far, which are the high profile, long profile of the valves, which induces a left ventricular outtract risk of obstruction, and this is why there's a lot of patients cannot. But also the size of the annulus itself, because these patients come very late to us, and then also the transapical system in patients who have a very weak hearts. So this is the cardio valve. Cardio valve is a very interesting valve, which reminds you the surgical ones. It addresses one of the unmet needs today with a very short and profile, which eliminates the risk of LVOT obstruction. Of course, this is the beginning of this valve, and this valve is implantable transeptally. We have to wait and see what happens in the future. And one of the most interesting valves today that we had the chance and the honor to do the first in man in Lille, and now there are more than 10 cases that have been done with a really very satisfactory result. So this is the first patient we did. Had one rig back, as you can see it here. It has also a very small, low profile as the cardio valve, which reduces the risk of non-eligibility because of the LVOT obstruction. And it achieves a really great satisfaction in terms of eliminating the mitral regurg, low gradient, and no LVOT obstruction. And we have to be, I mean, Asia is very active in the field today, and there are many, many devices coming from Asia, mainly from China, that reproduces the approaches that I've been talking about, leaflet repair, cord repair, or simply a mitral valve replacement. So I think really we have to keep in mind that mitral valve disease cannot be approached at the aortic stenosis because of the variation of the disease itself. And I think percutaneous repair is unlikely to reproduce what surgeons are doing, because we do a combo approach in almost in our patients surgically, and I don't think, but maybe we're wrong. Only time can tell. If you want to be sure that we can fix the annulus, repair the cords, and eliminate the regurg, one approach device is too simplistic in my eyes to make it happen. With the edge-to-edge repair, there are some limitations, and even it needs also some skilled hands, but also it needs skilled eyes, which are the echocardiographers. And for that reason, complex cases for edge-to-edge are in favor of transcatheter mitral valve implantation or replacement, because you can implant it almost on everybody, providing that you have eliminated the risk of LVOT obstruction. And this is one of the algorithm I propose. If you are a cardiologist or a surgeon that you can do all of the techniques, you will always choose the easiest one and the best one for your patient, and you can do what we call in France an indication à la carte, a personalized medicine, and not one therapy for everybody. This is not the way science and surgery working today. Thank you very much.
Thanks for Thomas' innovative lecture about the new device in mitral valve repair through the endovascular technique. So would you, Thomas, would you please proceed to the case in the box, show your case about transcatheter mitral valve repair in your institute.
Yes. Thank you very much. So if you can run the live in the box that we have recorded.
Yes.
Good morning from Valve Summit, Bordeaux. Can you, yes. So France, thank you for the invitation to share this recorded case with the Taipei Valve Summit, which goes virtual this year. Unfortunately, due to this pandemic, we have to get separated, but fortunately on site and discuss further implications of this new therapy. So we're gonna show you a case of a mitral regurg, but before treated by a mitral clip. So the case that we chose to show you is a mitral clip edge-to-edge implantation case. Next slide, please, of a patient of 85-year-old who has been admitted for pulmonary edema due to heart failure. In the history of this patient, we can find an AViV with a transient ischemic attack, fully recovered. And when we did the testing examinations, we could have found a severe mitral regurgitation due to P2 prolapse. Professor Lafitte will explain thoroughly the anatomy of the valve, which led us, based on a heart team decision, to propose this patient for the mitral clip, which is the gold standard today for the transcatheter mitral valve repair solutions. We believe that this mitral regurg is not very new, and that this could explain the pulmonary hypertension. We, of course, assessed the coronary arteries circulation, and I will show you the outcomes that we could find. Fortunately, this patient, despite the age and the chronicity of the disease, has a good left ventricle ejection fraction. Next slide, please. So the coronary angiogram showed on the right, for the right coronary artery, a non-significant disease. However, if you look at the left coronary artery, next slide, please, it showed clearly a left main stenosis, significant stenosis, and this could be subject to a discussion with you later on. So we decided, given the age and the symptoms, which are related more to the mitral regurg, and based on the fact that the patient has a chronic coronary artery disease, together with the frailty of the patient, the high STS score, we considered the patient better and suitable for first mitral clip procedure to stabilize this lesion, and secondary coronary angioplasty for this particular patient. So this is a very interesting case.
So we have now in our university hospital a new Philips Azurion FlexArm hybrid room, which is very comfortable for us to show you this procedure. And thank you to Astrid, thank you to Stéphane, thank you to Catherine, thank you to Louis Labrousse, our chief, to be here today for this special mitral clip for Taiwan.
You see on the screen the very usual en face view, in which you can see the mitral valve, the aortic valve on the top of the screen. On the left, we have the left atrial appendage, which allows to describe the three parts of the mitral valve. With the zone 1, which be located just here, zone 2 in the middle of the mitral valve, and zone 3 on the right of the screen. It's quite an evidence that we have a prolapse, which is mainly located in zone 2, precisely located in the lateral part of zone 2. And we also can observe a small coronary rupture that could be confirmed on 2D imaging. Add the color Doppler, we see that there is a huge mitral regurgitation. And now we can go to the 2D imaging, and especially in this bi-commissural view, in order to better analyze and assess this prolapse. This image confirms that the main prolapse is located to the lateral part of the zone 2. By adding color, we can assess the extension of the regurgitation. The regurgitation is severe. Pisa radius is above 2 centimeters, as you can see here. Very nicely, we can observe the prolapse, and here, the coronary rupture. We can also measure the gap between the two valves, posterior and anterior, which has been measured to 7 millimeters.
So thank you, Stefan, for this extensive analysis of the mitral valve. It's very important to have noted the different analysis of the mitral valve, because this will define the strategy that you should adopt. And putting all this together, the strategy of the team was the following: we will start by using an XTR clip, which, as you know, is longer and could achieve better anchoring at the level of the leaflets. And the idea behind is to achieve a better capturing of the leaflets and, of course, increase the forces of the edge-to-edge final result. So, and then if we need one more additional clip, we may use an anti-R clip.
The beginning of a procedure is the right femoral access. So we used to secure it with 2 proglides in order to close the vein at the end of a procedure and reduce bleeding. And for the transeptal, we use the Baylis needle. It's a pre-shaped needle, as you see here. And we have some cautery capacity at the tip to close the septum. So, okay, thank you. So first you see here that the guide wire is in the superior caval vein. And so we put the sheath into the superior caval vein. We arrive here in the right atrium, and we are here correctly positioning in the superior caval vein. So you notice that the sheath itself is a pre-shape. And under echo control, we'll be able to go down along the superior caval vein and after along the septum itself in order to puncture at 4.5 centimeters regarding the mitral plan.
During this step, usually we, from the echo part, we are placing marker which will be on fusion. In order to target the best function directly on the X-ray image, as you can see on the right.
We just have to target the red dot, moving very slowly the catheter from superior vena cava to the septum. So it's a good puncture site because we are between 4 and 4.5 centimeters from the mitral valve. So we will be able to navigate in the left atrium, and we now have to complete the heparin. So we will now navigate inside the left atrium. So we will move on the sheath in the left atrium.
So Stefan, I need to see the
But during this time and just before, Lionel, I'm just assessing the pericardial to have some reference in terms of no effusion at this step.
We will use Super Stiff from Boston to securize the positioning. Inserting this guide in the superior pulmonary vein. This dilatator is a 18 French shears from Cordis, which is only to have a dilatation of the entrance of the vein. And we will add some minus to have a straight tip.
And the echo will be very important at this step in order to guide totally the passage from the right atrium to the left atrium. Trying to waiting for us at the best point, combining these two explained views.
So we are coming very close to the septum. Now we will check in echo to see the tip of the guide coming first and then the guide itself. So there is a little bit of tenting at this step, and like you see, we can do some rotational motions to help the guide coming inside.
It's in.
And we agree that the guide is inside, so as you can see, it's not a long way.
Okay. Confirmation from 3D, as you can see. The two markers from the guide are inside. So it's a very nice view of the extremity of the tip of the guide. At this step, I'm going back to 2D images in order to place a new fusion marker. Which will be the reference marker, allowing to control every time the length of the guide inside the left atrium.
So at this step, we will remove the dilatator, check the length of the guide inside of the atrium. So it's around 2 centimeters. So we can now remove the wire inside the dilatator and under aspiration, remove all the system.
And now we can have this marker on fusion imaging. I will zoom on this image.
C'est vrai que
j'ai peur que tu vas être dans le plan et comme t'es pas stérile, j'ai peur
you
que
see,
ça fasse mourir.
The blue marker corresponding to this a very important part of the septum again, which definitely will allow to have this distance, this length of guide within left atrium. So for sure, you can imagine the risk when we will move a little bit later on the external device with very small motion can yield in a back motion of the guide inside the right atrium.
All right, so we are well installed in the left atrium. The clip, as you can see, is ready. We will introduce it. Perhaps when we will be at the tip, we will do the fusion with echo and fluoro to have the anatomy of the left chambers on the screen at the same time of the fluoro. So at this time, we have to be very careful on the alignment of the blue lines to be able to have the good motion inside the left atrium. So here we are with the clip. And Stefan, if you agree, we will do the fusion with rotational acquisition.
Just now we will do the modelization of the heart. For that, we perform a 3D full volume of the total heart acquisition. And when we are combining two X-ray views in order the system to recalculate, integrating the modelization heart shape for this this kind of results. We have on the screen of the X-ray, you see, we can add structures. Okay, here we are. We all this structure, and we will just keep the one who, which are of interest for the procedure. So out, the outer out, aortic valve out. We can keep LA, LV, mitral valve. Okay, we're ready.
Okay, thank you very much. So it's indeed very comfortable for us to be able to see where we're navigating. And as you see, when we move the screen, we move the structures. And when we move the tube, sorry, we move the structures at the same time. So we can choose the best C-arm inclination to realize the different movements inside the left atrium. So here we are. So we can so we can move a little bit anterior part. Like this. And come very slowly at the end of the guide. And when we will come outside of the guide with the clip, we will remove a little bit the guide itself to be sure to avoid all injury of the left auriculum. So we are now inside the left auriculum, and we can check the pass, moving a little bit forward with the clip. And you can see we don't touch any structures. So we can do what we call straddling. Straddling is the position for to be able to move the clip with adding M to be able to see the valve with the clip. So the first thing is to obtain a good straddling. Straddling is this position with two little metal markers around the big metal marker at the tip of the guide. This is the position to be able to move the clip in M position. The M position is when we turn the button on medial, we will be able to move in the left atrium to orient the clip closer to the valve and to give the clip a good orientation for grasping. So like you can see on the 3D view, so medial part is on the right on the screen, lateral part on the left, anterior at the top, and posterior at the bottom. So now we will be able to open the clip and choose the best location to be able to grasp as accurately as possible, and hoping to grasp just one time to have a good result without any injury of the valve itself. we open the arm of the clip and we want to have a good orientation. So we want to target the apex of the left ventricle. So it's very important to have a good orientation of the clip before going in the LV. So in this view, you can see that the clip is pretty perpendicular to the valve, and it's probably a good way to start moving in the LV.
Maybe the last way to confirm the good position, the right position of the clip is to do some MPR for multiplanar reconstruction, because we can have some lack of precision by using X-plane, as you can see on the screen. Multiplanar reconstruction will use 3D acquisition. And then we build some 2D views, as you can see on the screen right now. But by the way, you can see that this image, word square, is of high quality, with a very good position of the clip just above the valve. And maybe we can use this view in order to do the descent inside the ventricle and then to grasp the valve. Despite some dissection of the heart, it's quite good in terms of visualization of these two arms, as you can see on the right side of the image. So maybe we can use, again, because the resolution, spatial and temporal resolutions are better here, we will start going through the valve with these views.
We very slowly going in the left ventricle. Before that, we close a little bit the arms and we check with echo and X-ray at the same time that we are not moving too much. So we have to stay in the good position for the rotational part, and of course for the location inside the left ventricle and on the prolapse. So here we are in the left ventricle. We can open a little bit the arms and come back, and we check the rotation. And at the same time, you see that Louis is doing some movements, anterior or posterior, to come closer to the anterior or posterior valve. So like this, we are not so bad. I think we are at the good position regarding the prolapse. There is a tissue between the arm and the gripper. So we can begin to close a little bit the clip. And now we will check if we have what is the first result and if we have sufficient tissue inside.
Okay, very good. You see the quite disappearance of the leak around the clip. Just small leak is observed on the medial part of P2. And now in terms of tissue, leaflet tissue inside the clip, it's much better, especially in the posterior valve. So then we going in 3D, and you see these triangles. The first one, anterior lifted, anterior annulus to the clip, and the same in the posterior. It's a good sign that there are enough tissue inside the clip. Here we have some pizza, 2 to 3 very small pizza.
Okay, thank you, Stefan. So first of all, we will, if everybody is happy with the position, we will be able to finalize the closing of this one. So we move forward and finalize the closure of the device like this. So now we can do the final assessment and analysis of the leak. I think it's not so bad. So if everybody is happy, we will start the releasing procedure.
As you can see, the gradient is around 2 millimeters.
Okay, so we will start the final procedure to release the clip. So we do the first final arm angle.
Thomas,
just
because
to be sure the clip
we
cannot
a little
open,
bit behind the schedule. Could you put a video faster or shoot the presentation as possible as you can? Thomas, please open your speaker.
Yeah.
Sorry, I have to interrupt your presentation.
Okay,
it's a very nice operation, integrate the image, echo, and the fluoroscope guide. So I think we have a few minutes to discuss later. So anyway, let me introduce the last speaker. So the last speaker is Professor Maurizio Taramasso. Taramasso is, I think, is the new generation of a cardiac surgeon because he received a well-trained about the cardiac surgery and the interventional cardiologist training in Milan, Italy. Currently, he is the attending surgeon working in University Hospital of Zurich, Swiss. Today, his talk entitled two speech. The first one is the advance of transcatheter mitral valve therapy in patients, patient segmentation and the clinical updates. And the second topic is about the case in the box. Talk about the transcatheter mitral valve replacement. So let's welcome Professor Taramasso, please.
Thank you. Thank you so much for the kind introduction and for the invitation. I hope you can hear me well.
Yes.
And it's really a great pleasure to share with you ideas and experience. And I share my screen.
Yeah. Share your screen, please.
Yes, I'll try to be fast in order to maybe record. No, in order to have some time to discuss after the presentation.
Of course, thank you very much.
The topic of the first presentation is a bit overlapping with the first presentation that Thomas did. So I will try to touch some other different point because it was really comprehensive, as usual, the presentation of Thomas. Just to start with, as we already discussed, modern transcatheter mitral valve interventions can be divided in three big groups. We have obviously leaflet devices, and among leaflet devices, at the moment, let's say the most important, the one who has been achieved, the highest implant in human is obviously MitraClip, but we have also chordal therapy or coming, apical now, but transeptal is coming soon as well. Then we have annuloplasty. We have direct and non-direct annuloplasty, which can somehow address different pathology than leaflet devices, but they are pretty much interesting also in order to complete the repair. As Thomas said, in surgery, we do always mostly combined procedure. We address the leaflet, but we address also the annulus. And most likely in the future, this will become a paradigm also for transcatheter, addressing the annulus together with the leaflet. And then we have the big chapter, this nuke therapy of transcatheter mitral valve implantation. We are still learning which are the best patients for this therapy, but the field is moving fast. And I will show you after a short case with the device that is first in the list, the Tendyne, which at the moment is the only one commercially available in Europe for TMVI. So let's start with a few words about MitraClip. We know everybody mitral, we know the result, we know the limitation, we know after COAPT and mitral FR that in functional mitral regurgitation, if we select well the patient, we can achieve prognostic benefit. But obviously, after more than 100,000 implants, and after many years of considering MitraClip therapy, which is somehow a palliation, I think we should move a bit forward. So if you ask me, which is the modern role of mitral, which is mitral therapy in 2020 and in the next future, I think that we should start considering mitral clip not anymore like a palliative therapy, but we should try to consider mitral clip as a tool, and we can use a tool in a different way. And if this tool is properly used, mitral clip can be a curative, or let's say at least a therapeutic option. What does it mean properly performed? So we need to perform mitral clip properly in 2020. That means obviously correct patient selection in terms of anatomy, but also in terms of clinical setting. Proper periprocedural imaging. We have seen this super nice case from the Thomas team showing a fusion imaging. Actually, periprocedural imaging is fundamental to achieve optimal result. And then let's not forget the two last, which are not enough discussed in my opinion. Procedural performance. So mitral clip is a tool. So it's like surgical mitral repair. Technical performance makes the difference. Operator is much more important than other, for example, I don't know, for example, in TAVR, the impact of the technical performance, and this has been shown pretty well also in mitral FR and co-opt results. But the technical performance, so the completing of the learning curve and the volume of the operator is extremely important to achieve optimal result, as well as a fair assessment of the outcome, including not only echo, but also hemodynamical assessment and also the proper reporting of the follow-up. Just few words. The first study investigating the role of mitral clip, which basically opened mitral clip to the clinical use, was the Everest 2 trial. Everest 2 trial was a bad trial at the end, because the background was that mitral clip should have become a kind of competitor to surgery in operable patient, which at the moment is actually, we know is not the case, is not true. So in Everest 2 trial, operable patients were randomized against mitral clip. And at that time, mitral clip had still a lot of technical limitation. For example, the learning curve was not completed, so there was not previous experience. At that time, there was no 3D echo. And as you can see, the incidence of single leaflet attachment at the beginning and the number of clip implanted during that period was different as the one we do now. Now we tend to use 2, even sometimes 3 clip if the result is not good. At that time, most of the operators were tended to use only 1 clip. And actually this trial almost killed mitral clip. I just show you an example before moving to other technology on how mitral clip should be conceived in 2020. So this is a patient with basically degenerative mitral regurgitation and, functional mitral regurgitation with a cleft-like indentation between P1 and P2. You can see it in the 3D. You can see that the regurgitation is mainly due to this cleft-like indentation. So this is a typical relative contraindication to mitral clip. We always say that if there is a cleft, mitral clip is not the best device to treat it. But if you think that mitral clip could be used as a tool, you can address also some kind of different anatomy. For example, you can close a cleft by implanting 2 convergent clips, as in this case. You see the first clip is on the lateral part of the medial part of the cleft, slightly oriented counterclockwise, and then a second clip was implanted on the medial part, on the lateral part, slightly clockwise rotated. And by doing this, you can address cleft-like indentation. So mitral clip is a tool, like in surgery. Mitral clip is your stitch, and depending on how you use the stitch, you can achieve different outcomes. This is another example of, let's say, off-label use of mitral clip, a complex Barlow disease with annular calcification, with multi-segment prolapse. This patient was inoperable. This is obviously an anatomy that usually qualify for surgery, but unfortunately, we have also patients that are not surgical candidates, but who have still a good life expectancy and still good quality of life. So even this really challenging anatomy, by using some trick means, for example, using some atypical echo projection, being ready to use more than 1 clip if needed, we can achieve an almost surgical-like result, at least in the acute phase. This is obviously an extreme case. We implanted 4 clips, but if you look at the residual jet at the end, it's really minimal, and the gradient was 3. So you can achieve good result even in off-label anatomy if the 4 group that I've shown you before are respected. And then obviously technology is coming to helping us. Now we have the possibility to tailor the mitral clip to the anatomy. So we have different type of devices. We have longer devices. We have XTR clip, which is basically clip with longer arm. Now we have also clip with wider arm, which are not available yet in Europe. Obviously, having different devices let us give us the opportunity to better tailor the therapy, but also give us the challenge of better select the device for the patient, because it's not true that a bigger clip is always the best. Obviously, you need to have enough leaflets, you need to have proper leaflet insertion, otherwise the outcome could be suboptimal. We have been discussing this already. I want just to stress the fact that in the decisional process of which device to use, in this case mitral clip, clinical factor, anatomical complexity has to be taken into account, but also operator experience make a difference. There are clear data from the TVT registry that the outcome are really pretty much depending on the case volume, not only of the team, but also of the single operator. There are also different devices available, like the Pascal. Thomas showed us the Pascal, so I will not focus on Pascal. Pascal is now approved in Europe for mitral intervention. There are also ongoing studies on tricuspid position. Pascal is a similar concept. The main advantage is that you can grasping independently the 2 leaflets. This is coming also with the new generation mitral, the Gen 4. But Pascal is also a slightly different steerable possibility. So it's an interesting device, but obviously long-term results are largely unknown. And then it is more bulky than mitral. So modern mitral therapy imply that with experience, anatomical indication may become wider as usual. Palliative approach should be acceptable only in really inoperable patients. So if you want to treat high risk or intermediate risk patient, but still operable, then the quality bar should raise. So we cannot think the mitral clip is a tool to reduce MR to 2+. We should really target to optimal result. Obviously, we have now new devices coming. Thomas showed out neocord harpoon and a new device to perform chordal implantation through septal approach. There are also other ones coming. One is Cordart. The concept is the same. Neocord implantation will be most likely a game changer once it will become transeptal. At the moment, the devices available are delivered through the apex. And the main limitation beside the access is that here is how the neocord device works. Basically, you grasp the leaflet, and then you implant your cord, and then you exteriorize through the apex the cord. You can adjust the length of the cord by checking live at the echo the result. The main limitation is, again, anatomical selection. If the anatomy is easy, the results are really good. You see 100% of freedom from MR in Taipei. Taipei means P2 isolated flail or prolapse. But obviously, this result you achieve also with mitral clip, you achieve also with minimally invasive surgery. So the paradigm that the easiest is the anatomy, the better is the result, is true for all type of technology. If we move towards more complicated anatomy, like multi-segment prolapse or anterior or paracommissural or bileaflet prolapse, then you see the results are pretty much poor. And this is, in my opinion, still the limitation of this and most of the technology. Few words regarding annuloplasty. I've been mentioning that we have indirect and direct annuloplasty. At the moment, there is much more interest on direct annuloplasty because indirect has some limitation, as we have seen from the presentation of Thomas. I'll show you a few slides on Cardigan, which is at the moment the only direct annuloplasty which is clinically available and commercially available in Europe, and there are also ongoing trial in US. Cardigan is delivered through the septum, transeptal puncture. by means of a steerable catheter. And then the concept is interesting because the band is implanted on the posterior annular surface of on the lateral side from the medial trigon, from the lateral trigon to the medial trigon by means of different anchors. Sizing is performed by means of CT scan. So we know from CT scan which is the size of the band that we have to implant. And then the most important feature of this device is that it is adjustable. So once the device is implanted, then the length of the device can be shortened by means of this cinching. So there is a cinching wire inside the cardioband, and making the cardioband shorter basically reduce the anteroposterior dimension of the mitral valve, and the coaptation of the leaflet is forced. So this is obviously a therapy which has been developed for functional MR, but that can be interesting also for combined procedure, for example, leaflet plus annuloplasty. I don't show you all the cases, but this is a real case that has been performed a couple of years ago in Zurich to show you also some of the challenges. The most important challenges are imaging, because you need really advanced echo guidance to be able to implant all your anchor at the hinge point. So not in the atrium, not on the leaflet, but really at the hinge point. And each anchor should be carefully assessed before the final release. And then the other challenge is the proximity of the circumflex artery. You can see on the screen that there is a wire on the circumflex artery, and this wire is used as a reference. So each anchor potentially can impinge the circumflex artery. So we should pay attention not to have this complication. And the best thing is that each anchor is retrievable. So if you are not happy with each anchor, we can retrieve it and implant it again. I just show you the final result. This was a 16 anchor implant. It's fastened, obviously, because the procedure takes long. It's quite challenging, but it's learnable. There is a learning curve of about, I would say, 15 to 20 cardioband. After this, the procedural duration becomes slightly longer than 2 hours. Francesco Maisano can implant a cardioband in less than 2 hours, but obviously he has a huge experience, hundreds of implants. But after a learning curve of about 20, you can implant in about 2 hours, 2 hours and a half, which is acceptable. And then after all the anchors are in place, the cinching is then performed. You can see that the anchor become closer and the antero-posterior distance reduces. And as a consequence, there is an improved coaptation of the leaflet with reduction of TR. Patient selection is really important for cardioband therapy. We are still learning which are the best candidates for this therapy. Most likely type 1 Carpentier lesion, so functional MR due to annular dilatation are the most responder to this therapy. Here you see some results of the CMARC study. They are core lab adjudicated, and you can see that the result in the context of high-risk patients with functional MR are quite similar to the one that we can achieve with mitral. Nice reduction of anteroseptal dimension, which seems to be stable over 1 year follow-up. And then obviously, annuloplasty is really appealing because we can think to combine this therapy to leaflet like we do in surgery. In surgery, we address the leaflet and we put an annuloplasty. This is why in DMR, we have better acute result, but we have also better durability. The same in FMR. In FMR, especially if there is advanced annular dilatation and advanced tethering of the valve, combining leaflet, so edge-to-edge, and underside annuloplasty in surgery has been shown with better durability. So obviously there are also some economical issues in combined this therapy because they are really expensive and they are not dedicated reimbursement tool for combined therapy, but this most likely in the future will improve long-term durability and will improve also MR reduction acutely. I've seen the alarm telling me that we have to move to the end, so I will go faster. This is an example of combined cardioband and mitral clip. Obviously, also carillon can be used to perform, as in this case. So undirect annuloplasty can be used to perform combined procedure. And then we have TMVR, so transcatheter mitral valve replacement. We have been seeing some example already. We have different devices. The most advanced at the moment is the Tendyne, which is commercially available in Europe. Transeptal is coming. We have seen implant of Sifia. This was the really first in man cardiac coup implant through the septum. So you can see that it's feasible, but it's challenging. You can see how many catheter, how many wire are present in the picture. Now we have better devices which are easier to implant. So it's coming, but it's still a challenging procedure. And then the promise of transcatheter mitral valve implantation is that we can address all anatomy in a more reproducible and easier way. But at the moment, this is more a promise than a reality. So TMVI is still challenging. There is still a lot of patient selection. There are still a lot of open challenges. We cannot think to address all the anatomy with one single devices. Access is still, at the moment, mostly apical. So there is still a lot of work to do, but it's moving forward. And obviously, mitral is not aortic valve. We have different anatomy, and most likely we will have different devices for different anatomy. We cannot think to treat Barlow disease and functional MR with the same mitral valve replacement, because the sealing is going to be different in the two anatomy most likely. LVOT obstruction is an issue, so anatomical eligibility is, I would say, a big limitation at the moment. We cannot address all the patients with the current devices, so many patients are not eligible. And then at the end, this is a slide from Professor Maisano, not always replace is the best option. We know from surgery that at least for degenerative MR, if we can repair, it's less invasive, and the impact of the heart is less. So obviously, if we can repair, most likely repair is still the way to go, but not always we can repair. So the main challenge now, and in the next few years, now we have different devices, we are learning how to use it, is to put the patient in the middle. So this red P is the patient, and we should really discuss each case, each anatomy in order to deliver to the patient the best tailored therapy according to his expectation, his anatomy, and his clinical profile. There are no official algorithm, but this is somehow what is done now in degenerative MR. If the patient is operable with acceptable surgical risk, surgery is obviously the gold standard. If the patient is inoperable at high surgical risk, then transcatheter treatment should be treated. If the anatomy is a favorable anatomy for repair, then percutaneous edge-to-edge or chordal implantation could be performed. If not, TMV replacement should be considered. In functional MR, obviously surgical risk has to be considered, and especially if concomitant CABG is indicated, then surgery has to be considered. If there is isolated FMR, or if the surgical risk is high, like in most of the cases, then transcatheter treatment has to be treated, and then we have different options. If you have prevalent tethering, then probably edge-to-edge is going to be the most effective strategy. If we have mainly annular dilation, then we have to consider annuloplasty first, which has the advantage of keep the door open for further replacement or further leaflet repair. If the anatomy is unfavorable for repair, so we can predict residual MR, then TMVI is the way to go. And this is another way to say the same things. Obviously, heart team assessment is the best way to decide which kind of therapy is the best for each patient in absence of rigid data. But I would favor at the moment a repair first strategy if repair is achievable with optimal result, and we have now experience to predict when a repair is achievable with good result. If not, go for TMVI evaluation, perform a CT, assess the anatomy. If there is no risk of LVOT obstruction and the annulus is not too big, then TMVI should be considered. And I think in the interest of time, I move to the case that I want to show, if there are no questions. So I move to the second presentation.
Okay, please move to the second presentation.
Yeah, which is a case. It's a case of tendine, and is a pretty much. Can you see my screen?
No, just your previous slide.
1 second, then. Now, if I make it big, I should work like this. Can you see the video running?
No. Maybe you have to.
Probably have to stop sharing and then share again. Now?
Okay, yeah. Yes.
Perfect.
Yeah,
perfect.
Perfect.
Okay, perfect. So it's a case of transcatheter mitral valve implantation with tendine that we performed, I think, 3 years ago. So before tendine was commercially available. Just few words regarding the clinical profile of the patient. It was a 84-year-old female, really symptomatic. So in a heart failure condition, near class 3, with with paroxysmal atrial fibrillation and some copathology. The etiology of MR was degenerative, as you can see. There was some alteration at the leaflet level. Probably this was post-traumatic rather than degenerative, but for sure was organic disease. At that time, we tried MitraClip first, but we were able to abolish MR, but with creating severe stenosis. So you can see there is the minimal gradient we were able to achieve was 12. Obviously 12 is not acceptable. So we removed the clip and we decided to study the patient for transcatheter mitral valve implantation. So this was a failed clip, aborted clip. Here you can see the CT planning. CT planning is really crucial for all the 10 VI devices for many reasons. One, you have to size the device, so you have to check whether the annular dimension fit with the device. And then you have to plan 2 things. First of all, the access. If you perform a device through the apex, like in tendine, the planning of the access, I will show you now, is crucial. It's crucial to be coaxial to the mitral annulus in order to achieve good implantation. And then also to study the neo-LVOT. Neo-LVOT means that since the device is quite bulky, we have to predict how much space we will have between our devices and the anterior mitral leaflets and the septum, because the risk of having severe LVOT obstruction is big with the MVI. The big advantage of tendine is that tendine is retrievable and recapturable until the final position. So you can remove the device after the position. So even if we have a severe LVOT obstruction, we can remove the device and put, for example, a smaller one or just abort the procedure. And this is really a winning tool as compared to other devices. This is the direction where also other devices are trying to go, because this really makes the difference. Anyway, in this case, you can see that the CT reconstruction was showing a nice LVOT after the virtual valve implantation. So we decided to move forward and schedule this patient for tendine. So here you can see the space between the valve and the septum. Planning of the access is crucial. So with CT scan, you can really know exactly where to puncture, where to do your skin incision, how far you should be from the sternum, how you should angle the device in order to be coaxial. So everything is really planned carefully. Then let's go to the procedure. The first step of the procedure in a tendine implantation is obviously the transapical access. And after the skin incision, which is performed exactly where the CT tells us to do it, poking of the apex with the finger is performed in order to check that our entry point, you can see here, we are pushing with the apex, with the finger on the apex, in order to be sure that we are really coaxial in the 2 view to the mitral annulus. Then we puncture the apex, and the first step is to access the left atrium with the wire. And then over the wire, we have to perform this flossing with the balloon in order to be sure that we are not within chord so that we are free. Once we know that we are free, we are not within chord, we are sure that we can insert our sheath. The sheath is inserted. So here you can see the balloon flossing. The balloon is moving freely, so there is no chordal entanglement. And then the sheath is inserted. Obviously, everything is done with the beating heart. Here you can see the sheath. The sheath has to be inserted. There is a marker, fluoroscopic marker, has to be inserted in the left atrium. And through this sheath, we will deliver our valve. So you can see now the nose cone entering in the left ventricle. All the procedure is performed mainly with 3 echo view, exactly like mitral. We want to have a nice intercommissural view with the apex in the middle. We want to have a nice LVOT view, and then we will use 3D surgical view to orient the prosthesis. So these 3 views, which are the same which are used in mitral implantation, are the one used for tendine implantation. So you see the sheath crossing the mitral annulus retrograde. You have to be in the middle of the valve. You can see in 2D echo that we are in the middle of the valve. There are no chordae impinging. And then you can move your sheath toward anterior, toward posterior, lateral, and medial. After this, the valve is delivered. The atrial flange is opened before. Then the valve is pulled back in contact with the annulus, and the ventricular part is opened. At this stage, we keep the tension manually. We can check the result. If we are not happy, we can recapture the valve and reposition. So you see now the stent of the tendine valve coming. Tendine is a biological valve with pericardial bovine leaflets. These are 3 leaflets valve. You can see as soon as the stent of the valve is going out from the sheath in echo, we recognize that we are going out. And as soon as the first few millimeters of the valve are out, we should recognize which is the anterior part and which is the posterior part of the valve and orient it. This is really important. So together to coaxiality of the annulus, which is crucial, proper orienting of the valve is the second crucial part. But it's really easy because the valve is asymmetrical, so we can recognize easily what is anterior and what is posterior. There is also a fluoroscopic marker that tells us where is the A2P2 region. So the more we open, the more it will become easier to recognize which is anterior and which is the posterior part. So now you can see this kind of folding. This kind of folding is will be the mid portion of the anterior part. So we have to orient this part corresponding to the A2. And in 2D, you see it very well. This longer part is the anterior part of the prosthesis. So you check in 3D, then you confirm in 2D. Once you are nicely oriented, you pull back the valve and you get nice annular contact. Once you have annular contact, you proceed with the opening of the ventricular part, and you see the leaflets are working. So the valve is already working now. Now the valve is opened, leaflets are working, there is contact. At this stage, we check whether there are paravalvular leak or not. And if there are not paravalvular leak, we proceed with the fixation with the apical tether. If there are paravalvular leak, we can recapture and implant again, or we can apply more tension. You see now there is now sealing of the prosthesis within the annulus, no paravalvular leaks. Obviously, at this stage, you assess also LVOT obstruction with echo, but also with invasive measurement. So you check that there are no gradient in the LVOT. And again, this is a unique feature of this valve, because if you have any issue now, you recapture the valve and you implant again from the beginning, or you can remove it. This is different from all the other devices. Usually the patient is really stable during the implant. You can see there is no reason to rush. Once you're happy, you proceed with the fixation of the apical pad. So you see there is a tether connecting the valve with this pad, which is fixed to the apex. And then the tether is tensioned against the pad. And the tension between the tether and the pad hold the valve in position. And this tension is adjustable. So we can release or increase tensioning and check in echo and in our hemodynamic profile what happens. And then release the valve with the correct compromises between too much or too less tension. You see, you check that you do not create increase in the LVDP. You check that there is no leak. You check that the systemic pressure doesn't drop. So you check all the hemodynamic parameters during your tensioning. If for any reason your valve loses tension, you can still come back, I don't know, 1 month, 3 months later and release or increase tension. This is still feasible. Now the valve is working. And if you're happy, you release. So all the implantation took about 1 hour and 20 from skin to skin. So it's pretty much, but from the insertion of the device to the release is usually 20 minutes if everything goes smoothly. I hope it was a nice case to show. And now I stop sharing my screen and I'm open for question, discussion, or comment. And thank you for the opportunity.
Thank you, Moderator. Thank you for your great talk and a wonderful case sharing. So today's we have 4 wonderful speakers. The first 2, Professor Fan and Professor Meng, they gave us a traditional but durable and advanced mitral valve repair in rheumatic heart disease. And the other 2 speakers, Professor Thomas Modine and Moderator, they give us some advanced tech innovation about the transcatheter mitral valve repair or replacement. So we have another moderator or commentator from Professor Gu Tianxiang from China, and Dr. Chen Yisheng from my colleague from Zhenxing General Hospital. So now we open for discussion. So first I will ask the Professor Fan and Professor Meng. Some audience raised a question about for the beginner, how to choose the case for repair in rheumatic mitral disease, how to choose the best case to learn when you start to repair rheumatic mitral disease. Professor Fan or Professor Meng, could you comment about this one?
So I think this is a very important question. As you know, we have some difference between the rheumatic valve and the other in comparing between degenerative and rheumatic patient. You see, normally the valve lesion in rheumatic disease is multiple, and we also need at least 3, 4 to 5 different techniques to repair rheumatic valve. But in degenerative, sometimes you need, sometimes we just need the artificial core, or you resect and then you put the ring. That's all. For rheumatic repair, we need repair not only the valve lesion, but also the subvalvular lesion too. So it's not easy to select, in my opinion, the good patient to repair for rheumatic disease, because the valve lesion always combine together. So in my opinion, for the beginner, I think we should select the valve should not too fibrosis, not too much calcification, and especially the subvalvular not too much retracted, or also the valve tissue should be enough. Don't try to get in the patient with valve tissue very small, subvalvular fuse, and especially in the patient I showed you in the video clip, the cordon shortening syndrome. We have very short cord, hypertrophy of papillary muscle. In such case, the repair is more delicate. I don't know how about your opinion, Dr. Meng. Maybe you share with us about your experience, how to select a good patient to prepare for the beginner surgeon.
Professor Meng, please. Please open your speaker. We cannot hear your voice. Professor Meng?
Yeah, okay, sorry. Okay, I can talk to some points. According to our experience, I think that at least in China, first thing I think maybe the less than the 50 years the cases that's maybe easily repair, and if the patient more than 60 years, so the pathological change is very big. Maybe there are some difficulty for repair. Second is I think for the stenosis area, if you can, if you are the beginner, you can choose the area about the 1 cm to the 1.5 cm. So maybe the subvalvular apparatus, maybe that's okay. So the third point, I think if the patient, you can see the echo, the special the anterior leaflet thickening less than the 1/3 area, 1/3 area. That's maybe so that case with the good anterior leaflet function. So if you according the score procedure, it's our experience about the more than the 70% the rheumatic repair we can finish.
Okay, I have a question.
Yeah, Professor Gu.
Yeah, I have a question to ask Professor Wang Fan and Professor Meng-Chi. As you know, it's just both of you give the many cases operation about the rheumatic heart disease. From the Professor Meng-Chi's data, is about nearly 20% of the patient has the leaflet body is the shaking. Yes, I think it's just both of give us how to do the commissurotomy, how to relieve the papillary muscle, is the shortening, adhesioning. But I want to ask you, both of you, is whether or not is needed to treat the leaflet body, the shaking. As we know, is the body of the leaflet is affected, is flexible. Because the second valve affected the opening. For that kind of is the pathology, whether or not need to the setting. How about both of you's opinion about the peeling, the saving of the leaflet body area, such as the basal zone and transparent. Transparent zone already is no transparent, is a thickening. How about your strategy to treat that kind of pathology?
So how about your opinion, Professor Fan?
I think it is very important question. You know, in rheumatic disease, it's not easy having just one lesion alone. For example, valve thickening alone, very free. I think we have very few patients with such lesion. Normally, we always have a combined lesion, leaflet thickening, and subvalvular also thickening, fusion, and retraction. So when I decide to repair the valve, especially in case if leaflet thickening, I also, combine the valve lesion and subvalvular lesion too. So if the subvalvular too much fusion, even we have very good valve tissue, I don't like to repair because the long-term outcome not so good. So when we decide to repair the valve, it should be, both valve tissue and subvalvular should be free at the same time. That's the first thing. Number two, I travel around the world to do, cases in the different, and I also repair the rheumatic valve in many different countries like Vietnam, Philippines, Indonesia, in China, in Taiwan, and so on. And I recognize that even with rheumatic disease, but the valve lesion different between the nations. For example, the Vietnamese with rheumatic valve, a little bit the same Taiwanese patient or Filipino patient. But the patient from Thailand, a little bit the same with Malaysian people, something like that. It means that sometimes the valve lesion and subvalve lesion not go together, So I think we should adapt to the patient in your country, in the hospital you're working for. So sometimes you have a very thick valve tissue, but subvalvular is good. In such case, you can peel the leaflet. You can peel the leaflet, and then you can do commissurotomy, peel the leaflet. That's all. That's good. But if the valve tissue thickening, subvalvular also fusion and retraction, even you peel the leaflet, the subvalvular not good. The long-term outcome not good too. So the question here is a long-term, result of the patient, not immediate result or the midterm result. For me, a mitral valve repair, if it's not stable for at least 15 years, we should change valve. Before I say 10 years, but now it should be 15 years. So the patient go back after a few years, 5 to 7 years, after the first operation. For the second time of surgery, we have to change the valve. It means that there's something wrong, maybe wrong indication or wrong technique to repair. So it's better we do a good selection of the valve to repair. So I think this is a very important question. And even, sometimes I already spend 20 or 30 years valve repair, but sometimes I still assisted, repair or replacement in some patients.
Dr. Meng, for the same question, Dr. Fan says that if the repair cannot last for 15 years, then he will change the valve for rheumatic valve. How about your opinion? What condition that you will give up, repair the valve, and go ahead with the replacement of the valve in rheumatic disease?
Okay, some agree with the Dr. Van Fan. There's the different country and the different rheumatic patient style and the different technique. So, but my idea that's the first thing that's for the rheumatic repair. So I don't think though that's the anatomic repair. That's maybe we can do the functional repair. That's okay. That's maybe we can get the patient the long-term the good results. Maybe we can get that patient the long-term survival. So in China's condition, as our study and research, we can find that the very important that's for the anterior leaflet, if the thickening more than the 50%, so maybe that's the difficult for the repair. But this kind of patient in China less than the 20%. So if the patient the anterior leaflet that's the clear zone, that's okay. There's the good mobility, so we can do the good functional rheumatic mitral repair. So our paper show that the average that's 5 years old. So the mitral opening area generally average about the 2.4, I think, that cm square. So that's for the mitral function. That's okay. Maybe so. Peeling the leaflet or deal with the short cord. That's our experience. That's in China, at least in China, about at least the 50% of the rheumatic mitral repair, we needn't do some other procedure. So only the 4 steps we can finish the functional repair. That's my idea. Okay, thank you.
Maria, I have one question about the transcatheter mitral valve repair. From our daily practice, some patients will ask the surgeon, could us receive the transcatheter mitral valve repair? If failed, then we shift to mitral valve, surgical mitral valve repair or replacement. How about your patient, once he asks you such question, how you answer such question to your patient?
Well, we should. I think we should answer in a fair way. For sure. First of all, it depends on which device you consider. For example, if you implant neocord, probably is going to be easier to repair the valve if the repair fail, if the transcatheter repair fail. If you perform a leaflet repair like mitral clip or Pascal, for sure you can still repair the valve if you perform surgery, I would not say immediately, but really early. If you perform surgery early, most of the time, even if it is not easy, you can preserve the valve and repair it. The best way to do it is probably to keep the clip in place and maybe extend edge to edge. Sometimes you can remove the clip and still try to repair the valve, but for sure the chance of ending with a replacement are slightly higher. So I don't think it's correct to say to the patient that if we have a problem, we can just repair the valve surgically with the same chance, because it's not true. Especially if the failure occurs many months after the first procedure, because then we have fibrosis, we have retraction, and then in that case, the chance of repair are really, really reduced.
Okay, we have 2 questions from the audience. It's asked about the repair about rheumatic heart disease. The first question is they talk about some cases monocuspid valve reconstruction was created, but some cases we needed to do posterior leaflet enlargement. So how do we choose? Is the one cuspid monocuspid is enough, or try to maintain anterior and posterior cuspid will be better for rheumatic mitral repair? This is the first question. And the second question is about the calcification about the posterior mitral annulus. How much should we decalcify the annulus calcification is enough? And instead of damage some danger area that such as circumference territory, or about the long-term durability of the rheumatic mitral repair. It's deal with the issue of annulus calcification. Professor Meng or Professor Gu and Professor Fan, how about your opinion about these two questions?
So, can I answer firstly?
Yes,
so
please.
My experience that's for the rheumatic repair. So I focus on the anterior, the leaflet movement. That's the first thing. And second is the commissure tissue, the moving the commissure area, the tissue plaque. That's okay. For the posterior, some stick or some construction, I don't think so. It's necessary to deal with that. That's okay. So we can get the rheumatic, the functional repair. So for the annular calcism, so if the patient with the severe annular calcism or severe subvalvular apparatus calcism, I don't think so this the suitable for the repair. Maybe you can choose the replacement or something. It's my idea. Thank you.
Okay, I answered the two questions. About is the anterior lift is enlargement. I think to my is the experience. I choose the phrase the pericardium, yeah, to enlargement. If they choose the enlargement, we can from the commissure to commissure. Yes, just like the one fancy is the experience is the same. At the beginning, we do just the enlargement is the part of them. Maybe comparison found enlargement area is good enough has the cohabitation, but it is the previously normal is the leaflet. It has the size regularization. That is from the previous experience. Is modified. Yes, to enough the pericardium enlargement from the commissure to commissure is got good enough the coagulation to the anterior of the posterior leaflet. About the second questions about the calcification of the annular. If we want to, I think the majority is the calcification about the post is the annular area. I think we do the decalcification. I think is some surgeon worry about is to do the rupture. Is the calcification maybe is the damage to the left ventricle wall and maybe get the potential risk of the rupture of that ventricle. I think it's for the calcified bar. If you use the subknife, the careful, just is the cut of the calcified bar. Use the pericardium to the implementing is the defect area. I use the big needle is spiral is not very deep. Yes, I think it's a large area. The bite is the calci is the left ventricle muscle. I think a continuous suture avoid the local tension. I think we can do the repair. You use the even as the posterior the annular calcified, I get the result. I have the nearly 10 cases about is annular calcified. It has the same good result.
Professor Taramaso, I have a question for you. I saw that one of your presentation with mitral clip, transcatheter mitral valve repair, you put 4 clips on the mitral valve, and you nicely eliminate the mitral regurgitation. It's very nice. But afterwards, what's the transvalve pressure, gradient pressure, and how much the mitral valve remaining opening? Is this question about if there's any mitral stenosis after the mitral clip? And since you have another tool of the 10-die replacement, why not put a 10-die instead of 4 clips on this valve?
This is a really important question. obviously, this is an extreme case that I showed. We almost never put 4 clips. In that specific case, there was no gradient because the annulus was really large, so the gradient was 3. But obviously, whenever you put an adjunctive clip, you reduce the opening area. So you have always to negotiate between residual MR and increased gradient. And actually, the impact of residual gradient on the long-term outcome has not been really well studied so far. We know that the highest is the gradient, the worse will be the outcome. What we do in our practice is we always check the invasive change of the left atrial pressure. We put a pigtail in the left atrium. Now with the 4th-generation clip, you can do it with the mitral clip system. And then after the implantation of the adjunctive clip, we check whether the mean atrial pressure drop, increase, or stay the same. So even if you have a reduction of MR, but the mean atrial pressure increase, we remove the clip. So we don't accept this. Because our clinical experience suggests that hemodynamical, let's say, change, mainly increase in mean left atrial pressure, are much more predictive of color in echo on outcome, and also gradient in echo. Obviously, the case that I showed you was a few years ago, so Tendyne was not available yet, if not for compassionate use, and the patient was hospitalized, so there was no logistical possibility to do Tendyne. And the other problem is that Tendyne is also not always feasible because many patients are not eligible due to the risk of LVOT obstruction or due to the fact that the annulus is too big or too small. So it's not an option for all the patients, unfortunately, not yet at least.
Professor Fan, what are your comment about the monocuspid and keep the bicuspid in rheumatic mitral valve repair?
I have comment on this, and then I have a question for Professor Mori later. So for rheumatic valve repair, in most of rheumatic patients, we have a type 3 disease. Type 3 is being restricted leaflet motion. So the purpose of repair in rheumatic disease is how to increase the mobility of the valve. So for me, release the subvalvular, open the commissure in rheumatic repair is very important. Normally, I spend a lot of time to resect the secondary cork to release the subvalvular to do papillary muscle splitting, not only for anterior leaflet, but also for posterior leaflet. But for posterior leaflet, it's very important too, because in many cases of rheumatic patients, the posterior leaflet retracted down to ventricular side because the retraction, the fusion. So if we don't release the movement of the posterior leaflet, even you have a very good ring, but sometimes the coaptation is not good. So we try to move the free edge of the posterior leaflet to the same level to the anterior leaflet. So that's why, for me, I spend a lot of time to mobilize the both leaflet, not just one. Number two, when we have a too much calcification of the annular, in such case, even when you repair or you replace the valve, your needle not easy to go through the annulus with too much calcification like that. So in such case, it's better we need to take out all calcification and then the annular with the pericardium. How to avoid circumflex artery? Don't go so far. When you see some fat, the yellow tissue, it means that you almost touch to the circumflex tissue. So normally, if you will carefully, slowly, we can take a block of calcification of posterior annulus together, and then recontract the annulus after that. And for leaflet extension, before a long time ago, I do both. I stand anterior leaflet and posterior leaflet, but mostly anterior leaflet. A few times I stand the posterior leaflet. But actually, I don't like to extend the posterior leaflet anymore. I do mostly anterior leaflet extension, because if the posterior leaflet too much retraction, even we extend it, the movement not to that. So if I think that the posterior is too bad, it's better I change the valve. I change valve. I don't like to keep the valve with very very bad posterior leaflet like that. This is my comment. I would like to ask Professor Mori your question. When you do the mitral valve in transcatheter, how can you select the size of the bank to be used? In surgery, we select the size of the ring based on the size of the anterior leaflet. But on transcatheter procedure, how can you select the good size of the bank of use?
The sizing is yes, I am active. The sizing is performed with CT scan. So on CT scan, the distance from trigon to trigon is measured. And then based on this, there are different sizes, and the size which fit with this CT measurement is analyzed. So you don't measure the anterior leaflet, you measure really the distance, let's say the length of the posterior annulus.
When we repair in conventional surgery, I always compare the length of the leaflet I measure by myself and the length of the leaflet measured by 3D echo, and we always have some different, different number of this. How about your experience?
Well, I think in CT scan the difference is less; it's more reliable. But obviously, there will be always some variability between the intraoperative measurement and the one with imaging. The good thing is that this kind of band are adjustable, so you can adjust, but still, if you select a band which is too short, then your efficacy will be impacted, you will be less effective. So sizing is crucial, yes.
Okay, I have a question to ask Professor Wanfan. Just from your slide, so you do the mitral valve repair. You use the edge-to-edge is the double orifice. I think it's to the doctor introduced is a mitral clip is also is the same is the mechanism. I want to the cardiac surgeon, yeah, from the classical operation. Well, what is the position about edge-to-edge? Is the prior choice of the last choice? Give us your consideration about you choose that master.
So for me, edge-to-edge stick, I just do in commissural area only. I never do at the middle of the valve. I never transform the mitral valve from one orifice into two orifices. No, because we in my mitral valve, of course, edge-to-edge technique is good technique too, but for me, mitral valve repair is something like an art. It means that you repair the valve, not only no leak, but the valve should look beautiful. Okay, so if you fix two leaflets together at the middle to transform from one orifice into two orifices, the valve no leak. But for me, it looked not very beautiful like you do the other technique. We have a different technique to do, not only just one. And for me, for the commissural prolapse, when I repair it, I like to do edge-to-edge technique because I need the perfect result at this area, and I don't like even very small leak come out at this area. So that's my opinion. Yeah.
Okay. I think we learned lots of from all your lecture and your discussion. It's the final section of today's program. I have to thank all the new friend and old friends participation on this meeting, especially Professor Fan, our mentor in mitral valve repair. So thanks for all your participation. I hope to see you soon, and especially in Taiwan, and we can show some wonderful about Taiwan for you. Thank you for your participation.
Thank you very much.
Thank you.
Thank you, everybody.
Thank you. Bye.
Bye-bye. Thank you.
Bye-bye.